பிரவீன் யாரோ ஒருத்தர் சொல்லு. கொஞ்சம் க்ளீன் பண்ணி விடுப்பாங்க. கொஞ்சம் க்ளீன் பண்ணி விட. இல்லைப்பா க்ளீன் பண்ணி விடுங்கப்பா. பிண்டருக்கு போயிருப்பான் நினைக்கிறேன். ஏய் கையில் எடுக்கணும்ல, தள்ளி விட பண்ணிவிட்டேன். தள்ளி விடுங்க அட்லீஸ்ட் வருமா.
Good morning all. May I have your attention please? Please be seated. I request all delegates to be seated please. A very good morning to one and all. Happy to see you all on the third day of DPH ICON 2022, an International Public Health Conference. Today on day 3, we have sessions focusing on drugs, logistics, information system, and we have a special topic on emerging and re-emerging infectious diseases, and we are covering topics like antimicrobial resistance, health education, and we have exciting sessions by our Health Secretary Sir, MD Ma'am, and PDT and HSRP, and Commissioner Sir from Food Safety and Ayush. And the valedictory function is planned around 4 p.m. So without much delay, we'll start the sessions. The first session is a plenary on emerging and re-emerging infectious diseases, handling the uninvited visitors. Please join me in welcoming the most renowned, eminent person, Dr. Soumya Swaminathan Ma'am, Chief Scientist, World Health Organization. Ma'am is a pediatrician and a globally recognized researcher on tuberculosis and HIV, and she has 30 years of experience in clinical care and research, has worked throughout her career to translate research into impactful programs. She was a Secretary to Government of India for Health Research and Director General of ICMR from 2015 to 17, and she focused on bringing science and evidence into health policy making, building research capacity in medical schools, and forging South partnerships in health sciences. From 2009 to 11, she also served as coordinator of the UNICEF, UNDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases in Geneva. She received her academic training in India, the UK of Great Britain, and Northern Ireland, and the United States of America, and has published more than 350 peer-reviewed publications and book chapters. She is an elected foreign fellow of the US National Academy of Medicine and a fellow of 3 science academies in India. She has previously been on several WHO and global advisory bodies and committees, including the WHO expert panel to review global strategy and plan of action on public health, innovation and intellectual property, the strategic and technical advisory group of the global TB department at WHO, and most recently was co-chair of the Lancet Commission on TB. Above all, ma'am is our beloved and constantly supporting us in all our endeavors, and especially her guidance and directions she rendered to our department to face the recent COVID-19 pandemic was remarkable. We are happy to have you, ma'am. We welcome you, ma'am. Over to you, ma'am.
Thank you. Thank you so much for that kind introduction, and good morning, everybody. Thank you very much for the warm welcome. And I know that you've had 2 very good days of discussion already. Nice to see many of you, old friends and colleagues. What I wanted to do today is to talk a little bit about the potential of outbreaks, epidemics, and of course pandemics, and what are the lessons learned from the COVID pandemic that we can apply now for the future. And of course, we need to think about the preparations at the global level, at a regional level, national level, and also at the state level, and below that actually, district level down to the community. So I think we have to think differently now about surveillance and response than we used to in the past, because I think one realization has been that a next pandemic is a question of when, if not if. So it is very sure that there will be another pandemic, but nobody can predict when that will be or what pathogen it will be. And the second thing is that I don't think human beings have the capacity to prevent the next pandemic. So when we talk about preparing, it is preparing to act quickly, not preparing to prevent the next pandemic. What we can do is to act quickly to try to localize the response, outbreak response. If it is efficient and quick, then we can prevent it from turning into a pandemic. And even when you look back at COVID-19, if you think that maybe if we had advanced the understanding and the actions had been put in place even 2 weeks prior to what it was done, the result could potentially have been different. But on the other hand, when you have an airborne virus, which is a respiratory, being spread human to human through the air, and it's a respiratory virus, it does have the potential to spread very quickly and to go beyond, even if you take very strict measures. Now, infectious disease outbreaks, of course, have shaped history. If you look back over the many centuries, we've had plague, bubonic plague, we've had the influenza pandemic of 1918, we've had cholera, which we still continue to have, yellow fever, typhus, many things which actually have shaped history. But there was a point in the 60s and 70s when people thought we had controlled infectious diseases. This is because antibiotics had been discovered and had been found to be highly effective. And as you know, so at that time, in fact, investments went down in infectious disease research and also in drug development. But then now you know that thanks to or because of antimicrobial resistance, we have an increased risk of drug-resistant infections. So when we talk about emerging and re-emerging infectious diseases, we tend to think about viruses mostly. And it's true that viruses are the bulk of the zoonotic infections. But we have to also remember the threat due to bacterial infections, particularly drug-resistant bacterial infections, as well as fungi and rickettsia and other such parasites. So while 70% of emerging and re-emerging may be viruses, and most of them are zoonotic, this can come from wild animals or from the farming of domesticated animals, and including the illegal wildlife trade that is, and the wet markets, like what we saw in Wuhan was the fact that there were so many different animal species. They were live animals and they had been kept in that market in very crowded settings. And so not only was there animal to animal, different species were being exposed to each other, but also the animal to human. And this actually creates the environment for jumping of viruses from one species to another. The other factors, of course, are globalization, urbanization, there's climate change. I'm sure that you have discussed all of these factors. The fact that today a pathogen arises in one rural area, even in a remote rural area, it is estimated that in 36 hours it can spread around the world. So that is the speed with which today the pathogens travel, and that's why it's so very difficult to actually prevent and control it. And this is why we need to change the way in which we have been working. Now, if you take example of any disease which has been eradicated, it is of course smallpox. And it had certain properties why it was possible to eradicate, which we have not been successful in eradicating any other pathogen so far. Smallpox had a very good vaccine, sterilizing immunity with one vaccine. The vaccine was heat stable, it did not need refrigeration. The cases of smallpox, as you know, are very easy to recognize, so you could immediately identify the case, do isolation, do the contact tracing, ring vaccination. That is what actually helped in the eradication program. And that asymptomatic cases were not there. And as lifelong immunity following a vaccine. Now in the case of COVID, of course, these criteria are not there fulfilled, and therefore it is we cannot think of eliminating or eradicating COVID. We have to live with it. And if you look at what happens to pathogens when they get introduced into the human species, it takes a period of time. When it comes like this. It's a new virus, it causes acute disease, it causes a lot of illness because there is no pre-existing immunity. But after a period of time, as it has spread like how it's spreading now through the population, immunity is achieved, of course, both from natural infection and vaccination, and over a period of time, it becomes endemic. So that, sometimes it can take decades or many years to achieve that status. And we are often asked, is COVID endemic, is COVID endemic? It's very difficult to answer that, because tomorrow you may get a new variant. We have seen previously variants emerge suddenly out of the blue. And luckily for us, the last 1 year we've had the Omicron variant, even though more than 500 sublineages of Omicron are now being tracked. And as you know, they all have complicated numbering system, but they have not, any of them have not proven to have more severe disease clinically. So the vaccines are still protecting us against severe disease and death, though we know that vaccines are not protecting against infection because the virus was able to mutate to overcome the antibodies that we have generated. So it's still able to cause infection, but not, luckily, the large majority of people are protected from severe disease. But again, we have to remember that immunity wanes over a period of time. And especially if you're older, if you have underlying conditions or immunosuppressive conditions, immunity wanes. And this is the reason why the booster dose is very important. And whether in the future we'll need boosters once a year or so, at least for the vulnerable groups, elderly, that is something that is to be determined. But just like influenza, we have a variant adapted vaccine every year. It may be that for COVID also, we may need that type of vaccine, either using the original strain or using the latest variant strain. So this is why at WHO we had set up these committees to actually track the viral evolution and inform the development of vaccines, so that the vaccine developers are given some guidance, just like we have the program for influenza, which has been running for many years. Now, I wanted to say a little bit about the preparations, like for the future, how should we really start thinking about preparing for these emerging or re-emerging infections, or what the title has been called as uninvited visitors. But whether you invite them or not, they're going to come, and they're there all around us. And so I think we have to be smarter than the pathogens, which unfortunately very difficult. Viruses, you can see how COVID has been smarter than us, the way it has been mutating the critical parts of the spike protein. It makes the changes so that it's able to overcome. And every time you have a new variant, it's getting better and better at transmission as well as at avoiding the antibodies. So surveillance is going to be important, and we need to start thinking about surveillance in a different way, looking ahead. One thing that did happen, of course, over the last few decades, and especially during COVID, we saw the expansion of genomic technology, right? So while genomics had started being used to identify pathogens and to sequence them and to learn more about them, both for tracking outbreaks, but also for understanding things like drug resistance and understanding more about transmission. Today we are moving into the era of genomic epidemiology and genomic surveillance. And in many ways, this may turn out actually to be even more sometimes cost effective than a regular surveillance, for which you need good laboratory setup, you need culture. It's very difficult, of course, to set up viral cultures everywhere. We do have a network in India of VRDLs, but serology is easy to do. But when it comes to identification and trying to find out about resistance, etc., then this is where genomics is going to play a role. So it makes a lot of sense for the Department of Public Health to invest in genomics. The cost of sequencing has been coming down drastically. Today you have the small portable DNA sequencers, which can be sitting even in a district hospital or beyond. And very soon we will probably have portable ones, even solar powered, that can go into the field and that can be used for better patient management as well. As you know, we have many cases where we never make a diagnosis and we have syndromic management. But looking to the future and using technology, we should be able to make more accurate diagnosis. Just take the example of nosocomial infections or antibiotic resistance in the hospitals. Obviously, the patient is not going to survive if we do not provide the right kind of antibiotics. Similarly, for TB, we know that if you can diagnose the drug resistance early enough, put the patient on the appropriate treatment. Today, we have short course regimens for MDR TB and XDR TB. You'll be able to have a much better outcome. So this means that we have to invest in genomic technology, and we have to invest. It is possible now because, as I said, the cost is coming down. It's becoming simpler to use and to operate. And so we have to think about what type of, we don't have to put a whole genome sequencer in every district, but there could be a couple of labs in the state which can do the advanced type of whole genome sequencing, but you could still do genomic testing at the district level. And this needs to be thought through and it needs to be planned appropriately. Once you do that, you're also going to have to think about the data systems, right? And I think this is the most critical element today, and particularly when we think about the One Health approach, we know that because many of these infections are going to be zoonotic, we need the surveillance in animals, we need the links with the veterinary community, human health, and environmental sampling. For example, wastewater sampling has been used in the past for polio, it has been used now for COVID. In fact, in the US, before the cases increase in number, they are able to tell by wastewater surveillance that actually the circulation of a particular COVID variant has increased. And so they're able to, at least 1 week before the cases start coming, they can see that. Similarly, we can do it for other diseases as well. So we have to think about environmental surveillance. What type, for example, you have the waste that comes out of the food markets, especially when there is animals, meat that is being sold. That waste water surveillance could be another place. Similarly, we'll have to think of critical places where you want to put in place some kind of surveillance. Similarly, for people who are exposed a lot to animals, who are working in abattoirs, who are working with either domesticated animals or places where animals are being bred, or in the wild, people who come into contact with wild animals because of their profession. These could be sentinel populations where some kind of surveillance can be put up. It's also very important to think about community-based surveillance. So we have different kinds of surveillance, of course. We have the facility-based surveillance, we have the lab-based surveillance, but community-based surveillance, and I know that in Tamil Nadu there was a pilot program that was run in Tiruvallur district by the National Institute of Epidemiology, where you basically have reporting coming from the community. And this is a very good, I think it's a step in the right direction. It could be expanded to other districts also, because it involves a community. You pick up information which you earlier, of course, all the information that's coming through doesn't have to be acted upon. So that's the next stage where you have to deal with the data that's coming and be able to take the right decisions. At the WHO, they have something called the Epidemic Intelligence EIOS service, Epidemic Intelligence Outbreak Surveillance, which uses actually the data from different sources. So you can use artificial intelligence today to screen the newspapers or other sources of information, and it picks up anything that's being reported about a certain outbreak, you know, few cases of fever or few cases of diarrhea or of pneumonia. Of course, you will get thousands like that, and then out of that you can try to see which are the ones which need to be further investigated, and out of what the district level person should be able to decide. And then you can, out of that, one or two may turn out to be ones that you need action. So people even use a Google search today to find out about influenza, because when a lot of people start searching on Google for symptoms of fever, or they start searching for some symptoms, and you see that trend going up in Google, then you can know that in a particular area there are people who are searching for this, means there are more symptoms happening. So similarly, this machine learning algorithms, if they are used to scan the literature or to scan things like the internet, one can pick up what is going on. And of course, for a state, this can be done using local media and reports in the local regional newspapers, etc. So community-based surveillance is something which is important because it also helps to inform and educate the community, because ultimately all epidemics or outbreaks, they begin and they end in communities. They are not somewhere beginning and ending in some air. Some community somewhere has to be the starting point. And therefore, it's the community's action also that needs to be important. So if communities understand more about how these outbreaks are happening, could be a foodborne outbreak, waterborne, it could be vector-borne. So health education and risk communication is extremely important. And I think, again, it's an area where public health officials need to take a lead. Because we saw, and we are seeing now, the amount of misinformation that circulates through WhatsApp groups, through social media channels, actually is very damaging, because it confuses people and they don't understand what they should do, what is appropriate behavior that they should adopt, because they are hearing 10 different messaging coming. And if they keep getting the message in WhatsApp, then you start believing it, you know. So public education around about science and about biology and about the causation of disease, this has to be done at all the time, not only waiting for outbreaks or emergencies to start communicating that. So even on things like hypertension, diabetes, why are people getting these diseases at a young age today? In India, I feel that the impact of the Delta wave was so massive, partly because of the underlying comorbidities in the people who are 30s and 40s, obesity, diabetes, hypertension. And because of the high prevalence of these, we actually had more severe illness in this age group compared to the same age group in the developed world. There you saw people in above 60 being maximally in hospitals and getting severe illness. Here we saw many younger people. So for infectious diseases, we now know that non-communicable disease or chronic disease is also a very important determinant. And if you have obesity or hypertension and you get a respiratory illness, you are likely to be worse off. So there are links between all of these, and so this is why it's very important. And for Tamil Nadu public health, I think it is the number one priority, if you ask me, is attention to chronic disease, because the prevalence is so high and it is increasing day by day. If you look at the trends from the surveys that are coming, including things like childhood obesity, especially in the urban areas. So while we still have some undernutrition and malnutrition and anemia, but the rate of obesity, the rate of hypertension, diabetes is going up. So unless we have a very well done public health program, not only for identification, but also for management of these type of chronic diseases, which is affordable, which does not cause so much of disruption to people's lives, because if you have and we can learn from the ART program actually, how to run a chronic disease program where you actually listen to people, you listen to the HIV community, and then the National AIDS Control Program always moved based on the inputs that were coming from people, from the affected populations. That type of approach we have not taken for other diseases. So we need to start talking to the community about the risk factors and the determinants of disease, and also start thinking about how do we change those risk factors. If people are having an unhealthy diet, if people are taking too much of salt, there is of course a lot of alcohol use also happening, tobacco, and lack of physical activity. These are some of the drivers of chronic disease. So we need to start thinking about the risk factors, determinants, and trying to address those also. Of course, those are complex. They need interventions at multiple levels. It's not always within the Department of Health or the public health that can do that. If you want to address the issue of food systems, to give people a healthier diet, one has to talk to other departments and ministries in order to make changes. Let's say the PDS, you want to introduce more millets, or you want to introduce fruits and vegetables, etc. But I think for the long term, if you talk about health of the population, not just the absence of disease, but also health and wellness, then we have to address also the risk factors and determinants, and that has to come through a dialogue in the community. So we talked a little bit about the types of surveillance, and I wanted to mention genomics, because this is an area where investment is needed, training is needed, we need more bioinformatics training. But then once you have the data coming from surveillance, you need a very good analytical capacity as well. And I was very impressed with what South Africa was able to do. Starting with very basic capacity at the beginning, they were the ones who identified both the beta variant and the Omicron variant. And when they identified the Omicron variant, it was within 2 weeks of a cluster of cases that had emerged in a particular community. It was mainly college-going people, and they were living in a hostel or something. And so the local doctor there saw a cluster of cases, which she thought was COVID, but it was unusual because they had very mild symptoms and they were not getting admitted or anything. She was seeing them in the outpatient. But immediately she alerted that something is going on. They were able to collect samples and do the sequencing, and they immediately found out that this was a variant very different from the previous variant, which was Delta, and this had a lot of mutations, so that was called as Omicron later. So sometimes that alert is coming to you from an observant doctor, not necessarily from the lab surveillance that you have set up. And in fact, the first cases in Wuhan that were observed were by doctors who were working in the hospitals, who were sharing on WhatsApp groups amongst themselves about what they were seeing. Similarly, when you have any other atypical illness, and a few doctors in that area are seeing that through WhatsApp groups that have been created, you can identify very early. So again, we have to think about these digital ways of communication today. All of us depend on WhatsApp groups. Why not use it also for surveillance and reporting of these kind of events, right? So that is a digital epidemiology. You have genomic epidemiology, and then you have your traditional epidemiology, which is understanding, going to the field, identifying cases, screening the contacts, doing the contact tracing and understanding how a disease spreads, what is the source, etc. So traditional is always there. Now digital and genomic, how to integrate those, how to bring all those data together, and then how to act on it. There's no point in collecting a lot of data if we're not going to act on it. And that action has to be empowered at the district level, of course, and then if it is more or lower than that, and more serious cases will come at the state level. Vector-borne diseases also is the same. I was happy to meet somebody just now who said they are an entomologist. I think public health entomology is also a discipline which is probably getting neglected. In the earlier days, you had a lot of people who were going and screening for mosquitoes, identifying the different type of disease carrying mosquitoes. And it's not only mosquitoes. Scrub typhus today is one of the very common infections which is usually not diagnosed and not treated, and it can be fatal. And even in my own family, I've had family members with scrub typhus who were very seriously ill, and thanks to a doctor doing a full examination and finding out the SCHAR, that diagnosis was made, then confirmed by serology, and then of course treatment with tetracyclines is straightforward, but mainly it's a missed diagnosis. So it's not only mosquito-borne. We have to think about the other vector-borne diseases, and we are going to see more and more of, because of climate change and adaptation, we are going to see not only new diseases vector-borne, but also they are going to spread into areas where normally they were not seen. The hilly areas, we used to say there won't be any dengue, etc. But today in Europe also, you see that the prevalence of dengue and these type of filoviral infections is increasing in places which have never seen such infections, because those mosquitoes are able to survive. So again, with climate change, we have to also think about how vectors are going to behave and be prepared. And so public health entomologies should be a discipline which should be encouraged, and we must make sure that there's always a workforce, because I think we cannot ignore vector-borne diseases for the future. So one aspect is the surveillance. We talked about communities, in engagement and involvement of communities, and risk communication, and how to improve their understanding of science, and try to prevent what is called the infodemic. This was a word that was coined early in the pandemic. So the Director General actually said, not only are we fighting a pandemic, we are also fighting an infodemic. That means an availability of information, and a lot of it is misinformation. So this trend which has started is going to continue. And this type of misinformation can start in any country, but today, because of social media, there is no boundaries, and this spreads throughout the world. And in fact, we see today that in Africa, immunization programs are suffering because of misinformation that has come from some other outside country, but it has created a lot of confusion. So I think that's an important, again, area, and we need to build the skills of the public health department in order to also use behavioral science and behavioral and social science to understand the behavior of people and public, and how our messaging can have the maximum impact. And again, I think HIV is a good example where this has been used to good effect, but we need to use it across other public health programming. And I don't know if there are any social scientists here in this audience. Can you please raise your hand? Any? Oh, very nice to see few hands going up, but far too few. So we need to include more social and behavioral scientists, anthropologists, etc. within the public health service. We have seen in previous outbreaks like Ebola, because we did not have that expertise, it took much longer for the community action. Like, for example, in Ebola, the dead body has to be managed in a way that family members cannot touch the body, and that is against all the cultural practices. And therefore, initially, people kept on getting infected because they were doing the funerals in the usual way. It's only after anthropologists went in there and spoke to the people and understood and convinced them that the Ebola outbreak actually could be stopped. So I think it's an important lesson to be learned. Now, the other aspect is the countermeasures, or what we call as, how do you manage once you have an outbreak? Drugs, diagnostics, and vaccines. And we saw that for COVID, we were able to develop both diagnostics and vaccines very rapidly, though there was inequity in access, especially for diagnostics early on, because very few countries had the PCR capability. They were not able to scale up. India also scaled up quite rapidly, and of course we have a lot of companies and startups, and private sector came in and made the point of care tests, etc. But in many African countries, only 1 or 2 labs in the whole country could identify, and this is why you don't have number of cases being reported from those countries. So diagnostics is very important, and again, today using PCR, very quickly one can diagnose a new infection. As soon as the bug has been sequenced, you can develop the primers for PCR, but we need more innovation on the point of care rapid diagnostic tests even for existing infections. Today, if you look at a primary health care center, how many infections are we diagnosing? We are not. We are managing syndromically. But today, it should be possible to have these multi-platform, a platform which has multi-pathogen capacity to be placed at the primary health care center, which can give you a rapid diagnosis of, say, the 5 top infectious disease which may be prevalent in that community. So that type of thing is possible now. So diagnostics is important. Drugs, well, antivirals have been neglected. We don't have good antivirals except for HIV, and there again we have to use combination antiviral drugs. But antivirals in general is an area that there should be more of R&D. And of course, as I mentioned earlier, antimicrobial resistance, we need more R&D for new and better antibiotics. Of course, we need to also prevent antimicrobial resistance from developing by taking action. Infection prevention and control and surveillance is going to be very important. And some states, I saw that Kerala has recently set up a system of AMR surveillance, and they make the result openly available to everybody. Then vaccine. Vaccine development today has taken a big jump in terms of new technologies being available. And again, because of the availability of the sequence, you don't often need the whole virus or the whole bug. You can take the sequence, put it into an mRNA platform and develop a vaccine. Today there is something called a 100-day mission, which means that in the next pandemic or next severe outbreak, we should be able to develop a vaccine within 100 days. That's a sort of a goal that has been set. And there are many agencies trying to work towards that. Means it needs a lot of preparation and investment in the past. That is before a pandemic happens. So in WHO, we set up a prioritization committee, which is looking today at all the viral families, as well as bacterial and fungal families, which are the most likely to cause a severe outbreak in humans. And once we have that priority list, then vaccine developers can address those particular families by developing a prototype vaccine. So you can take one pathogen from that family and develop a prototype vaccine. That can then be modified very quickly if the outbreak is due to a different pathogen. So not only that upstream development is important, but downstream also, like how to do the clinical trials very quickly, having the ethics review capacity and the regulatory approval capacity, having the sites to run the clinical trials, having again the community engagement, all those things are important. So maybe in the end, I just want to say that that research is going to be a very important element of preparation, because research is the way in which you learn new things, whether it's about behavior of communities, whether it's about risk factors, or whether it's about the biology of a pathogen. And that, unfortunately, is still lacking. If you ask what is the dengue epidemiology in the country today, there are some studies that have been done, but we need much more in-depth understanding. Zika has been recently reported from a few states. What is the circulation of these viruses? Even if you take within one state, what are the hotspots? Where are the risk factors? Where are the outbreaks occurring? You need a kind of a map. Similarly, for food safety, using these new approaches like digital epidemiology and so on, one should be able to identify where are the hotspots where you have more likelihood of events due to lapses in food safety, etc., including identification of those commercial establishments where this could be happening regularly. So better use of digital tools, artificial intelligence, data sharing platforms. We have INSACOG, which is an Indian genomic surveillance platform, but you also have global platforms like GISAID, which today are expanding beyond flu and COVID to cover pathogens like RSV, tuberculosis, as well as other pathogens. So we need to also become part of these global networks and share the data and also learn from the global data. But I think investing, I know that many of the staff of the public health department have undergone a master's in epidemiology, have undergone FETP program. That actually gives you the skills to undertake research, including operational research. And then, of course, there should be always good centers and medical colleges that can undertake detailed epidemiological studies, detailed clinical studies. For example, in post-COVID today, we need to understand actually how COVID has impacted the population here in terms of long-term sequelae, long-term neurological problems or cardiovascular problems. We get anecdotal reports coming in the newspapers. But unless you have a well-designed and well-conducted follow-up cohort study, we won't be able to establish the links and we may come to false conclusions. So methodology is extremely important. But I think Tamil Nadu does have the capacity, the infrastructure and the human resources. So I'm very confident that in the future we can be even better prepared. I've not talked about the clinical care and management aspect. So normally there are 5 C's one needs to think about. The collaborative surveillance is one. The community-based action is the second. The countermeasures, the drugs, therapeutics, etc. is the fourth. The coordination, that is a central coordination is extremely important. And the 5th C is the clinical care and management. And we saw how important that was in reducing the mortality and morbidity. By having standardized protocols for clinical management, making sure that you have the essential drugs, including oxygen available at all levels where they are needed, and also doing tabletop exercises. Once in a while, I think, do a tabletop exercise or what is called a war game kind of approach, where you try to mimic what may happen if you have a severe outbreak of a respiratory-borne outbreak or a food-borne or a blood-borne, for example. The next one may be a hemorrhagic fever. Do we have enough blood banks and blood facilities available in order to be able to do that? Do we have the isolation rooms available in every district in order to isolate such patients? So these are the kind of preparatory activities that would be needed also for clinical care and management. So I think I will stop there, but I'm very happy to answer questions, and thank you very much for this opportunity to share some thoughts.
Thank you, ma'am. Any questions?
Very good morning, ma'am. My name is Arun Selvaraj. I represent an organization called Eco India. I had the fortune to work with you in the past. We did an extensive training program, during the times of midst of COVID for a state of Gujarat and Chhattisgarh. It was an extensive 2.5 months training program. You and Dr. Priya Sampath ma'am have been, mobilizing it. Thanks so very much for that. I have a question related to the surveillance part that you spoke about. You talked about the Epidemic Intelligence Service program, which is, I believe it's run by NIE. It's a 2 years, intense hybrid on-field and as well as, classroom training program. Skill building and surveillance, all that is a part of, a multidisciplinary approach, which means it's a team effort. I see this program is only right now catering to the medical doctors, and the criteria itself clearly says, medical MBBS and so on. But a lot of these surveillance activities are happening on the field. Don't you think, or at least in your own opinion, it should not be open to other cadres of healthcare workers like social workers or nurses or field level staffs? They also play an integral role in contributing in bringing cases to the community, to the higher centers. So that's...
Yeah, the answer is simple. I agree with you that the EIS program or training in public health should not be only for doctors. It has to be for all categories of people, including nurses, social scientists, other public health personnel who are present. And using the ECHO platform. ECHO is a digital platform for capacity building and learning. As he mentions, it was used a lot during COVID, but it's also being used before and after. And I think Tamil Nadu state also has an MOU with
yes, ma'am, you've
ECHO
been
India.
extensively working here.
That can be used actually for furthering some of these trainings, including for the lab side. So that's a good point.
Thank you, ma'am.
Good morning, ma'am. Thank you for that very comprehensive presentation. I'm Jakun, I come from Vellore. Ma'am, you covered the aspect about community acceptance, and now we see, especially in Tamil Nadu, at least where we work, there's a lot of skepticism towards modern medicine. A lot of, I mean, we can call it misinformation, but mainly due to local players, you know, traditional healers, faith healers, who feel that we are getting into their system and they will lose their livelihood. So what approach do we follow? Carrot approach, get them into the system, use them to forward modern medicine, or the stick approach, you know, crack down on them. But it's like the Medusa's head where you chop one off and two pop up. So what do you think is the ideal way of going about this? Thank you.
Yeah, see, that's a very good question actually, and it's important not just for Tamil Nadu, but for I think all states. It's a complex social issue, isn't it? So there is no clear-cut answer. Neither the carrot alone or the stick alone is going to work. So this is why it's very important to understand the health-seeking behavior of a population. Why do they prefer to go to that person? Normally because that person is part of the community, is well-liked and respected, is available 24 hours of the day, right? And speaks in a common language that that person is able to understand and appreciate. Now, if you had a health worker who was also available there all the time, the government health worker, who was able to explain and understand. See, changing behavior takes a long time, especially something which is very much entrenched, but it can be done, and it has been done. So I think we need to understand which are the areas where it will be dangerous for a traditional medicine or a faith healer to be treating. For example, TB, we know that for an average TB patient to reach the government system, it takes many weeks or months, and they have been through many different practitioners. And I would say it's also private medical practitioners, allopathic. It's not only the faith healer. So allopathic practitioners also, you have different standards and different capacities, right? Not everybody is following the evidence-based medicine. So I think, again, that's a big gap for the public health system, because the private sector is not going away. It's not going to disappear. The private sector will continue to deliver services, whether they are allopathic or non-allopathic. How do we bring them into the fold? How do we train them and incentivize them so that simple things they can be looking after, but what are the things for which they must immediately refer? You know? So I think it's really that engagement rather than a very simple approach of a stick, which is definitely not going to work, as we have seen in other disciplines. But it's a really important issue. And I think you reminded us that the private sector delivers so much of healthcare services that they are they can be an important ally if they are brought into the fold, but if not, they can also be a sort of a barrier in our public health goals.
Thank you, ma'am.
Any other questions? Mike?
One of the important agenda for public health would be to coordinate and collaborate with the government that present there. They have a political agenda, they have their own agendas. How difficult or how easy it is to bring in the health agenda into their political agenda or government's agenda? What would be the way forward to take them on to reflect on health agendas as well? And you have been doing that as a WHO representative. And what suggestions would you give us on this aspect? Thank you.
Yeah, thank you. That's a great question as well. So I think today health is higher up on the political agenda than it has ever been. And that is because of the pandemic. And the pandemic exposed the good, the bad, and the ugly. And we saw both our strengths and our weaknesses. You know, every country, every state was able to identify the strengths and weaknesses in the system. It's a very good opportunity to build on that, strengthen wherever we found that there were fault lines. I think we have to continue to make the case. Basically, you have to make an economic argument. That is the only thing that will convince politicians to invest more. Because you see, the investment always goes into the areas where you can get an economic return. So the argument, I think, is that if you have a healthier population, then you, economically, that state or that country is going to do better. And there are enough models and things to show that. But I think we have to keep on demonstrating that an earlier identification, for example, if you take premature mortality, okay, that's mortality before the age of 70 years due to any of the chronic non-communicable diseases. Premature mortality has been increasing in developing countries, whereas in the developed world, because of the high quality access to treatment, even if somebody has hypertension or diabetes or heart disease, they can live a comfortable, good quality of life. If you see the Indian data, our life expectancy today is, say, around 70 years. It's higher for women than for men, maybe 72, 68, something like that. But if you look at healthy life expectancy, it is 10 years less. It's only around 60 or 62. That means all of us, for the last 10 years of our life, are living unhealthy. We are living with multiple chronic diseases. And why do we have these? As I mentioned, it's the risk factors. Today, air pollution is one of the biggest risk factors to our health, not only for lung, but all organ systems. And we are not doing enough. Food systems, we are not doing enough. Our urban environment where we can go for walks or people can have some greenery and fresh air, we are not doing enough. So I think the health department has to go now, open its eyes broader and go beyond. We'll only manage our own hospitals and public health system. We will never be healthy. We can manage ill people and sick people. But if you want to be healthy, you have to look at these others. And that's where convincing the politicians is going to become really important. We need the data. If you tell that we are losing so many thousand people every month because of air pollution, and which are the areas where there's more air pollution, can correlate it with higher incidence of cardiovascular mortality, then with that data, actually data speaks volumes. And I really feel we have a long way to travel in the way in which we use our data to impact on policy changes.
Good morning, ma'am. Just one question. With evolving digital health, we are involving everything in health digitally. So do you think that the patient interaction, starting from making an OP ticket entry, we have started entering everything in computers. Previously, the person who may know the person, but just now what they do is just look at their keyboard, type the patient's name, age, address. They just hear everything, but they don't see the patient. So do you think that with evolving digital and involvement of more digital technology, we lose interaction with the patients? And also for the healthcare workers, previously Asha, Anganwadi, VHN, they meet the patients, they talk to the patients, but they are now more involved into the data entry part, digital. So do you think that with evolving digital technology, we are losing touch to the patients?
That's a very good question. I think you have partly answered it in the sense that, yes, if you're going to be spending a lot of time entering data, your face-to-face interaction with the individual is going to be less. And that's not a good thing, because ultimately it's that human-to-human interaction that makes a difference, to people. Of course, we can use digital technologies to help us do our work better, like data collection, sharing of electronic health records, also telemedicine, telehealth. But I think technology is not going to take the place of humans ever. And we should not think that that will happen. Just because we have collected all the data doesn't mean that we have communicated effectively to the patient who's sitting there. I don't know what the solution is. We have to think of solutions. But to me, one thing is that you need more of a workforce. Because today what I see is that the same workforce is being asked to do more and more digital recording of data, right? So that's taking away the time from what they could spend in talking to people. So whether it's a VHN or whether it's a doctor, if you have a lot of data to be entered, then, and that's something somebody is monitoring, you'll be trying to do that rather than do the counseling that you're supposed to do, right? So I think the way is that we need more of a health workforce. We need more of paramedical people who can support the doctor, nutritionists, physiotherapists, experts on counseling, mental health, etc., which are support staff with the doctor to provide the holistic primary health care service that the patient needs. Today, you will find that as Tamil Nadu is aging, we are going to have a more and more demand for rehab, physiotherapy, palliative care, assistive devices, end-of-life care, etc. Are we thinking about those things? How we are going to provide? Do we have the workforce that can provide those services? So digital, yes, we need it, we have to use it, but we have to also see that it doesn't take away from the quality of care that we are providing. So actually answers should come from all of you, and suggestions should come on how the system can be improved.
Please be seated. Thank you, ma'am, for an insightful presentation throwing light on organisms re-emerging, the infra and lab systems we need to get prepared, and the data systems with the technology. And on health education, and also we will take your valuable suggestions to have more community-based interventions from our side. And on behalf of organizing committee, ma'am, we thank you wholeheartedly for making your presence in this and gracing our prestigious occasion, ma'am. Now I request our organizing secretary, our additional director, Dr. Somasundaram sir, to felicitate ma'am with a memento. Thank you. Moving on to the next session, it is a plenary on time-tested drugs and equipment logistics system to reach the last mile healthcare delivery in Tamil Nadu. Please join me in welcoming Thiru Deepak Jacob IAS sir, Managing Director, Tamil Nadu Medical Service Corporation. Welcome you, sir. Sir is an engineer turned civil servant belonging to the Tamil Nadu cadre of Indian Administrative Service, committed to finding people-centric and sustainable solutions in public service delivery, believes in participative democratic values and upholds compassion, empathy and benevolence on the key virtues in personal life, extremely organized and adept in prioritizing work with proven competencies as an administrator. He started his career as an assistant secretary in 2016 Ministry of Corporate Affairs, New Delhi, and continued as subdivisional magistrate 16 to 17 District Administration, Thoothukudi. And he also served as project director in December 2019 to June 2021, Tamil Nadu AIDS Control Society, Chennai, and joint chief electoral officer. His interests are generalist administrator with a deep interest in public policy and development, infrastructure development, public health policy and risk management, and currently MD TNMSC. And sir is another pillar of support to our department and has ensured uninterrupted supply of essential drugs and equipment to the medical institutions and PHCs in India, and manages and runs the largest network of radio diagnostic centers, and he is a member of COVID task force in advising Honorable Chief Minister of Tamil Nadu. We welcome you, sir. Over to you, sir.
A very warm good morning to all the participants, attendees of this conference, and of course, esteemed speakers. First of all, let me place on record my best wishes to Directorate of Public Health and all the team led by Dr. Selvanayam sir in celebrating the 100 years of establishing this esteemed institution. When I got this invitation to present or maybe to speak in this forum, I thought I was a misfit because all our doctors, all our public health experts, people practicing medicines or practitioners, but I thought I was a misfit. But DPH was gracious enough to grant me a titular of Dr. Deepak Jacob because I have served almost 3 years in health department. So I would like to extend my my gratitude for the organizers of this conference in giving me this opportunity to share this platform with wonderful speakers and other eminent personalities. So without further ado, I would like to start my presentation on the famed TNMSC model I don't think TNMSC requires an introduction to this gathering, especially because all of you might be quite conversant with the role of TNMSC and how it is supporting the other directorates of Health Department of Tamil Nadu. But still, I don't think many would be quite, will be more understanding about the model of TNMSC, how it actually functions, what is the structure, what are the guiding principles of TNMSC, and how TNMSC can expand its scope in the years to come. So my whole presentation is about explaining you the basic structure of TNMSC, the way in which it functions, its modus operandi, and interestingly, few areas where in which we can expand our scope in the near future. So, how do I turn this? Yeah, so the pre-TNMSC scenario, as most of you might be knowing, earlier before TNMSC was set up as such, there was acute shortage of drugs and medicines across the medical institutions of Tamil Nadu. And each institutions had to procure more than thousands of drugs individually, which all led to non-uniformity in the prescriptions or non-uniformity in the constitution of the medicines. The rate was abnormally high and used to vary from, let's say, tens of rupees to thousands of rupees. And basically the prescriptions were market driven, meaning this was not actually what was being prescribed. It was based on the lobbying or maybe the push from the drug companies. All the drugs procured were in bulk packaging and it was in unhygienic storage and distribution was the result. It all led to lack of faith in the government services and resulting in the participation in the healthcare delivery system. So TNMSC was set up in 1994-95 by the government order dated 12/6. The main objective was to deal with the procurement and supply of drug purchase and distribution, capital equipment purchase of surgicals and stores, hospital maintenance, training of medical manpower and any other functions assigned by the government. So these were the initial mandate of TNMSC, but over the last more than 2 decades we have evolved. We are strong on certain aspects, we have I should admit that we are weak or maybe certain areas were neglected and few other areas we have improved our scope. And currently TNMSC is procuring nearly 95% of the health supplies of the state. So this is the structure of TNMSC. The board is the all in all the spine of TNMSC. The board is being headed by a chairman of principal, who is the principal secretary health. We are having representations from the finance department, of course MD TNMSC and all the directorates, other HODs, MDNHM, DME, DMS, DPH, Director Drug Controller, and because of the limited warehousing activities or construction related activities, we are having a representative from the PWD, which is Chief Engineer PWD. So the board is the all in all powerful organ of TNMSC and all the tenders are being approved by the board. As far as the tender is concerned, there is a subcommittee called Tender Committee, which has been delegated most of the powers to approve the tenders. And the tender committee is again headed by the chairman, who is the principal secretary health. We are having a finance member, MD TNMSC, and the directorate of medical education, other members of tender committee. The tender committee's responsibility is to recommend all the proposals to the board of TNMSC, and the board finally gives the approval. And of course, the huge role of TNMSC lies in ensuring the availability of drugs and medicine across all the government institutions. And how are the drugs being finalized and who takes the call? So that's the role of a subcommittee another committee called Drug Committee, which is again having representation from all the directorates, DME, DMS, DPH, Directorate of Family Welfare, DMS, ESI, and Director of Drug Controller. All the treating directorates, HODs give the recommendations regarding what all new drugs needs to be added, if there is any modification regarding the strength or any other changes, they will be giving the recommendations, and statutory and legal aspects are being vetted by the Director of Drug Controller. Now, what is the how is the procurement process being done? Basically, it is being backed by a statutory act, Tamil Nadu Transparency in Tenders Acts and Rules of rules framed in 2000. As far as drugs are concerned, we float a single national competitive bidding, which is a single tender for almost all the essential drugs and specialty drugs. The conditions of tenders are only manufacturers with GMP certifications are allowed. It is basically consumption-based procurement, meaning most of you might be knowing we are having two lists, which is called essential drugs and specialty drugs. And the essential drugs, we don't procure it based on the indents from the hospitals. We have a consumption pattern based on which TNMC itself decides that these are the past consumption trend, and accordingly we place orders with the empaneled suppliers and make it available in the warehouse. So this has its own pros and cons, the advantages being that we need not collect the indents from each of the medical institutions or the hospitals. Whereas on the other hand, any market distortion or maybe any other forces which would disturb the consumption trend will not be captured in the portal that we are having. So it became evident when during the COVID period. Post the COVID pandemic, there was a sudden increase in the consumption. And the logic of our consumption, the formula is that the last 365 days consumption of any particular drug or the last 3 years, whichever is higher. So this is taken as the consumption value, and we place orders for the next 3 months in advance. Whereas because of the COVID pandemic, there was a huge, sudden dip in the consumption trend, and now it is suddenly picking it up. So, but what happened was that the logic that we have applied for the last 365 days and the last 3 years consumption was no more relevant at this point. So we need to improve and had to manually override the system. So it has its own advantages and disadvantages. Next, as far as the drugs are concerned, they supply directly to the district warehouses, and the payment is based on the receipt of material receipt certificate and the subsequent quality clearance. Generally, the drugs are procured with 2 years of expiry date. On the other hand, with respect to the medical equipments, we usually go for national shopping method or international competitive bidding in case of externally aided projects like World Bank or JICA projects. The manufacturer bidder are usually preferred, whereas non-manufacturer bidders are also allowed with certain additional conditions, such as they should produce the authorization letters from the manufacturers, they should have extra security deposits should be submitted. All these extra conditions would be prescribed. When compared to the drugs, the equipments are indent based, meaning we start the procurement process only once the indents are received from the end users. The end users could be the medical colleges or maybe funding agencies like TNHSRP or NHM. Based on the proceedings only, we start the whole tender process and the procurement is initiated. The direct supply happens to the institutions, and after the installation, the payment is being initiated by TNMC. One main advantage of all the equipment procurement is that the equipment during the tender stage itself, we ensure that 3 years warranty followed by 7 years CMC is covered, which means that once an equipment is procured for the next 10 years, which is basically a life cycle of an equipment, is already been taken care of. In both the drugs and equipment procurement, 2-cover system is being usually followed, which is first opening of the technical bid, and once the technically qualified bids only will be further processed for the financial bid opening. It's a transparent online process. At each stage, there is a stakeholder involvement so that we keep our bidders involved in all the decisions being taken. And the authorities or maybe the stakeholders involved in the administrative process are tender inviting authority, who is basically the general manager in the TNMC. There is going to be a technical scrutiny committee, which will be a panel of experts. And once the tender is being technically evaluated and the bids are finalized, we submit it before the tender accepting authority, which is MD TNMC, for all the procurement up to 1 crore. Anything above 1 crore, we submit it through the tender committee for the board to take a call. And the appeal authority lies with the government. Now, this is the fund flow mechanism for drugs. Most of you might be knowing there is annual budgetary allocation from the government, and the HODs get the annual budgetary allocation, and further the HODs allocate budgetary allotment to individual institutions. And 90% of the budgetary amount is deposited with the TNMSE in the PD account, personal deposit account of MD TNMSE, and the balance 10% is kept with the HODs to meet out any emergency procurement. So this huge 90% of the budgeted amount is available with TNMSE at any point of time, with which we are able to make the timely payment to all our suppliers. So the motto over here is that payment, the suppliers or the private people, they always look for timely payment, and that is being ensured because TNMSE has always sits on certain amount of money. And once this amount, once the tender is being finalized, we issue passbooks for the individual institutions, and the institutions can lift the drugs based on the passbook value. For making the payment, we withdraw money from the PD accounts as and when required for making payment to the suppliers. And in case of equipment procurement, there are low value procurement, which is defined by the Tender Transparency Act for anything less than 25 lakhs, which is basically national shopping. We can take quotations, receive quotations from the different prospective bidders and finalize the tender. And anything above 25 lakh is what is called an open tender. We also float rate contract, which is valid for 1 year, wherein which the quantity can vary from anything from, let's say, 0 to 100 or even more. One interesting thing, or maybe one interesting innovation that we did in the equipment procurement is the single tender with multiple schedules. So for all high-end equipments like CT, MRI, LINAC, Cath Lab and all, we float a single tender with multiple schedules so that different specifications of each item is empaneled. And final orders will be placed based on the fund availability and the end user requirement. So which means that I have a 16-slice CT of varying specifications. It ranges from 2 crores to 2.4 to 2.8 or 3 crores. Based on the fund availability and the end user requirement, I can operate any of these particular schedules. So this is being adopted for the last couple of years, which is quite successful model that we have been following. And for the import value of rate contract with respect to the Indian rupees, there is an escalation of 4% with respect to any indigenous components. This ensures that whenever there is a price escalation, our bidders are also equally accommodated. Now this is the procurement value over the last couple of years. As you can see, the drug value, which was almost around 400 crores, has crossed 1,000 crores, especially during the COVID period. Similar is the case with the equipment procurement also. Now we are having the whole drug thing is being managed by the supply chain management with respect to the establishment of drug warehouses across districts. And we are having 32 drug warehouses. 5 new drug warehouses are being constructed in the newly formed districts. And we are also having an own construction and maintenance department for the maintenance of the drugs. One main aspect of TNMSE which we always take pride is the strict quality control measures that we enforce. So for each drug samples that we have been receiving in the warehouse, samples are lifted within 3 days. Common batches of each product are eliminated at the headquarters. There is masking of the supplier details, and these are being sent to private empaneled laboratories across India. So the idea is that the manufacturer's details are not known to the laboratories, and the suppliers also won't be knowing which their sample has been sent to which laboratories. On receipt of the result, the drugs are being released from the warehouses. If there is a failure in the samples, it is being returned, and if it is being passed, it is distributed to the institutions. On the right side, you can see the pass percentage over a couple of, over the last years, we have maintained a pass percentage of more than 99%, and our fail count is always less than 1%. Now, this is the procedure for blacklisting with respect to the drug. Whenever there is the blacklisting can be based on 3 aspects. One is the quality failure. Another case in which the supplier is withdrawing from the whole tender agreement. And in case of non-performance. These are a bit fairly technical. Now, with respect to the equipment maintenance model, we take pride in having a unique model which is being adopted across Tamil Nadu. One thing is, which I mentioned earlier, is the 3 years warranty and 7 years CMC, which means that for the 10 years, for the next 10 years, which is basically the life cycle of any medical equipment, the whole maintenance and the service aspects are being taken care of. And all essential equipments directly procured by the medical institutions also are being maintained and CMC centered by TNMSE. The installation of equipments, calibration, quarterly preventive maintenance, contamination of equipments, it's all done by the presence of biomedical engineers, which is being appointed by TNMSE in the field. So we are having biomedical engineers across the districts and in all the medical colleges. This is unique in the sense that in most of the states, they have outsourced the work of maintenance and service aspects to a different agency, which means that a Philips product can be serviced by another third party. Whereas in Tamil Nadu, only the original equipment manufacturers or the suppliers are doing the preventive maintenance. This ensures the cost economy and competitive services as they provide genuine space and on-time services. The BME, biomedical engineers, locally resides in the districts and ensure the installation, easy complaint monitoring system, and they help to minimize the breakdown time. So all these things are being monitored through a centralized monitoring system called equipment management and maintenance system. So these are the other services that we offer to the medical institutions, which is basically operationalization and management of diagnostic services. TNMSE again takes pride in managing the world's, maybe perhaps the world's largest network of diagnostic services, which is more than 117 CT centers. Another 5 is also on the pipeline in 88 locations. 33 MRI scanners at 32 locations, and in all the CT MRI scan centers, wherever there is radiologists are not available, teleradiology is being implemented. We also operate PET CT high-end, which are high-end diagnostic machines through PPP mode even. Now we are venturing into therapeutic services. TNMSE has taken over radiotherapy centers about 4 years back, under which 9 LINAC centers are operational, 10 cobalt centers, another 5 is in the pipeline, 8 brachytherapy units. Other high-end equipments like lithotripsy and cath labs are also being maintained by TNMSE. This is one other extra service that we offer. We operationalize and manages the pay wards and consultancy services to governments and other medical services corporation. In certain exceptional cases, we provide financial support to medical institutions also on loan basis. Now, this is all about TNMSE and its structure and functioning. Maybe I would like to inform the group about how a decision can be taken based on the data that we are having. So we are having multiple dashboards and multiple tools like drug analysis dashboard, the oxygen alert dashboard, by implementing telemetry devices in all the LMO tanks. There is equipment management software. There is DDMS, which is the drug maintenance, drug distribution and maintenance software. So all the decisions that are being taken by TNMSE are basically data driven. So at any point of time, I know what is the stock of any particular drug in all the warehouses. And based on this, how a procurement agency, a medical procurement agency can widen its scope or maybe redefine the boundaries. This might be interest to maybe many of the attendees. See, our major role was that we are a master of all the drugs. But the master of the drugs that we procured, does it end with the drug warehouses of TNMSE, or should we take it to the next level of medical institutions? So now we are expanding the scope of having control over the drugs from the warehouses to the medical institutions. We are also thinking of improving the health service delivery. We have already taken care of radio diagnostics and radiotherapy centers. Next step might be, why don't we take over the dialysis centers? Why don't TNMSE take over the cath lab centers? So that is the way in which maybe TNMSE can help and support the other medical, other HODs or maybe other directorates in improving the health service delivery. We are sitting on huge data sources. The legacy data of the drug consumption is too much, and proper data analysis of the data that we are having would help the policy formulators or the policy makers in making an informed decision. I can explain, I will show a few examples of the same in the coming slides. We expanded our scope into giving consultancy services. Other medical service corporation have been set up based on the same lines as that of TNMOC. As ma'am was also saying, see, emergency, I mean, health emergency comes without, they comes uninvited, and it's all, I mean, no one anticipates any emergency. But when it comes to health emergency, TNMOC needs to quickly respond. So how to streamline the emergency procurement, especially in the case of and pandemic like COVID and maybe other natural calamities? How can TNMOC streamline the emergency procurement activities? Green and sustainable medical procurement. How can we reduce the carbon footprint of the medical equipments that we procure? Of course, health technology assessment is one another area wherein which it would be more helpful for TNMOC to make informed decisions. So these are few examples. As an administrator, maybe this is more important for TNMOC. This is just a slide which shows the analysis of suppliers. Yeah. So the blue one is on the left side, you can see the blue color tab, which is the essential drugs. And essential drugs, for over a couple of years, the suppliers for the essential drugs are almost, remaining constant. It's in the range of 100 to 110. So as an administrator, as a medical procurement agency, how can I improve my supplier base? Should I do some kind of a, publicity campaign to untap the suppliers across India? I mean, this is one area where as an administrator or as a government should take a call on the same. On the right side, I have furnished the data of the statewide suppliers. As you can see, most of the Madhya Pradesh 132 essentials drugs or the 132 suppliers for essential drugs are from Madhya Pradesh. If you look at Maharashtra, another 165 essential drug suppliers are from Maharashtra. Almost 237 specialty drugs are from Maharashtra. This is all the more important for a government policy formulator, in case of an emergency like COVID. Suppose the sons of soil argument kicks into picture. Will Tamil Nadu get sufficient supply of drugs? I mean, these matters can be taken up at the government level, and further decisions can be taken whether government should invest upon, inviting more pharmaceutical companies to Tamil Nadu. One interesting thing is that Sikkim, there are 6 specialty drug suppliers who are situated, who has their manufacturing premises in Sikkim. Why in Sikkim? Because the government is offering a lot of incentives. They are offering a special economic zone for all the manufacturing companies to set up their manufacturing units over there. So these are information that the government can rely upon to make a drug policy or related to pharmaceutical industries. Another example, this might be important for directorates. You can see how the drug budget of individual directorates are, has improved over the past years. DME and DMS, there is a sudden increase in the drug budget from 130 to almost 250 in the last 2 years, whereas DMS is still in 50s and 60s. So what is lagging? Should DME and DMS get major chunk of the drug budget, and DPH, shouldn't there be any commensurate improvement in the drug budget? So this is another analysis that we can do and help the directorates to make, to factor in the increase in the drug consumption, and based on which the drug budget can be formulated. Another example, this is an analysis that TNMOC has done based on the drug consumption data that we are having. So we have defined almost 43 tracer drugs, which most of you might be knowing. These are the drugs that fulfill a population's health requirements and should always be available. The trajectory or the consumption pattern of any tracer drugs would show that whether the disease is being prevailing in certain community or not. So here I just taken a snapshot of one particular drug called metformin. So metformin, we have tagged it with the diabetes, which is the tracer drug for diabetes mellitus. You can see in the below graph that there is an increasing volume, increase in consumption volume wise of metformin, which means that there is increasing cases of diabetes mellitus in community. So this is based on the drug consumption data that TNMOC is having for the last 10 years. Another example is about how to understand the disease profile. See, I have just taken snake bite. So most of the drug are being dispensed from Tanjavur and Trichy, which means that most snake venoms are being consumed in Tanjavur and Trichy. Maybe because these are delta regions and there might be cases of rats and snakes, and maybe because of which anti-snake venom is being consumed over there. So if I take any other drug, most of the consumption will be based on will be in Madurai or Coimbatore or Chennai, because of the major population. Whereas this is another interesting area wherein which I can see that this is the area, Tanjavur and Trichy, based on the consumption pattern, this is where a public health intervention should be made. Another example is about forecasting the trend. So atorvastatin, it is basically associated with cardiovascular disease or maybe cholesterol. So my forecasting analysis says that it is on an increasing trend, meaning it is nowhere going to die soon. The drug atorvastatin, which is preferred drug for maybe cholesterol, shows that it is in an increasing consumption trend, which means that all the directorates should factor in the trend in how the disease pattern is being changed, how the drugs are being consumed. So all these would help the policy formulators to arrive at a very informed decision. Now, I'm coming to the core, to the fag end of my presentation. The core strength of TNMSC lies in the fact that it's a very lean and efficient organization. We are having functional autonomy. This is a structured fund flow because the funds are being available with TNMSC at any point of time, and there is prompt payment being done to the vendors. And there is a robust IT infrastructure which helps us in making an informed decisions. There is rigid quality control. I have explained the quality assurance mechanism which are in place. Supply chain infrastructure by establishing the drug warehouses across Tamil Nadu. Management information system is helping us in making any informed decisions. And at any stage of tender process, we involve the stakeholders so that the stakeholders are involved and they are kept in good confidence. So finally, how has TNMSC changed the scenario of health sector in Tamil Nadu? So earlier there was decentralized purchase by the deans or the JDs or DDs of the hospitals in staggered quantities. Now it is a centralized procurement. Because of a centralized procurement, I am getting very competitive rates, which even government e-market GEM portal cannot even give me that offer. I'm getting a very centralized. I'm doing a very centralized procurement of all the drugs, in which the quantity is huge, so that the supply and the payment is on a very prompt basis. So the suppliers are happy to do business with the TNMSC because of the assured payment on a timely manner, and the rates are very competitive. And earlier there was supply by dealers. Now there is supply basically by manufacturers and the direct importers, which means that the quality of the products that are being delivered are taken care of, and also it ensures that the service or the after sales service aspect is also being taken care of by the actual original manufacturers. Earlier, with respect to the drugs, it used to be in loose forms in bottles. Now it is in strips and blisters with the logo of Tamil Nadu and not for sale outside government hospitals. This ensures that there is no pilferages in our system. So there is effective and systematic quality control. Different rates was there for hospitals. Now there is a uniform rate for all the hospitals. Payment used to be from multiple sources earlier. Now payment is from a single source. Rate, as I said earlier, it were higher, and now it is, since it is in a bulk purchase, rates are very competitive and cheaper. So I would like to thank you all for again listening to this presentation, and this is all about TNM. So we have been joined by our Health Secretary sir and PDT NHSP ma'am. So I was just finishing my presentation about TNMSC. So any doubts or any clarifications with respect to the TNMSC model, I'm all ears. Thank you.
In the interest of time, we'll take 2 questions from the audience. Only 2 questions.
Yeah. Sir, good morning. And thank you for your extensive presentation. No doubt TNMSC serves as the role model for the whole nation. I just have one question. Are we keeping in trend with the drugs that are available at the private, because in private we get medicines which have in combinations, in mixed combinations, and those are especially useful for pediatric children, because instead of prescribing 2 or 3 medicines or syrup together, in private we get in a single bottle. So are we keeping in trend with are we following the trend that's being followed in private? And the second is the taste of the syrup. The flavored syrups are available in private side for pediatric child. So I myself have tasted all the syrups from TNMSC, and I have given to my own children, but they prefer the taste of the syrup that's available in private. So what is that's preventing TNMSC to get into that? Thank you, sir.
Yeah, interesting question. Nothing is preventing TNMSC from adopting any new, available products in the market or any other new innovations that private sector is trying out. In fact, we are actually, in the drug committee, which I mentioned in my presentation, the drug committee takes care of all the top selling drugs in the private sector. And we see that whether these drugs, we have in fact taken analysis of the top selling drugs in the private sector in the last 2-3 drug committee meeting, and we have checked whether these drugs are available in our essential drugs or specialty drugs. If the top selling drugs are are not available in our EDL or specialty, then we include it. Because always, private is always ahead of the government sector in terms of adopting newer interventions or new technologies, which also we make sure that it is being adopted. So we do that. And any cosmetic changes, like let's say maybe the taste or maybe any suggestions with respect to the packaging or anything else, it all happened on an annual basis. I can give you an example wherein which there was a feedback from government and also from the practitioners about the iron syrup which is being given to the pediatric cases. There was a suggestion that a dropper needs to be included. So in this tender, we have changed the specifications that for pediatric iron syrup, we will have a dropper facility. In the bottle itself, there will be a dropper, and the color coding can be changed. So all these we are very receptive in accepting all these suggestions, and we can regularly improve that. We are doing that also.
Yes, sir. Regarding the flavor and the combination.
Yeah, combinations in our EDL, we are not accepting any combinations as of now, because if we start accepting combination, there is going to be a wide variety. Right now, we have maintained our list of essential drugs to 322. Last year it was 348. Now it is 322. Combinations meaning that each practitioners can have their own
combination
preference.
We can't do in public, sir.
Sorry?
Combination is not allowed by NHS. It is not for the public. We have to, as a doctor, we have to do the combination.
Okay.
Right. Sir, I am from the day 1 of TNMSC. I was working in DPH, DMS. I am Dr. Amudakumar Ramasamy from Madurai. At that time, from Purnalingam, our senior professor, Sir Purnalingam has been started this. We have done 145 beds for only 20 lakhs. Now TNMSC is giving extensively very good. But my thing is, we can still do more if we ask us to be cooperate with your advisory. We are ready to do, because in my hospital, it is SKG hospital, my father's first batch of Marimedi College, he has not allowed me to come to Chennai when I finished all my 12 categories of critical care by US. When I've been in government service, I have to do only 1 week is permitted to get the training. So by 2007, I got my severe psoriatic arthritis, I couldn't do. At that time itself, there is only 300 drugs available in TNMSC. In my hospital, I am having 1,500 molecules to run a hospital in critical care at par with any of the persons in Chennai or any other corporate hospital. We are doing for the CMC scheme, which has been approved. And that I don't charge for any CP child. I have not charged for any pediatric, because I am an adult critical care. In that itself, we need 1,500 drugs. But you see, our TNMSC, even including DME, we are having only maximum 500 molecules. What about the other 1,000 molecules, sir? Because I am the person who is doing 220 cases per month, helping the poor, and we have screened more than 2,500. It's not an ordinary one. In the whole world, I have been checked. 2,500 villages we have been screened, and we are given even for the respiratory.
Please come
Sorry,
to
ma'am.
that question, sir.
That's why I am requesting for all to improve our quality.
Hello.
Single
Yeah.
molecule itself, 1,500 molecules are available, sir.
Sir, the list of drug, there is a mechanism which is in place. All the treating doctors can give the recommendations of what all drugs needs to be added to the EDL or the specialty drugs through the HODs. That is why I explained in the presentation also the drug committee meets annually, where in which the representative from all the directorates are there. So any request for addition, deletion, modification or any request with respect to the existing drug list is being entertained by the drug committee through the HODs. And as far as the number of drugs are concerned, not all drugs are required. The drugs which are required, there are alternatives for the same. For example, I am having one particular drug for, let's say, cholesterol. I need not empanel all the drugs for cholesterol. Okay, so there is one particular drug which is out of patency, non-branded generic drugs. The TNMS's principle is that we procure only non-branded generic drugs which are out of patency, and that is being included in the list.
I am asking for the emergency drugs, sir, because there is no bisoprolol, there is no perindopril in our TNMC, sir. That is the most basic for any CCF patient. So it will alleviate to longevity, not the patient. That is the most important thing. That's why
Okay,
I
let
requested,
the
sir.
directorates give the recommendations, because the doctors, if we keep on asking, 10 doctors will give prescriptions to each medicine, different 10, maybe 10 or 15 drugs. So that is what I'm saying. There is a system which is in place. Any request for addition of, let's say, your drug, it should come through the directorates. The directorates DPH, DME or DMS are there in the drug committee, and that will be included.
In this PLIA, I requested our HRs also to include the private sector for the advisory board, 1 or 2, so that we can help to get the things easy to the poor, sir. Thank you.
Sure, sir. That we do also. We consult the private sector for any other further recommendations.
Thank you, sir. Now I request our OSD ma'am, Dr. Chitra ma'am, to felicitate our TNMC MD, sir, with a memento. We will move on to the next session, which is a plenary on rational prescribing or antimicrobial resistance. I welcome Dr. Daniel Van Rende to deliver the presentation, and he is a medical officer, Division of Healthcare Quality Program, CDC USA. Welcome you, sir. Dr. Van Rende has worked with CDC as a medical officer since 2015, supporting many countries, Africa, Asia, Caribbean and Middle East. Since 2018, he has worked to support efforts to build sustainable capacity to prevent, detect and respond to healthcare associated infections in India. He supported India in building capacity to prevent and respond to healthcare associated infection. He has many national and international scientific publications to his credit. He is also the principal investigator in multiple international research projects. Over to you, sir.
Thank you for that kind introduction, and thank you for the invitation to speak. On behalf of CDC as a public health agency, I want to congratulate and also recognize each one of you here for all of the hard work that you do in public health. Being in public health isn't always very easy, and to do it for 100 years is quite an accomplishment. Today I'm going to speak on rational prescribing. I do work in antimicrobial resistance. I've been working with NCDC and AIMS and ICMR and building surveillance systems, laboratory capacity. And when I was asked to speak at this conference, you chose antimicrobial resistance and stewardship. And that's very commendable. As a forward-leaning state, this is probably the more difficult of the antimicrobial resistance topics to really address and move forward in. So I appreciate that you've taken on a challenge. What we do know is that when we use antibiotics, it causes resistance. It causes it in the short term and it causes it in the long term. This is a group of studies that were looking at E. coli in urine and found that resistance developed in 2 months and then was persistent in 12 months. The same thing was found in respiratory bacteria. So we know that using antibiotics is not something that we take lightly. We also know that we tend to overuse antibiotics. And if I ask you if you knew somebody or knew if you tended to overuse antibiotics, many of us would probably raise our hands and say at some point, I may have not used it appropriately. I may not have prescribed it appropriately because I had fear. I didn't know what the data was. I didn't know what was going to happen to my patient. And we recognize that, but we also recognize that there are reasons why it's difficult to do that. And so these are some studies that have been done which show that there are many barriers to doing good prescribing practices that happen in the rural setting. They happen in the hospital setting. They can also happen in the intensive care unit or here in a transplant setting. So we know that there are lots of barriers to proper prescribing. And you are fortunate that many of these authors come from your state and have these already kind of understood. And that's a very great starting point, is to understand what your barriers are. We also recognize that there are opportunities and some building blocks for doing appropriate stewardship. And this is a study that was done under ICMR and AIMS, where they point out where they have capacity and where they still need work. If we take on stewardship, we also recognize that we're taking it on not only for ourselves, but also for our children, for our friends, for our family. Because if I get a drug-resistant infection, if you get a drug-resistant infection, you might stay in the hospital longer, you have a greater chance of passing away. And we may not be saving that for our children. We also may result in death. I think one of the things that gets missed often in using antibiotics is that we fail to recognize that they themselves can lead to adverse outcomes, even death. It could be simple, an emergency room visit, GI illness, disruption of the microbiome, and other things. But using them is not something that we should say that it's like candy or water, that it's not something that has consequence. I think the good news is that when we look at if we are responsible, there are things that can happen. So in this study, which is a meta-analysis, a group of studies that looked at when we de-escalated, when we took appropriate laboratory tests, and we gave a lower antibiotic, a first line instead of a second or a third line, then we were able to improve outcomes. Also, if we just adhere to guidelines, we found is a reduction in the relative risk of mortality, which may be surprising to some, to know that if you do use antibiotics appropriately, you actually are improving outcomes, not making outcomes worse. An example from South Africa, which is limited in its resources, using pharmacists and changing their system. And in changing that system, they were able to decrease use of antibiotics. And over time, many, many years, decrease consumption. And I think that's an important point to point out, is if you embark on this, if you choose to take it up, it's not going to happen in 1 year. It's going to take 3, 4, 5, 6 years before you'll see a sustained trend. But we know that if you do that, you can make a difference. In this study that came out of Scotland, when they had sustained reduction in the use of antibiotics, their MRSA prevalence decreased, which is methicillin-resistant Staph aureus, which is a common surgical site infection. And why should you care? I mean, 54 to 37, I mean, why would we care about that? So in a meta-analysis of studies that had MRSA patients, and this was around hemodialysis patients, there was an increased risk of mortality. So would rather go to a hospital that has a lower incidence of MRSA than I would to a hospital that had a higher incidence. And here's another example. We have Hospital 1, Hospital 2. Hospital 1 does stewardship, Hospital 2 does not. In the hospital that does stewardship over a 6-year period, they had a decreased risk of E. coli being resistant. Would you rather go to Hospital 1 or Hospital 2? But I'll also point out as a fundamental that stewardship across these examples isn't happening just because one person is making a change. It's the system that changes, and the system change requires leadership. The system change requires someone to put personnel that are dedicated toward making that change. When we look at antibiotics, we also have to say, where can it be used appropriately? Antibiotic stewardship is also about making sure it's used correctly. So in this example from India, appropriate use of antibiotics to save the lives of children has been very effective. So it's not only about not using the antibiotics, it's making sure that you're putting your people and your providers in a position with information that when they use antibiotics, that they're saving lives. This is an example from Barbados with Corey Ford, who I've had the chance to work with. And in this hospital, there was no stewardship program, but there was large outbreaks of resistant Klebsiella. Many patients died. There was a lot of medication that was being used. It was felt to be inappropriate, and Corey and his team said to the administration, can you please give us a chance to have a stewardship program? Can we have someone with specialty in infectious disease? Can we have a pharmacist? Can we use our infection control nurses? And when they did that, and when they went in as a program, they were able to reduce the number of antibiotics. They were also able to save the hospital a lot of money. 65% of their antibiotic costs were coming from these antibiotics. This same phenomenon of decreasing costs was done over in Kerala at Amrita by Sanjay Singh and his team. And what they also found is they had to institute a program whereby a stewardship committee was given the opportunity to make interventions which then decrease costs. Without actually empowering people, this would not have happened. So if you take this on, if you empower people within a hospital and create systems that make it better, you can also save yourself money in addition to improving patient outcomes. And again, another study. Looking at antibiotic interventions to improve antibiotic use. Seeing that it decreased the time in the hospital. So again, a little bit counterintuitive. If you have better stewardship, you may decrease hospital stay. You may decrease length of stay, but you don't increase mortality, which is always a fear that I'm just going to make, my patients are going to die. So we know that there's antibiotic resistance. We know that people are affected. We know that it's persistent. We also know that change can happen, but it takes time. We know that personnel are needed to make these changes, and you have to change the system. And if we look at stewardship as a practice, making sure we're giving the right drug to the right people at the right dose at the right time, that requires some intervention. And at a state level, there are some simple things that you can do, that any state can do, that any country can do, that don't cost a lot, but require organization and require leadership, development of committees with clear terms of reference, with clear objectives that have accountability. And once you move past that, you require a little bit more resources into doing some surveillance work, infection prevention. And this chart here from this reference that CDC's put together is a place that you could start. At the facility level, the WHO has a nice reference with core elements of stewardship, but it all starts with leadership. I've been working in public health for a long time, and I've never seen meaningful change, sustainable change happen without leadership. At the facility level, at the state level, or at the national level. And that leads to appropriate activities for your environment, starting somewhere, having some kind of systems where there's reporting and data that gets fed back to leadership to know progress. Are we making a difference? Are we having sustained change? And this toolkit is freely available for anyone to use. Encourage, either at the facility level or at the state level for you to have this information. Contains ready-made SWOT analysis, and this is also from the CDC guidelines on interventions that can be done with different resources. So if you have a pharmacist, you can do some things. If you have a data collection system, you can do other things. And starting somewhere. So these are the basic interventions that are from this document. But just to point out that we have to start somewhere. If you want to do stewardship, you have to at least take one step forward. And that is public health. We always have to take one step forward and then another step forward. And these are steps that you can take. And although I was talking mainly around stewardship, we also recognize that stewardship in and of itself isn't effective. I can't just treat and make sure that only the antibiotics are given appropriately. What we also have to recognize is that it's incumbent upon us to stop the infections from happening in the first place with infection prevention control, with infection control nurses, with training programs for those individuals. That appropriate vaccines, appropriate diagnostics has been talked about as appropriate. If you don't know what you're dealing with, physicians don't have access to laboratories, then they can't tailor their antibiotics. And of course, the environment, having appropriate water and sanitation and hygiene. So having a holistic system, and I know that you may be involved in state action planning for AMR, and this is something that as a holistic approach you can make a plan in order to move forward. So again, I commend you on your work as a public health department. I admire your work, having been here in India for a number of years. And if there's any way that we at CDC can help, we stand ready to go shoulder to shoulder with you, knowing that public health is a commitment that's made across countries.
Thank you for the nice presentation, sir. Just one question I would like to ask and take help from you. Antibiotic prescription involves certain self-autonomy, and it also involves self-discipline. So it involves all the practitioners when they write antibiotics. So when we try to bring a system in health facilities to make some regulation or to make some corrections, or there are good protocols or good practices across the globe which can be tried. starting from primary, secondary, and tertiary.
So you ask a very difficult question. There's no ready answer for you just to say that I can point you and say this, 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 and this. The CDC document has some guidance on that. Every facility has their own capacity. So every facility has maybe some expertise with infection prevention, and pharmacist or no pharmacist has an infectious disease doc, no infectious disease doc, somebody who's interested in it. It may be that patients are getting it outside and bringing it in. So it's a very complicated question. I think that to approach this question, what I would do is you have to examine your own system and say at your PHC level, at your CHC, district hospital, and what capacity do you have, and then to develop a plan. And there is some guidance out there for that, but a lot of it kind of depends on what resources are available. Monitoring and audit requires personnel. A pharmacist to actually go and audit what's being used requires personnel. But you need to have some kind of system, because you're right, autonomy and one person just making the decision is not effective. And from the studies that I've shown, whenever we give physicians complete autonomy without any oversight, you're going to have a system that continues to overprescribe antibiotics. Both here and in the United States it happens, and other countries.
One final question. Okay, thank you, Dr. Daniel, for enlightening us on one of the current areas of concern and the interventions we need to undertake to overcome it. Thank you. I request our Joint Director, Dr. Nirmal Sen sir, to felicitate the speaker with a memento. Sir, please. Thank you. We'll move on to the next session. It is again a plenary on support of CoWIN in India's fight against COVID-19 pandemic and repurposing this technology through digital public health goods for universal immunization program, for which I welcome Thiru Abhimanyu Saxena, Officer in Charge, Health System Strengthening, UNDP India Country Office. Welcome you, sir. He is an engineer who has specialized in business administration, has completed sourcing and supply chain management program. He joined UNDP 8 years back as subject matter expert for implementing EVIN and CoWIN process flow dashboard reports along with approval of Ministry of Health and Family Welfare. He is the first nodal person of National Cold Chain and Vaccine Management Resource Center, founded by Ministry of Health and Family Welfare in 2013. He has contributed to national assessments and modules related to cold chain management. Over to you, sir.
A very good morning to all of you. Honorable Health Minister, sir, Honorable Secretary, sir, Dr. Soumya Swaminathan, Madam, all the dignitaries and all the participants. I would like to start with first congratulating Directorate of Public Health and Preventive Medicine, Tamil Nadu, for completing 100 years. I think this is a humongous achievement, and we all are so proud of. DPHS is not just contributed and contributing towards the health status of Tamil Nadu, but I think this is the role model for all other states. So I would like to start my presentation with just an overview on how the platform for CoWIN evolved, what were the guiding principles, how we are now leveraging this technology to taking it forward, and more importantly, the G20 presidency of India and how India is emerging as a leader for digital public good. So just to start with the background, in 2014, Government of India and Ministry of Health and Family Welfare realized that there are certain challenges in terms of managing the immunization supply chain. That includes lack of real-time visibility, storage temperature monitoring all the time, non-standardized stock keeping, multiple areas, multiple health facilities were using multiple ways to track the record. Mismatch between the demand and supply. We track consumption, but we were not able to supply based on that. And India is a self-procurement country for vaccines. Vaccines are procured centrally. We are procuring more than 700 million doses every year, and we need to have the end-to-end transparency in place. And then we have multiple levels of supply chain, starting from national stores to state stores. Then we have very large states like Tamil Nadu, which has so many regional stores. And then we have blocks stores, we have primary health center and community health centers. So we started even to answer 3 critical questions. Where are the vaccines? Are they stored in adequate quantity? And are they stored in recommended temperature? So even how it works is that we digitize the record keeping of the immunization supply chain by empowering the last mile cold chain handlers with the mobile application, wherein they can perform their transaction like issuing stock, receiving stock, doing the editing, discarding if required. And then we installed a temperature logger, which is SIM enabled or Wi-Fi enabled, across all the temperature monitoring storage cold chain equipments to understand what is the exact storage temperature and get this temperature data on real-time basis. And then once these 2 tools starts talking to the cloud server, which is based in India, the program manager at the district level, at the block level, at the state level, they can start looking at the data and start taking data-driven decision making based on this. And of course, this entire system is completely open source. So this is a slide just to show you that how EVEN is evolving from last 6-7 years. We started with basic Java-based phone, and then over the years, we evolved the application. We included online indentation. We connected the government medical store depots, and now it's a new application with all the features. And 29,000 cold chain handlers are using one platform to do the data entry. And again, talking about the scale and the impact assessment, I think there was one impact assessment done by Ministry of Health in 2018, which shows that over 90 million vaccine doses were saved, and the return of investment is 2.91. So it means every $1 we invest on EVEN, it gives a return on investment of $3. So as previous speakers were also claiming that these are not actually expenditures, these are savings which we do if we invest in the supply chain and the digital health areas. Also, we have seen 75% reduction in stock out nationwide. There's a dedicated cadre for vaccine logistics and cold chain management. And it is seen that there is a 99% adherence rate, which means across the country, we have more than 29,000 cold chain handlers. So every week, out of those 29,000, 99% of them are performing the entries in time, and we have 100% users on board. The system captures more than 7 million transactions every month and 20 million temperature data, which is we are capturing every month. So now in 2020, when the government of India started planning for COVID vaccination, there was one guiding principle that we have to do the individualized digital tracking of the COVID vaccination. And it was not an easy task because we are talking about more than 1.2 billion beneficiaries? Can we actually register all of them? Can we actually capture their data, capture their vaccination status? So those were certain guiding principles, which includes there has to be a digital acknowledgement of every vaccine dose administered. There has to be dose interval maintained, like 28 days or 3 months as advised by the NTAGI. We have to adhere to that. The consistency in the vaccination schedule has to be in place. The verification and tracking mechanism of each dose administered and identify where it was administered, on which date, by which vaccinator, all those details has to be there, because we have to capture the AFI data also if that happened. And then again, talking about guiding principle, it has to be equitable and inclusive. We have a country with so much diverse population. Some people have authentic photo ID, some don't. Some are in prison, some are in asylum. We have to vaccinate everybody. And the system has to be able to be inclusive enough to capture each and every vaccine dose administered. The other guiding principles include, of course, that this has to be single source of truth. And we are thankful to all the states and UTs, including Tamil Nadu, that they do all the transactions on time within the system, so that migration shouldn't be a problem. So if somebody from Coimbatore traveling to Palakkad, it doesn't mean that somebody in Kerala should not be able to pull the record. The whole idea is that even if a beneficiary is traveling anywhere in the country, from Tamil Nadu to Kerala, Kerala to Tamil Nadu, the healthcare worker should be able to pull the record, check the vaccination history, and able to vaccinate them. And of course, there has to be a scalability, and this was one of the key aspects which Honorable Prime Minister said, that we need to ensure that the system should be scalable, should be able to take the load of 1.2 billion vaccination now. So again, in terms of the core functionalities, we provided blended registration. If you can register yourself online, if you can book an appointment online, fine. If not, you can walk in. Healthcare worker, the common service centers will help you. It will help you to track the vaccination. You will get the SMS and other alerts as and when your vaccination is due. There's very convenient slot booking from the system. You will get the instant digital certificate based on WHO protocol, which can be, which is accepted worldwide, the COVID certificates with the QR code. The mode of registrations are multiple as per the convenience of the users. We have very simplified access and with very minimal data inputs. You need not to fill lengthy forms to get vaccinated. You just have to enter your name, gender, year of birth, and that's it. And of course, the photo ID to do the data duplication. So we are very proud to say that till date we have administered more than 2 billion doses, and India is a role model for the entire country. And thanks to the strong health directorate like Tamil Nadu, we have administered more than 1.2 billion doses for first dose, more than 940 million second dose, and as of date, more than 170 million precaution dose. And CoWIN has data of more than 1 billion citizens now which are registered, and which is like 85% on-site and then 15% online. So it's not like you have to be very tech-savvy to get registered. Our healthcare workers, the cadre is good enough to register the beneficiaries. Again, very quickly, just to walk you through the data, more than 74% vaccination happened in the rural areas, and nearly 70% of doses were administered in the rural areas, the rural COVID vaccination centers. And we also have a dedicated COVID helpline, and more than 9 million grievances has addressed so far from the COVID helpline, and as well as from the raise an issue section if you want to make certain change in your certificate, if you want to add passport, if you want to do any other update. And now moving forward, leveraging this technology, Ministry of Health and Family Welfare is all set to introduce UVIN, which is the universal immunization module of CoWIN, wherein this strong database will be utilized to vaccinate pregnant women and newborn as per the routine immunization schedule. So after EVIN and CoWIN, UVIN will be started in the first quarter of 2023. Already we have identified 65 pilot districts, including Tamil Nadu also. We have identified 2 districts. And why the key advantage includes, of course, we have the database of around 1.1 billion beneficiaries. We have more than 250,000 vaccinators already registered, very well familiar with the workflow of CoWIN, and can do it in routine immunization also. There's a very technically sound architecture. On 1st of March and the first week of March, it was close to 1.2 billion hits per day, and CoWIN is the second most searched word on Google in 2021 and 2022. So again, you require a very sound and technically strong architecture if you want to have this kind of database in place. And of course, the CoWIN and EVIN workforce, which is there in the country, more than 700 healthcare workers are there in the form of senior project officers, vaccine and cold chain managers, who will be instrumental in scaling up this program. So UVIN will include a module of healthcare workers wherein they can plan the session. It will include a module for citizens where they can register or they can walk in. It will also have a delivery point module, and that will be most important part, that we should be able to register all the delivery outcome and newborn, and then we can reduce the 0 dose target, we can reduce the left outs once we have the data with us. We'll also have a vaccinator module, very similar to CoWIN. And moving forward, we are tapping a mobilizer module also. This will include ASHA workers having an application wherein she can see the routine immunization sessions and VHNDs happening in her area, and also the due list generated from the system, that who all are there to get vaccinated, and also she can facilitate registration from the same application. So if I talk about the overall learnings, I think in terms of governance, the strong government ownership helps to implement the system in a right way. Having strong standard operating procedures in place is very important. Digitization and technology is just an enabler. There has to be SOPs and skilled workflows in place to do that. There has to be regular capacity building and review mechanism in place. And dedicated and skilled human resource, of course, is very important. And if I talk about the technical learnings, we have seen a journey of digital health in India while implementing EVIN and CoWIN. In 2014, our concern used to be that can a healthcare worker use this mobile application, or are they well versed to do that? But here now the things have evolved. We are not talking about just the traditional database, but we are talking about the big data architectures which are interoperable. Authorized access to security, audit and compliance to ensure that the data is in India, it is secured. And if you are talking about electronic health record, we follow all the security compliances which is important for the privacy of beneficiaries. Also, from licensed products to open source product, all the systems are now considered as digital public good. And we are thinking, taking it forward to the world, offering this to the world. And moving forward from data triangulation to API-based interoperability. So all the systems are with open API, any system can talk to any other system, and that's how we envisage the future of digital health in India. So, as India's leading the G20 presidency, and if we talk about the health agenda for 2022-23, it includes the health emergencies prevention, preparedness, and response, wherein the digital platform will play a very important role, just like COVID. Strengthening the capacity to manufacture and having a make in India kind of a solutions which have effective quality and which are affordable. And of course, the digital health innovation and solution to aid universal health coverage and improve healthcare services. And I think just to update you that now when we are talking about UVIN, we will adhere 100% to the Ayushman Bharat Digital Health Mission protocols, which says that one country should have one directory for the beneficiaries, what we called unique health ID and ABHA ID, which we'll integrate. One directory for all the healthcare facilities, what we called HFR for public and private, so that each system can talk to each other. And healthcare professional registry, three things. Every healthcare personnel will get the healthcare professional ID from ABDM, and once we link all of them, then all the doctors, all the healthcare facilities, all the beneficiaries will have one ID, one kind of directory which can be referred by all. And that's how we are building UVIN and other digital health systems. So I'll conclude by saying that CoWIN is a strong case study to showcase how India's leadership in digital public good offers unique lessons and digital public solution, and that can be leveraged, that can be adopted by countries worldwide. So this is my last slide. Thank you so much for your patient hearing, and I'm open to all the questions. Thank you.
So any questions? Yes. Thank you, sir, walking us through the achievements of CoWIN and EVIN and on the scope of and benefits of UVIN portal. And now I request our additional director, Dr. Shekhar sir, to honor the speaker with the memento. Thank you, sir. On behalf of the organizing committee, DPH ICON 2022, I take the privilege to welcome our Honorable Health Minister, sir, for the day 3 of the DPH ICON 2022. And also I welcome our respected Health Secretary, sir, and Thiru Lalvena IAS, sir, our Commissioner Food Safety, and Shilpa Prabhakar Satish ma'am, our Mission Director NHM, and Dr. Uma ma'am, our Project Director TNHSRP. We welcome you wholeheartedly for the prestigious event, ma'am. Now we'll take 10 minutes break and request all the delegates to be back by 12:10 p.m. Thank you. Please reassemble by 12:05 to 12:10. We'll have a session by our respected Health Secretary, sir. I request all the delegates to be back in 10 minutes.
Vinay. Can start the session. Huh? Kind request to all, we need to start the session, please. Request all to kindly assemble. தயவு செஞ்சு எல்லாரும் உங்கள் இடத்துல உட்காருங்க. செஷன் ஆரம்பிக்கணும் ப்ளீஸ். Request everyone to please be seated.
Dear participants, we have planned our valedictory function around 3 p.m. So I request all of you to please be seated so that we can finish the sessions on time. Please be seated. So we welcome Dr. S. Ganesh, IAS Sir, Commissioner, Indian Medicine Homeopathy, and through A.R. Gladstone Pushparaj, IAS, Chairman MRB, for this occasion. May I have your attention, please? I request the participants, please be seated. We are about to start the next session. So we are moving on to the next session. Now we have a plenary session on Tamil Nadu Model of Public Health, Role of Public Health Department in Tamil Nadu Health System, a Centenary Journey. Please join me in welcoming our respected Health Secretary Sir, Dr. P. Sendil Kumar IAS sir for delivering the presentation. So, sir became an IAS of the 1995 batch after completing his MSc Agriculture. He started his career as a general manager, worked as a sub-collector in the Viluppuram district, and worked as director of Tamil Nadu's government, Tamil Nadu government's Women's Welfare Scheme, and he is a former director of TNSTC and currently principal secretary to the government of Tamil Nadu Health and Family Welfare Department. Above all, sir is a very down-to-earth person, approachable and leading our department and guiding us always with a smiling face, whatever challenges we face. So, we welcome you, sir.
Slide change only.
Open.
Honorable Minister, other distinguished speakers, dignitaries and friends, good morning to all of you. The journey of Tamil Nadu public health for more than now 100 years. அது பொறுத்தவரையிலும் பார்த்தோம்னா நம்ம because most of you are part of the public health system, so you are familiar with the challenges as well as its journey. Many of you are with the public health system for quite a long time. So if we see the evolution of Tamil Nadu public health cadre as well as system, we need to study the Indian model in different states and how it is different in Tamil Nadu, as well as what are the challenges that we are facing, so that how we can evolve ourselves into a really fruitful model, so that the intended benefits reach the general public. So if we see, as in many other emerging economies, so India also faces this maternal child health challenges, communicable, non-communicable diseases, which needs to be addressed through the public health system. So this, coupled with rapid globalization as well as urbanization, has posed its own challenges. So unlike in the past, where most of our population used to live in the rural areas, now almost 50% of our population lives in the urban areas. This is in contrast to the rest of India, where still majority of the population are living in the rural areas, whereas few states like Tamil Nadu, Maharashtra, they have a almost 50-50 population ratio who reside in urban areas. So urban areas has its own challenges, so the density is high, the spread of disease is more rapid, so it has also led to a lot of lifestyle changes. So all this has an impact on delivery of public health services. So for example, every one of us know the challenges we had faced in COVID-19. So whatever was reported in one country, within a matter of 1 or 2 weeks, it has spread to every nook and corner of the world. Despite so many restrictions put by many countries, we had seen that it had spread rapidly. So it has its own challenge. So while globalization, urbanization has brought many good things, it has also brought challenges to the public health. And similarly, for example, dengue, which was widely prevalent in tropical areas, now we have seen that this year France has reported surge in cases of dengue. So because of climatic changes and other related issues. So the public health issues continues to evolve, not only here, but throughout the world. So we need to make ourselves suitable so that we address these issues. So
the public health has a significant role in, as far as India is concerned, in maternal child health, prevention of communicable diseases. Now, non-communicable diseases has emerged as a major area of mortality, and mental health is again an important and neglected area. So, all this poses a challenge. If we see the public health cadre, we have a dedicated public health cadre which is widely appreciated by many administrators as well as this medical professionals who are related to public health. So if we see the background, so while the Britishers who are here, they established curative hospitals. For example, our Madras Medical College, which started from a small army hospital, so it is more than 300 years old. Whereas compared to that, our public health establishment and institutions are relatively new. It started with the Public Health Act as well as this pandemic in the early 20s. It has resulted in establishment of this public health as a act as well as institutions to take care of the public health. The Britishers were worried about protecting the Europeans as well as army establishment, so that their interest as well as the life is at safe hands. So they gave a lot of importance to the sanitary aspect as well as environmental sanitation. So because of which this Tamil Nadu Public Health Act, erstwhile Madras Public Health Act, was enacted, which helped the state in engaging sanitary inspectors and other environmental sanitation workers, which helped in prevention of communicable diseases. So subsequently, if we see at the national level, there was a committee set up by the Government of India, Joseph William Bohr Committee, which was actually basically a health survey as well as development committee. So they had studied all the various institutions, and then they suggested a number of short-term things as well as long-term initiatives. So many of the short-term things were basically for establishment of public health, primary health centers, as well as in the long-term secondary care institutions, as well as even tertiary care institutions at the district level for curative aspects. So they also suggested postgraduate program, and also they also suggested this starting of MBBS, changeover from licentiate system to MBBS, so which we still continue to have. And then a committee also recommended starting of this sanitation certification program. So this committee had a major influence throughout India, and similarly subsequent to the independence we had Jungalwala Committee, so which was also a committee which was set up to study the existing institutions and also integrate various health services. So this committee basically suggested unification of health cadres. So previously, many of the states had medical services as well as public health cadre, two different cadres. Primarily, these medical services were manned by clinicians, and public health cadre were by those who were in charge of environment and then environmental sanitation aspect. So because of this committee, many other states which had a separate cadre, they had merged these cadres, so which almost resulted in eclipse of public health cadre in most of the states. But unlike most other states, I think the administrators at that time probably had a vision, or probably at that point of time they did not have a major funding from Government of India, so the state government could take independent decisions, so which resulted in Tamil Nadu keeping the public health cadre and also strengthening it, so which has resulted in continuance of this system, and subsequently many of the continuous the state government has strengthened our public health cadre, so which has resulted in one of the better maintained public health cadre system in the country. So coupled this along with the launch of various national programs, such as separate programs for eradication of malaria, filariasis, TB, smallpox. All these were, in most of the states, were implemented by the medical services, basically the clinicians. But since we had a separate cadre and then separate system, so it was better implemented. So the basic aspect was that though the committees had a good intention to establish and then integration of medical services, this resulted in almost elimination of public health cadre and from most of the states. So, and this, apart from this, earlier during 50s and 60s, the public health engineering, what we call water works, were with the public health department. So these were also looked after by them. So, but subsequently during 60s and 70s, most of the states, they established separate water supply management system. So Tamil Nadu also had established water supply and management system both for rural and urban areas. So we have established Tamil Nadu Water Supply and Drainage Board and also Metro Water in Chennai and metropolitan areas. So it looked after this water supply aspect, sanitation, sewage, both in urban areas and rural areas. So in 70s and 80s, it expanded rapidly. And then, but in retrospect, we should say that this was a good initiative. Had it continued with the public health system, I do not know whether we would have developed this kind of expertise, because water management and then purification, supply, as well as collection of sewage water treatment, including tertiary care treatment. So we have come to a stage where even the sewage water is treated with tertiary care treatment and then made it into almost drinkable water. So we have established systems in Chennai metropolitan area. So all this would not have been possible if it had continued with public health. Now we have a separate people, but fortunately, even the TWAD board, we have representation from the public health. Director of Public Health is one of the board of directors. So in a sense that our interest in ensuring that safety of drinking water and then quality of drinking water, that issues faced in the drinking water are duly taken care of. And similarly, earlier sanitary inspectors were there. So these were primarily with the urban and rural local bodies. However, these were directly under the control of, almost dual control, under the control of public health department as well as urban and rural, urban local bodies. However, subsequently, this has changed. Now it is entirely under the control of urban local bodies, while the workers who were there with the public health cadre system, so now they have been redesignated as multi-purpose health workers. So all these changes have some positive as well as negative consequences. So that is, in a sense, if we retrospectively see, in respect of Tamil Nadu, it has done mostly positive impact on our healthcare system as well as public health institutions. So if we compare Tamil Nadu with many other states, they don't have, some of the states still don't have Public Health Act. So the Public Health Act, which was introduced in even during colonial times, so it continues to serve very important purpose. It empowers the public health officials with a lot of powers to control and then manage the outbreak as well as diseases. So that has been one of the very important parameters, even during this pandemic. Before we invoked the Disaster Management Act, then we first issued a notification under the Public Health Act. So as far as Tamil Nadu is concerned, so even we had introduced some mandatory vaccination program for going to the public areas. So the act continues to be very relevant, especially during a pandemic and also to minimize the outbreak. So that is one of the key difference. Then another is another important aspect is the public strengthening over the years, strengthening of public health cadre with promotional opportunities. So this has attracted a good number of interested personnel, so who are well versed in managing some of the communicable diseases. So, and they pass on the knowledge and then wisdom to the field staff. So if we see that in Tamil Nadu, Directorate of Public Health has a separate budget as well as cadre with the promotional opportunities. They start as municipal health officers and deputy directors in grade 1 and 2, additional directors. And apart from this, we also have entomologists, statistician, maternal child health officers, all this coupled with block medical officers, and also a parallel setup is there in the urban areas, so which there are some lacunas in the urban areas as far as municipalities and corporations are concerned. So all the disease outbreak, and similarly in municipalities we have sanitary inspectors. So and as a linkage between public health department as well as urban local bodies, we have this post of municipal health officers, city health officers. Fortunately, we have now the municipal and water supply department has issued a GO indicating creation of this municipal health officer post depending on the population. So which is a very, very welcome move, and it is going to further strengthen the linkage and also improve our public health outreach in the urban areas, because in urban areas we are facing lot of challenges because outbreak is frequent, and then the contacts are likely to be more because of the density. So all this is creating its own unique problems. So probably with the issue of this GO creating new municipal health officer post as well as city health officer post in our urban areas, especially these municipal corporations as well as bigger municipalities, will definitely going to further strengthen our public health cadre as well as this management as well as outbreak of diseases. So, but despite all this, we still face a lot of challenges in the public health, and if we address these challenges, this public health cadre will continue to grow and be a pioneering as well as institution for years to come, because from birth, whether from the issue of birth certificate till the death certificate, everything in between is managed by the public health. So while curative care is important, but if we prevent the outbreak, disease, then that is much more important. So that's why the countries all over the world have now learnt that preventive health is much more important. So now a renewed focus is being given to preventive health. So that is why even under the One Health initiative, wherein all, whether animal health, plant health, and then human health, and then climatic factors, all these have close relation with the preventive public health. So we need to strengthen that. So we need to continue training our workforce and also encourage our workforce. So new career paths are being created. So we need to, while it may be attractive if, because under the urban health institutions, urban local bodies, we have a separate system, municipal health officer, then sanitary inspector, and then workers who have to do the work. But in rural areas, it is the deputy director who controls most of the workforce. So while it may be, we may be thinking that it is better if they are also brought under our control, but each institution is having its own purpose. So we need to strengthen our coordination and then cooperation mechanism so that we work together as a team and then deliver results to the public. So the coordination with the urban local bodies is a challenge as well as an opportunity, so that we can redouble and then double our effort. And while we have very good public health, primary health care, as well as upgraded PHCs and CHCs in rural areas, in urban areas it remains our weak linkage. So we have disproportionately low public health institutions in the form of urban PHCs as well as health and wellness centers in urban areas. So fortunately, government has now announced setting up of 702 health and wellness centers. So these are under construction and will be inaugurated shortly by the Honorable Chief Minister. So with this expansion of health and wellness centers in urban areas, we are going to see a better public health outreach. So, and similarly, the issue of GO by the municipal and water supply department, creation of this public health cadre posts in urban local bodies, because we have 21 municipal corporations and number of municipalities. So all this will go definitely a long way in strengthening the hands of deputy directors who are in charge of the district public health. And with more and more people opting to study public health, and I think we have a bright future, and we need to strengthen this cooperation, coordination with other departments to achieve the objective. But we need to, as I have told earlier, we need to further improve our strengthening our training system, and we also need to document better, in a better way. We every day, every week, we are seeing so many outbreaks, whether it is diarrhea or even dengue or chikungunya, so many diseases, and each district and each institution, they deal with it in a certain way, which has brought them under control. So, but all these are not well documented for the future generation to use. So our public, in the 100th year, we should renew ourselves and then evolve a system for publication, research of this, our success stories, so that it is available for other states to follow and also for future generation to study and then utilize. And similarly, a number of false propaganda are also coming up in the social media with the reach and power of social media. Many people are still going out and then issuing messages against vaccination, against delivery in public health institutions. So all this will have a tremendous impact on our public health delivery. So we need to have a mechanism to educate the public about the useful purpose of vaccination, how this wrong information can have a bad impact on the society. All this, for that we need to have strong social media presence and IEC activities like in YouTube and other WhatsApp and other media. So as I have told earlier, from birth to death and many activities in between, public health has been with the public and has also contributed and protected people from many of the outbreaks, and definitely as long as humanity is there, then its public health role will continue to be there. So we need to continue to evolve and then develop mechanisms to face the challenges so we can deal with all emerging diseases, new diseases, as well as lifestyle changes, and serve the people of Tamil Nadu and be a model for other states and countries. So I once again take this opportunity to thank all the staff from VHN, SHN, the maternal child health officer, multi-purpose health workers, health inspectors, medical officers, DDs, JDs, additional director and director who have been with the Directorate of Public Health and who have helped this institution grow. All the best. And then for many more years, this institution should evolve and develop into a role model. Thank you.
It's really an immense pleasure to listen to Sir narrating the centenary journey of our public health system. We feel really honored, Sir. We will definitely take your suggestions, valuable suggestions, to strengthen our research and social media component and achieve many more milestones in future, Sir. Thank you, Sir. Now I request our OSD, Sir, Dr. Vadivelan, Sir, to hand over memento to Sir as a token of gratitude. Thank you, sir. Yes, sir. Thank you, sir. So moving on to the next session, it is again a plenary on role of Food Safety Department in ensuring public health by our Commissioner of Food Safety and Drug Administration Department, Government of Tamil Nadu, Thiru Lalvina IAS, sir. We welcome you, sir. Sir has completed his BA and MA Political Science, and he belongs to the Tamil Nadu 2001 cadre, and he has worked in various departments: Revenue, Rural Development, Public Service Commission, Administrative Training Institute, Vigilance, Health and Family Welfare, Transport, Urban Development, Food and Civil Supplies, Sports and Youth Services, Arts and Culture, School Education, Juvenile Justice, Welfare of Differently Abled Person. He currently serves as
presentation uploaded, sir. We have the presentation uploaded.
Okay. I can start.
It's presentation uploaded, sir. Shall we change the slides or can you adjust them?
Okay. Which one shall I press? Good afternoon to you all, Honorable Minister and Principal Secretaries of Health and Family Welfare Department and all the dignitaries who have attended this program. First of all, I want to say that I'll just make a very, very brief presentation and a speech, because on the look in their face and whoever is attending this program, all of you are aware that what is food safety and what is good food and what is not that good food. Only thing is that we'll have to practice, that's all. So I'll just want to make a very brief presentation on regarding the functioning of the department and what we are doing. And if you can give any kind of suggestion or any kind of improvement, we can discuss later on. So general first introduction is that food safety first, we have this Food Safety and Standard Act 2006. Basically, this Food Safety and Standard Act, on the one hand, it laid down the standard for articles of food, and the other hand, you try to regulate and manufacture, storage, distribution, sale, and import to ensure availability of things. So regulation basically means that the department is going to check it whether they follow the quality or not. Some of them, they were taking a sample and then giving to that food analysis laboratory to check it out whether they have that particular standard or not. So this is definition. Food safety means assurance that food is acceptable for human consumption. This is a very simple definition.
Then public health is the science and art of preventing disease, improving health of people and their communities. That is the basic definition of the act. Then Food Safety and Standard Act. Here, if we look at it here, basically, mainly one thing is that it deals with the regulation and enforcement, and the other part is dealing with the creation of awareness and promotion. So, ensuring food safety, preventing food adulteration, food poisoning, micronutrient deficiencies, and all these things. Basically, we are doing this, we are trying to enforce this first by ensuring that license and regulation. All that food business operators have to obtain either license or registration certificate. On top of that, we are taking a food sample, and that food sample has been analyzed in the food analysis laboratory. Based on that report of the food analysis laboratory, either we are taking to, if it is not unsafe or substance that, based on that report, department used to take a adjudication case or civil case, or on the one hand, and then this criminal case of placing before the judicial magistrate. And then the next thing is that this one is another promotion cases. We are doing this, department doing this Eat Right Campus certification, Eat Right Schools, Clean Street Food and Clean Fresh Food and Vegetable Market. What actually we've been doing is that FSSAI have the empanel audit. Those people will go there and audit it. Based on that audit report, what is that lacuna and what is the loopholes and what is that lagging behind, they are pointed out. Based on that, our people, there is another training empanel. Those people will give a training. And then based on that training, they used to make improvement. After that, there is the post-audit. If they clear that post-audit certification, then they used to submit the proposal for getting those certificates. Here is another way of this thing, preventing food adulteration and ensuring food safety. Periodic inspection have been done, legal enforcement by lifting sample, and if that sample is found to be substandard or unsafe or not fit for consumption, based on that laboratory report, the department will do either the production of filing a case before adjudication or filing a criminal cases. One way of doing is that we can give the, based on that health hazard of the thing, we can issue the emergency prohibition, sealing that food business operator, and then we can, department also used to do that compounding of penalty, imposing a penalty on those of violator of this thing. And then this is another prevention of food poisoning. Primary awareness to catering food business operator to ensure food supply in the place of cooking, sanitation and pest control measures, just to ensure that disease communication, communicable disease has not been spread. Then lastly, we have this, just to ensure that there is no micronutrient deficiency, just to avoid this thing, our department is putting up the promotion of the fortification of rice, milk, oil, salt and wheat flour. So as on today, all that government establishment, integrated child development scheme, and noon meal center and CM breakfast scheme, they've been provided with fortification of this food item. But as on today, it has not been mandatory so far. So we have to convince that private sector, those people who don't provide. Then basically, another way this thing is that we are trying to promote this, preventing the non-communicable disease. RUCO, repurposed use cooking oil, has been promoted so that people don't reuse their cooking oil again and again. And to reduce that consumption of sugar and oil in their daily diet, particularly this was important regarding this consumption of oil. Tamil Nadu is more or less a developed state among the Indian states. So per capita oil consumption is higher compared with the other northern states. So all of us have to put a little bit more attention to this oil consumption. Then high fat, high sugar, we are trying to create we're taking action to create awareness among this high fat, high sugar, and high trans fat oil also. So ultimately, I should say that this thing, food safety is a medicine. And basically, as a doctor, if somebody, people, particularly a food business operator, come before you to get any certification for this thing, for getting license, food license or other thing, please ensure that basically you try to ensure that you are checking that they don't have any communicable disease. During some of my inspection, I have come across some people or some medical certificate in that business establishment also. They are saying, most of the number of times they are saying X-ray result and all those things without mentioning whether they get a vaccination or not, whether they have communicable disease or not. They used to issue that medical certificate. So basically, from that food safety aspect, we are looking at that communicable disease, whether they have a communicable disease or not. Please ensure that it has not been done. It has been there. So with this, So with this, I conclude that thing. So food safety department play ultimately major role in primary prevention of public health by ensuring safe and food standard food for human consumption. So as our department have said that Unave Maruntu, food is medicine, that's all. Okay, thank you very much then.
Thank you, sir, for enriching us on the major aspects of food safety department and throwing light on a bit on the non-communicable diseases role of food safety. Now I request Additional Director Dr. Gerard sir to felicitate the speaker with a memento. Thank you, sir. The next session is Investing in Primary Health Care, a Step Towards Universal Health Coverage. I request our Mission Director, Ms. Tirumati Shilpa Prabhakar Satish IAS ma'am to deliver the speech. Ma'am belongs to the 2009 batch Tamil Nadu cadre. She started her career as Assistant Collector in Tiruchi District, Sub-Collector for Tirupattur Division, and Deputy Commissioner at Chennai Corporation, Executive Vice Chairperson for Industries Guidance and Export Promotion Bureau, Industries Department, Chennai, District Collector of Tirunelveli. She has been awarded Special Award for Effective Implementation of Plastic Ban and Digital Transformation Award in 2019. And she currently serves as Mission Director, National Health Mission Tamil Nadu. And ma'am is closely guiding us and supporting us, our directorate, in all our initiatives and efforts. Please join me in welcoming our Mission Director. Ma'am, please welcome you.
Honorable Minister for Health, respected dignitaries and the guests, it's indeed a privilege to be part of this historic moment and to share a few things along with you. Universal health coverage is indeed the primary responsibility of the government, as our respected Health Secretary detailedly explained on the importance given by the government to strengthen the primary health care. I would just continue to add on a few points to say how National Health Mission has been working towards strengthening public health and primary health care. As you all know, National Health Mission, the primary focus of National Health Mission has always been to strengthen the primary health care. If you see the major schemes that are implemented through the National Health Missions relate to maternal and child health, to address the challenges in NCD. So in all these things, we see that the focus is mainly on strengthening the primary health care. We have comparatively more number of schemes in this than in the tertiary and the secondary care. Now there is no doubt in the fact that we need to invest in primary health. Now, the very evidence that the more you invest in primary health will lead to a better society is Tamil Nadu, because even before we all could have this conference and talk about it, the state has had a very strong public health system, very strong community health structure. If today we have achieved the sustainable development goal in maternal mortality rate, and the latest report say we are around 54 per lakh deliveries. The whole credit of controlling maternal deaths should go to the community health structure. The robust system of monitoring the maternal, the mothers, the VHNs who are part of the system, it is through the close monitoring through the community health structure of the antenatal mothers. Today we are able to achieve the rate at which we are here is because of the strong monitoring of the mothers, the high-risk categorization, following up on antenatal checkups, and of course the secondary and tertiary cares are also strengthened to see that we give the best of the treatments and best of the facility for maternal and promote maternal health. Now that we have achieved good position in maternal health, I think the most important challenge before us for the state is taking care of the non-communicable diseases. And towards that, NHM formalized and the state government announced the Makkalai Thedi Maruthuvam, a historic and a very unique project, a unique flagship program, which has now become a model for the entire country. Now, this was an attempt to see that health, it's not just to provide health care at the doorsteps, it is basically to educate people the importance of checking on the non-communicable diseases, because we as a community are very reluctant to go to the health-seeking behavior is not that great, and we do not take NCD very seriously. We in this hall also, in this hall where all the, the best of the lot is here, I'm sure half of us will not bother about the control rate on BP or diabetes. This is something that is a greater challenge before us. So the state government has taken up this scheme where the main here, although we are providing palliative care at the doorstep, we do deliver drugs at the doorstep. The intention behind the scheme is to educate public on the importance of achieving a control rate in NCD. Because on one hand, we are strengthening our THAI centers, that is the trauma care centers. But we really don't want people to end up in the trauma centers. So we want people to have a control over the NCD, have efficient modification in their lifestyle and lead a better life so that we don't end up in the trauma care. So that is the motive with which MTM is functioning. And we also have very good programs like the school health program. Honorable CM has just launched this. And this program is to have 100% coverage of the school children, children going to the Anganwadis, children between 0 to 6 years. It is to identify the birth defects and see that they are given, the earliest interventions are given to the children. Now this is again going to be a very unique project in the state where early detection of be it anemia or malnutrition or any other birth defect is made at the community level and it is treated immediately. Now this is where interdepartmental cooperation comes into being. NHM plays a very important role in bringing together departments in achieving these results. And lifestyle disorders, of course, I mentioned. And one of the major interventions on which we are working is to promote mental well-being of people. It is, as a society, we have a stigma talking about mental health. We do not have people, although we have set up a lot of adolescent health clinics and district mental health programs are running, we see that the stigma attached to mental health is stopping people from talking about mental well-being openly. Now this is where we need to interfere. We can see that be it your NCD or you have any other issues, most of them are related to the mental well-being of the individual and of the society as a whole. So the community health workers, the VHNs are here, the medical officers are here. We all should understand that mental health, mental well-being is a component that has to be at every level. So we are working on, National Health Mission has provided us with a toll-free call center. The phone number is already publicized. We have hired psychiatrists, psychologists who are sitting there to hear to the people. We have had a lot of calls coming in. But that is where we have to move towards. Mental well-being is something we all have to talk about, we all have to touch upon, and we are coming up with school health programs on mental well-being. We want to have exclusive mental well-being programs for the mothers, for the working class, for the geriatrics. National Health Mission has also been working towards geriatric health care, both for the physical and mental well-being. Because in these call centers, when we analyze the phone calls that are received, majority of them come from the elderly population. And their simple issue is that there is loneliness. I feel lonely at home. Now, this is something that we all have to address as a society. As a community, we have larger responsibilities, and it is in these areas that NHM is focusing. And as I said, our primary focus has always been to invest in the primary health care. So when we see at the community health services, the public health care, and the primary health care institutions, all this have been that is NHM's primary concern. We will continue to work towards strengthening the capacity of primary health care. And with this, I congratulate the Directorate of Public Health for having completed 100 years. And we in the NHM are there with you to strengthen, to strengthen all the programs that you are coming up with. Thank you.
Thank you, ma'am, for the thoughtful presentation on the areas where we need to focus and move forward. And also, we are happy that you are here to support us on all our endeavors. And now I request our director, sir. Now I request our DPH, sir, to felicitate our MD, ma'am, with the memento. Thank you, sir. Thank you, ma'am. We'll move on to the next session, which is on additive effects of Ayush services in control of non-communicable diseases. I request Dr. S. Ganesh, IAS Officer, Commissioner, Indian Medicine and Homeopathy, to deliver the presentation. Welcome you, sir. And sir belongs to the 2009 batch, Tamil Nadu cadre. He has worked in various capacities like RDO and as DRO, worked as General Manager in Tadpo, Tsunami Rehabilitation, Kadalur District, as a Special Officer in Tirupattur Cooperative Sugar Mill. He has also served as District Revenue Officer, Additional District Magistrate in Dharmaburi and Erode districts. He has worked as Joint Managing Director at Ward Board and as Corporation Commissioner in Coimbatore and as District Collector in Pudukkottai District. Currently, he serves as the Commissioner, Indian Medicine Homeopathy. Welcome you, sir. Over to you, sir.
Good afternoon to everybody. Respected Minister for Health and Family Welfare, respected our Secretary Health and Family Welfare, HODs of the department, Deputy Directors, Joint Directors, and all the Health Department officials. I congratulate Directorate of Public Health for completing 100 years of greatest service to the people of Tamil Nadu and still in the continuing way. Regarding Indian medicine, so we have all 5 systems, that is Siddha, Ayurveda, Homeopathy, Yoga, Naturopathy, Unani, etc. And now new system of Saura Ripa has been added, which is a Tibetan system of medicines. In Indian medicine, we focus almost all the diseases for health and wellness of the people. Especially in the non-communicable diseases, we have a great breakthrough regarding the controlling of the diabetics as well as the BP. And we have our separate scientists, they take care of the research and development in creating medicines and the dosages, etc. Practically around 1,500 hospitals, PHCs we are running along with the DPH, which is co-located. And in our Honorable Chief Minister's main flagship scheme of the Makkalai Thedi Maruthuvam, we are also joining with the DPH and NHM Around, so far, we have in our roles of around 32,000 patients are taking tablets and other medicines for these non-communicable diseases. So, since the session is for the special, our role in the non-communicable diseases of diabetics, so I have called our R&D special scientist from National Siddha Research Science Corporation. So, Dr. Natarajan, he will be presenting the details about the diabetics and the role of Siddha medicine. Thank you.
Thank you. Good afternoon, everyone, and good morning, all the dignitaries of the dais and the guests. So, our director has made an introductory talk about our Department of Indian Medicine and Homeopathy. So, I will quickly run through the. So, our department meant for the quality healthcare through our Indian system of medicines. So, it is mainly focusing upon setting up all the hospitals in every district and to provide quality drugs to the publics. So, as our director told, our Tamil Nadu have a unique credit that it has all the government colleges for all these streams. For example, Ayurveda, Yoga, Naturopathy, Unani, Siddha, Saubharakya and Homeopathy. Except Saubharaka, we are having all the government hospitals. So our department's services based on 4 things: medical services, education, research and development and direct. So our medical services will based on these type of medical services we are providing in the ISM services. So overall we are having 928 PhDs in ISM mix. Moreover, we are going to see there are 60 hospitals in modern medical hospitals also. So interestingly, you can see here there are 72 Ayush Wellness Centers. It is like the National Health Missions, there is National Ayush Missions also. So we are starting up the Ayush Wellness Centers, which is mainly focusing on the non-communicable diseases. And these are the public health activities in a nutshell of our department. Mainly when the vector-borne diseases as well as natural disaster management, maternal and child health diseases and non-communicable diseases as well as in the COVID management. And you well are about that in the 2006 when chikungunya outbreak come in Tamil Nadu, our veteran leader Dr. Kalaignar has introduced the Nilavembu Kashayam for the administration of the patients, and it helped a lot. And from that day onwards, that our department has always been invited in any type of this distribution of this Kashayam, that is Nilavembu Kashayam. It is very more famous in Tamil Nadu now. And interestingly, we are also invited for the national disasters management when we are the floods, Chennai floods and the Gaja cyclone and Varda Puyal also. We have distributed many number of Nilavembu decoctions all around the districts. And our Directorate of Public Health also has mentioned some of these, the importance of distributing the Nilavembu Kashayam is one of these recent publications too. And these are our distributions of our Nilavembu Kashayam during the floods. And one among interesting this Mahaperu Sanjeev kit is a maternal child health kit provided in the ISM wings, that is particularly Siddha medicines. It's a common name of Siddha medicines. And when we are promoting this type of fund, it increases in normal delivery more than 68%. And it will increases the low birth weight also. A pilot study has been done and a detailed study is proposed with ICMR, National Institute of Epidemiology, and our council, that is Central Council for Research in Siddha. So as Madam has rightly pointed out with the school health program, and the Indian medicine also is planning after an Ilanthali department which comprises of the taking care of the adolescent anemia as well as all the educational program, how these children has to be brought up with the traditional cultures and the traditional way of living, the food habits has to be incorporated. So during the COVID, it has given an opportunity for the Indian system of medicines, especially when the first COVID wave, we have provided with an Orachem kit with the Kavasarakudi distributions, and we have created the isolated Ayush COVID care centers. And interestingly, you can see here, this is the one of the breakthrough in the Indian scenario, because in the entire nation, there are 79 ISM COVID care centers. Among 64 are the Siddha COVID care centers, which is fully supported by the government of Tamil Nadu only, because it is a breakthrough, and we have cured about more than 23,000 patients for the COVID. So these are the publications, and we have conducted more than 4 RCT trials and 2 qualitative trials in the COVID too. So coming to the point, what is the role of Ayush, especially in the non-communicable diseases? So the Directorate of Indian Medicine has have 4 strategies. First, identification, engagement, and acceleration with an accountability. So identification is the previous madam and our food safety director also quoted us, Unave Marande. That is the base of the traditional medicines, Unave Marande, Marande Unavu. And madam has quoted about the Makkale Thedi Marthum. So the identification of research is there will be the metabolic risk factors as well as the behavioral risk factors. So the focus, the strength of all the traditional medicine focuses on the behavioral risk factors, the transforming the physical inactivity, the unhealthy diet, that the Ayush systems has a holistic approach by which can make that. So what will the engagement? So usually we have a practice that in our setup of all the ISM, for the diabetes we are prescribing Madhumeka Churnam. And interestingly, in 2008, the Department of Indian Medicine has proposed this drug Madhumeka Churnam as a holistic intervention for a study based, which is conducted in Sri Ramchandra University for more than 8 years, for following up on 8,088 patients. And interestingly, all the parameters, what are the laid down by the modern parameters, the drug standardizations and the accident studies and in vitro studies, the safety studies, it has done all the studies, even the genotoxicity studies level, the drug has been subjected for all the studies, and it has been subjected for the preclinical as well as the clinical studies. So it shows a good impact on hyperglycemia, and as well as it has a hypolipidemic effect. So these are the publications in the PubMed publications, Madhumeka Churnam and the study. So based on these type of evidences basis, so the eye system is not only a traditional, it's also the evidence-based and on the scientific manner. So we proposed 2 projects in the Tamil Nadu Innovative Initiative Schemes, for which we want to create the conversion of pre-diabetic into diabetic. We want to prevent. So we provide this Madhumeka Churnam and Avare Kudinin, and we got these 2 projects for the non-communicable disease program. So interestingly, in our hospitals, most of the patients who are taking the diabetic complications is diabetic foot ulcers. So we used to treat with the Matan Tailam or Vanga Varna Kalimbu, and there is a need of integrations where you could see there. This is one of the case that you could see the ulcers from the foot plantar region is now healed within the application of the Matan Thailam and Vangavarna Kalam, along with what are the conventional medicines that they are taking. So there is a strong point here to integration of those. And the other thing our director has quoted about the hypertension. For the hypertensions, we are conducting a special OPDs all in our PHCs and our district medical college hospitals also. So we are providing Vendamari Churnam and Ziraga Churnam, which is also subjected for the evidence base. It is polyherbal Siddha, it is a PubMed article, so it alleviates the hypertension via that. And also the cumin simin that you already known about the known spices in our each and every kitchen hold, so it's also a important thing. And coming to the point, to the next is the cancer, which is a very threatening for the upcoming generations. And there are a lot of potential list of medicines in the Ayush system of medicines, and it improves the quality of life of the cancer patients. And we are conducting the special OPDs in both Palangote and the Chennai, and they have a separate deputy director for taking care of these the divisions also. So these cancers, especially Rasagandhi Malugu is one of the important formulations. It alleviates the cervical cancers, and you can see the semicarpus legume is Siddha medicine, which is best for breast cancer. These are all the evidence-based PubMed journal publications. So the semicarpus in the legume, that is Serangotai, that you can see the identification of Urshal as a major active components, and it is also some Kalpamrudha, it is a Siddha formulations also for the leukemic mouse models too. So there is a strong point here to take up for the integrations with all the department from the Director of Indian Medicine. So what we are going to accelerate is the implementation of our system of medicine cost effective in all the PACs, and with strengthening of prevention and the control, especially in the primary health care runs. So you are aware about all these things, everyone knows about the yoga, and it is a well-known fact that these are the asanas for the diabetes medicals, And our department has envisaged an International Institute of Yoga and Research in Chengalpattu, which is especially taking care of the yoga therapy. And we are also running the yoga OPDs in cancer research centers. So it takes care of the other elements apart from the conventional medicines too. So coming to the final point, we have to align and have an accountability what we are doing is. So you can see there are two things are happening in the Indian system of medicines. One is the National Ayush Morbidity Code. So likewise, you can hear about the international classification of diseases, especially for the modern medicines. So likewise, we are having the morbidity codes derived for the Ayurveda, Siddha and Unani. So the Directorate of Indian Medicine has contributed in developing the WHO ICD 11, and there will be a chapter called the Traditional Medicine Chapter 2. So Indian department has contributed in developing the Traditional Medicine module, which is in the alpha draft. So this is the page of the portal where which you can see the national morbidity of Siddha, Ayurveda and Unani codes. So we are not in the older version. Now we have transformed and we are in an alignment with the national and statistical and accountability of how we have to document and we have to project to the society and make a better complement in deriving in a policy when in related to public health. So our department has a smaller component and we are putting effort to contribute to the public health activities. So this is some of the statistics of our Siddha, Ayurveda, Unani and Hoba, Yoga and Naturopathy. So our strength is very holistic and the people are having health-seeking behavior for the chronic diseases. First they thought of going for the our traditional systems. So this is our strength. And our weakness is the poor documentations. And now we have moved a lot from what we have been in the year. And recently our government has approved a data center for capturing all this data. So opportunities are wide open, and as I have quoted some of the examples, we need an integration and utilization of Ayush doctors. So threat is when we are amalgamating all the systems and we will be having the fund mobilization. So the final point is to here is, and we are having an opportunity to integration and utilization of the if those who have planned and process firmness, they will obtain what they have desired, even they have desired. And thank you.
Sir, can I ask one question, sir?
Come.
Sir, department has also conducted analysis of Gomutra, Ganga Jal and Gayatri Mantra on the effect of COVID, or their effect on COVID-19. What were the results, sir? Anything significant result has obtained, sir?
No, sir, these are not been done here. In our department has not carried out these Gomutra or Ganga Jal, or we have not conducted, sir. It's been in the northern India, but it is not been published, I think so.
Polyarthritis better than our allopathic. You are having a Rajamulya 22 Mulya, which has cured me. Even inflamaxib has not yet cured me. Why you have not supplied? You can do it.
Yes,
because
sure.
seronegative polyarthritis is very severe from top to bottom, from our CM to the low level.
Yes, sir. You're
It
probably...
has been given from the Siddha from Tirunelveli.
Yes, sir.
You can contact the professor of Siddha. They are having a 22 Mulya capsule. It can be distributed in our Ayush, sir. Which will be well versed for all our fever, anything, dengue, everything we can give, sir.
Yes, sir, we will provide.
Yes, these suggestions will be taken, and after the analysis by our expert department, so definitely it will be taken care.
Thank you, sir, for the presentation, for sensitizing our officials and staff on the treatment aspects of Ayush and NCDs and the measures being undertaken towards control of NCDs. Thank you, sir. Now I request our Additional Director, Dr. Shekhar, sir, to felicitate the speaker with a memento. Our next section is on scope of government health insurance schemes in primary healthcare services. Please join me in welcoming our project director, Dr. S. Uma, IAS ma'am, for presenting the presentation. Ma'am began her career as a health officer and was promoted as the Deputy Director of Health Services and Joint Director, National Health Mission, Tamil Nadu. Recognized her leadership and administrative ability, she was promoted to the Indian Administrative Services cadre by the Government of Tamil Nadu in the year 2019. She was the first government doctor to be promoted to civil services under the state selection category from Tamil Nadu. She took charge as the nodal officer for bed management in the state war room during the second wave of COVID-19 in May 2021. Currently, she serves as the project director of Tamil Nadu Health System Reform Program since May 2021. During her tenure in the project, she has been instrumental in achieving the expected outcomes of the agreed activities from the World Bank. She also is the project head of the prestigious CMCHS program, and for the first time since inception of the program, government share in CMCHS has increased to 48%. She also is the project head of emergency ambulance services and related helpline and call center. She also overviews the JICA project, which supports infrastructure development and strengthening of tertiary and secondary care hospitals with high-end equipment to treat the needy below poverty line families who approaches the government institutions. She was instrumental in smooth conduct of health-related activities as working group head in health team constituted by Government of Tamil Nadu in recently held 44th International Chess Olympiad, in which nearly 2,550 players took part from 188 countries. And to her achievements, she was awarded the gold medal in physiology from Dr. MGR Medical University, and a gold medal in MD Community Medicine in 2004, and a Best Doctor Award in 2018 by Government of Tamil Nadu, and Good Governance Award 2021 by Government of Tamil Nadu for effective management of state COVID war room during second wave of COVID, and Good Governance Award 2022 awarded by Government of Tamil Nadu for rollout of data purity project in CMCHIS, which made the scheme more transparent and accountable. Above all, we really feel proud that ma'am is from our Directorate of Public Health and Preventive Medicine. And it's really a great pleasure to have her in our 100th year celebration. Over to you, ma'am.
So, good afternoon, everybody. Respected Honorable Health Minister, sir, respected Health Secretary, sir, all the HODs here, and all the dignitaries as well as the participants of this prestigious event. It's a very happy moment for me. It's like just coming back home to the same public health department where I joined service in 1995 as a health officer. So really it's a very, very happier moment to stand before you and also share some of the experiences. So usually when we meet DPH sir, and earlier also when he was Additional Director Insurance, he used to say that insurance is mostly towards the secondary and tertiary care health centers and not much scope for the primary health centers. But sir, today we will give you some of the clippings, and again I'll share this presentation also. There is a scope for the primary health center packages also, so that the primary health centers can also develop their own resources at their level. So why insurance is being pushed across all the levels is, this is the only flexi pool money apart from NHM substantial support which is available at the head of the institution. So you can tune the money and you can do it at your convenience for what are the gaps you need to address in your facility. So definitely there is a scope for the primary health centers also, sir. So today I first of all thank the organizers for having given me this opportunity so that we can share some of our experiences. So before I go into my presentation, definitely I thank all the staffs who are under the public health department who have done a very, very tremendous work, especially during the COVID work, sacrificing all your Sundays, holidays, because of your intensive COVID vaccination. Definitely our state was able to show lesser mortality when compared to the whole world. So definitely I thank all the public health staff who have done a very good effort during the COVID. Usually having come from the public health department, always we feel that we are invisible doctors. Nobody knows who vaccinated your child, nobody knows. But they will be remembering the doctor who conducted the delivery. They will be remembering the doctor who treated them during the myocardial infarction or any high-end surgeries. So usually public health is one department which is invisible from the part of the public, but definitely all your collective efforts have made us stand head high in front of the whole world, because we have already achieved the MMR, IMR, and to some extent in communicable diseases because of the hard work done by the public health department, which has a very good, strong community force in the SDG goal ratio. So now the unfinished goals are our real challenges. As our MD NHM madam said, we try to pool all the available resources from all the schemes, and so that Tamil Nadu will be a forerunner in the control of NCDs also in future. And again, the whole world is appreciating the public health department, because now that all our learned experiences, and earlier 2 days also, you would have heard lot of speeches, and speakers would have enlightened you. Every investment you do in the public health department, definitely it will be going to be a very good opportunity for us to save lives of the people. Because control of hypertension and diabetes is a very, very cheaper, cost-effective method when you compare then investment in ICU beds, renal transplant, dialysis. All these are very, very costly efforts. So investment of public health department, especially in the control and the challenges we face in the NCD, definitely it will be a game changer in future. I hope all my World Bank team which was here also had given you good speeches on that. So with this short introduction, let us move to the scope of the, the insurance packages in the primary health center. First slide. So you all know very goodly that in the year 2009, it was introduced first as a pilot project as Kalaignar Kaappeedu Thittam. Now that after so many years, so many modifications have been done, and this 2022 has been a very, very important year. We have rolled out for a 5-year tender package, and the beneficiary extended to every family will be up to 5 lakhs per family per year. So this is a very good package which is available for every poor family who is enrolled into the insurance scheme. And this is the first government which has also extended the government employees insurance scheme also. So there are around 20 lakhs retired pensioners as well as government employees. So Tamil Nadu government has also been the forerunner in taking care of its own employees as well as the general public. We all know that Tamil Nadu is a welfare state. So though we say that 1.2 lakh income per family per year is the eligible criteria for getting an insurance card, but you know that the database we are having as on today is around 1.43 crore families who are enrolled under the insurance scheme. So this itself is a positive finding that Government of Tamil Nadu cares for the welfare of the people, so that anybody can approach even a private hospital for any high-end packages which have been included in the insurance scheme. So this is the journey of our insurance scheme. It started in the year 2009 with only 1 lakh was the eligible limit per family per year. After around 10-20 years, now that we have gone up to 5 lakhs, and we are having around 1,513 packages. United India Insurance is our private insurance agency, and the premium we are paying freely by the government per family is 849 rupees. So government has been so kind enough, and the budget which has been allocated for this program per year is 1,546 crores. So such a huge money has been invested to the scheme, because government of Tamil Nadu is so caring for the welfare of the people, out of which around 77.7 lakh beneficiaries who has been labeled as the socio-economic cost census BPL families, 60% of the money is reimbursed by Government of India. But anyway, we are getting this amount as an advance every year by Government of Tamil Nadu. So this is one of the important flagship program which is having a huge investment by the Government of Tamil Nadu. So again, we are very much care regarding the improvement in the services given by the government institutions, because you all know that we are having so many investments in the medical colleges, 36 government medical colleges. No other state has this much government sector influence. We are investing so many high-end equipments through NHM, through state budget as well as through our JICA project. But for the up and running of all the projects, consumable cost is very, very high. So definitely we have carefully ensured that all the high-end equipments are included in our insurance packages so that the money which is available with the institution, they need not wait for any resources from anybody. Straight away they can procure the consumable and put into use, and at any point of time the equipment is not, say, kept idle for want of money for consumables or annual maintenance. And life-saving procedures which need more money than 5 lakhs. For that also we are covering from Corpus Fund. Some really BPL family, but because of no ration card, they will be unable to get the insurance card. So case by case basis, for them also we will have the flexibility to release the fund from Corpus Fund. And also for structuring the BMT suite, like high-end procedures in RGGH, all the infrastructure development, we give a seed money from the Corpus Fund. So the 28% money is carefully, and all the inmates of, say, Institute of Mental Health, 514 inmates of IMH who don't have the Aadhaar card or any other card, we have straight away got a government order and we have given them insurance card so that if at all they require any high-end procedure, they can easily avail the services free of cost using this card. Then we have also included Sri Lankan refugees and differently abled individuals, and 1,414 journalists also have been given, thanks to our Honorable Health Minister who took forward this scheme. So this is one slide which we proudly show, and Government of India has also appreciated this. So I hope you can infer this. Government share has permanently improved from 31% to 48%. So this increase in the share definitely is a very good amount which is available in our medical colleges and secondary care hospitals, so that it is a proxy indicator of measuring the performance of any institution. We can now say that all the government medical college hospitals and bigger district hospitals which have higher equipments have started using all the high-end equipments. So this insurance performance is one proxy indicator which tells us how best our equipments and all the infrastructure has been put into use. And Niti Aayog has also given a positive note that Tamil Nadu government has been able to ensure that the free quality service is being given at all levels up to the poor people who have the insurance card and avail the facility. This graph clearly shows there is an increasing trend of the insurance scheme utilization in the government sector. Though we say that the DME share is very low, we all know that 11 best performing district headquarters hospital has been converted as medical colleges, but still the DME share and DMS share are definitely improving in a very good positive way. But these are the districts where we are very much worried, because though the investment and the equipment supply, manpower, everything is very equally across the state, but these states are having a higher, say, private insurance rather than the government sector. So here if you are going to give 100 rupees for insurance, only a very minimal percentage is going back to the government institution, whereas more than 90% is going towards the private institution. So here the awareness of the people in utilization of the services in the government sector needs to be improved. So this is one slide. You can see from 2012, yellow color is the government share and the blue color is the private share. These are the top 20 packages where our maximum insurance claims are booked. So this year you can see there is an appreciable increase in the length of the yellow bar, which shows that the government institutions are also improving in a very good way. And what I would like to say from this slide is, see the top 20 claims. It is mainly dialysis, PTCA, that is our cardiac issue, coronary bypass surgery, single valve replacement, acute myocardial infarction. So all these are interrelated to our NCDs. So if we are able to identify and treat the NCDs at the earlier stage, definitely the outgo in the top 20 packages will come down. This money can be utilized for another welfare scheme. So the main cheapest intervention which the world globally has agreed is the control of hypertension and diabetes at the primary health center level, rather than go for a myocardial infarction, stunt procedure, dialysis or transplant. This slide clearly shows that the maximum outgo is only in these areas, which has a very good earlier, cheapest intervention. So again, this is the slide which we would like to show to our DPH sir. There are around 119 packages which can be utilized at the primary health center level. We have given you in terms of every department, and this PPT I will share you. This is the package, say number along which will be useful for you while you come across. So we have, as I said, 475 PHCs under insurance, but only these 4 PHCs are able to show some appreciable performance. However, these 4 PHCs are also not in a very good shape. They are also in a declining trend. In 2017, the overall performance was 753, whereas this year it is only 50% of what has been done in 2017. And 3 belong to Ramnad district and 1 is in Viluppuram district. Anyway, we congratulate the DD Ramnad, Paramakudi and also Viluppuram for having shown a difference among all the other facilities in the Tamil Nadu. We have around 475 PHCs empaneled. But as I said, there is a very big scope for improvement in the PHC side also. So definitely we can do. And this is one slide which we would like to say. RBSK is another flagship program of the state through NHM. Here also all the high-end surgeries are covered under insurance. So here also the effort is being given by the public health team, right from early identification, proper referral, correct center for referral, and also ensuring that the treatment is done immediately so that the child's quality of life is very good. So this many number of surgeries have been done by the RBSK referral since 2015, the inception of the scheme. Around 326 patients and 917 crores have been invested for the treatment of all these congenital deformities, heart surgeries, cochlear implant, which has been identified by the RBSK referral through our insurance scheme. So really I congratulate all the RBSK team leaders, which is under the DPH side. So definitely you are doing a very good work. Please ensure that early identification, early referral, timely treatment, these are the key steps which will improve the quality of life of the child. So here you can see there is an appreciable say decrease in the performance during COVID. Now that the performance is again increasing. So this year around 6,522 congenital heart disease beneficiaries have been treated under the insurance package. And this is again cochlear implant. Again there was a dip during the COVID period. Now that the whole RBSK team is in position, again we are picking up the performance. This year we have done 310 cochlear implants for the RBSK referred children. So please keep up the good work. So these are some of the children who have been benefited by the RBSK team as well as the insurance scheme. So you can see the happiness. This is because of all your tremendous efforts. So as everybody knows, these 3 are because of the strong public health system we are able to do. And the 3 red are very, very critical. We need to achieve these indicators by 2030, trauma, mental health, as well as the NCD challenges. So as Madam, Mission Director Madam said, Makkalai Thedi Maruthuvam is one very key scheme and a flagship program of the state, under which the CAPD bag delivery is supported by our insurance packages, and also some of the physiotherapy packages are also there. But still here also, though 475 PHCs have been empaneled under the scheme, only a very few PHCs have raised the pre-auth in time and have also settled the claims. So this is one Niti Ayog's appreciation for the very good scheme which has been in place for more than 12 years, so that the out-of-pocket expenditure of the general public in Tamil Nadu is very low when compared to the other states in Tamil Nadu. And you can also see the recent NSSO survey says that there is an increase in the public share overall itself, because you all are public health persons, you know the cost effectiveness. So the out-of-pocket expenditure in a private hospital is the highest in Tamil Nadu across India. So the only way out, even I will say up to a upper middle class person, is to approach a government facility. So strengthening the government facilities with adequate infrastructure, equipments, human resources is the need of the hour. So this is also one of the compliment which has been given by National Health Authority, that Tamil Nadu government is doing a very good work in the insurance scheme. And this is also another year award. And this video can, Vinay, இது volume வராதா?
எனக்கு தெரியல ஃபர்ஸ்ட் குழந்தனால திடீர்னு பக்கத்தில் ஒரு தமிழ்காரோட அக்கா வந்து சொன்னாங்க உன் பையன் உனக்கு அம்மா அப்பா கூப்பிடுதா அப்படின்னு. நான் சொன்னேன் இல்லையே அப்படின்னு. சரி அவரு விளையாடும் போது பின்னாடி ஒரு தட்டு கீழே போட்டு பாடு திரும்பி பார்க்குறாங்களா அப்படின்னா கேட்டாங்க. சரி நான் ட்ரை பண்ணுறேன்னா கரெக்டாக அவங்களுக்கு சொன்ன மாதிரி போடும்போது அவர் திரும்பி பார்க்கல. அப்புறம் அந்த அக்கா சொன்னாங்க நீங்கள் போய் டாக்டர் பாடிங்க அப்படின்னா. டாக்டர் போய் இங்கே தான் கோயம்புத்தூருக்கு போனால் சாயந்தரம் ரிப்போர்ட்டில் என்ன வருதுன்னா என்னோடய பையனுக்கு வந்து காது கேட்காது வாய் பேசாது. அது சொல்லும்போது எனக்கு ரொம்ப கஷ்டமாயிடுச்சு. என்ன பண்ணலாம் எனக்கு ஒன்றுமே புரியல அப்போது. அப்புறமே டாக்டர்கிட்ட நான் சொன்னேன் சார் இதுக்கு ஏதோ வழி இல்லையா எப்படி. அப்புறம் டாக்டர் சொன்னாங்க உங்ககிட்ட ரேஷன் கார்டு இருக்குதா அப்படின்னா. இல்லை இது எல்லாம் இடிந்தால் அந்த சிஎம் ஸ்கீமோட ஆப்ரேஷன் பண்ணிக்கலாம் அப்படின்னா. அந்த ரேஷன் கார்டு வாங்கிறதுக்கு எனக்கு 4 வருஷம் ஆயிடுச்சு. பையனுக்கு 6 வருஷமோட டைம் கொடுத்தாங்க. கடைசி எல்லா டாக்குமெண்ட்ஸ் ரெடி பண்ணிவிட்டு டாக்டர்கிட்ட சென்னைக்கு சைன் பண்ணோம் எல்லாம் பண்ணிவிட்டு கடைசியாக கொடுத்து என்னோடய பையனுக்கு ஃப்ரீயாக ஆப்ரேஷன் பண்ணி விட்டோம். இந்த மாதிரி மைக்ரேன் எல்லாம் வருவாங்களோ ஒரு குழந்தைக்கு இப்படி இருக்கும்போதே நான் சொல்லுவேன் தமிழ்நாட்டில் என்னோடய பையனுக்கு நான் இங்கே அதுக்கு நான் தமிழ்நாடு அரசாங்கத்துக்கு ரொம்ப நன்றி சொல்கிறேன். ஏன்னா என்னோடய ஊரில் இந்த பையன் எனக்கு இருந்தான்னா இந்த வாய்ப்பு எனக்கு கிடையாது. எனக்கு தமிழ்நாட்டில் இந்த வாய்ப்பு கிடைச்சிருக்கு. இன்றைக்கி என்னோடய பையன் அம்மா அப்பா தம்பி சொல்லுது.
இதில் காசே வாங்கிக்காமலே இந்த ஃபுல் ஆப்ரேஷன் பண்ணி கொடுத்தாங்களா?
ஆப்ரேஷன் 6 லட்சம் ரூபாய்க்கு ஆப்ரேஷன் காசு வாங்காமல் பண்ணியிருக்கேன்.
ஒரு பைசா வாங்கல.
So this is the success of our program. So definitely we all will join together and extend our services to all the people of Tamil Nadu. Thank you.
Thank you, ma'am, for a motivational speech and also a precise presentation. We assure, ma'am, we will utilize the services being provided under CMCHS for primary care and will definitely improve, ma'am. And now I request our director, sir, to felicitate the speaker with a memento. Thank you, ma'am. Thank you, ma'am. Now we'll move on to the next presentation, which is on human resource management at primary healthcare, role of medical services recruitment board. Please join me in welcoming Thiru A.R. Gladstone Pushparaj sir, chairman, medical services recruitment board. Welcome you, sir. Sir belongs to the 2011 batch. He served as a district collector Ranipet, and he served as a member secretary state planning commission, and currently is the chairman of MRB. Welcome you, sir.
Honorable Minister, sir, respected Secretary, HODs, officials of Health Department and other participants, thank you for giving me this opportunity to have this short presentation. MRB, shortly the short form of Medical Services Recruitment Board, was formed in 2012. The main aim is to recruit the important personnel for the health department like doctors, nurses and pharmacists. The purpose is to recruit these personnel in a transparent, speedy and effective manner without any irregularities. The procedure is, we receive the intents from all the HODs in the month of January every year, and based on the intent, we sent the proposal to the government. And after the approval of the government, it is being notified in various newspapers and in the websites. And after processing these applications through a system called Online Application Management System, we conduct written examination or certificate verification based on the posts. For posts included in B category, we conduct examinations, and for the other posts, we simply conduct certificate verifications. And after this procedure, we publish the results based on marks and communal rotation. So far, we have recruited more than 36,000 personnel for the health department, including doctors, nurses, and pharmacists, and other paramedical staff. And for this year, we are planning to recruit around 4,300 personnel. And till now, we have completed recruitment for 1,700 people. We have a lot of challenges in recruitment, especially court cases. Whenever we go for a full-time process of recruitment, we are stalled by the court orders. Even now, many examinations have been held up by the court orders. And also, we receive indents from the HODs in a very delayed manner, and also the indents are not in a full shape or without enclosures. Moreover, we have changed to the online platform for the conduct of examinations, and we are seeing it difficult to find the infrastructure required. Anyhow, we are trying to provide all the personnel required by the department in a speedy and effective way. Thank you.
Thank you for a precise presentation, sir. Now I request our Additional Director, Dr. Bhavani Umadevi ma'am, to felicitate the speaker with a memento. Thank you, sir. Now we'll break for lunch. I request all the participants to be back by 2:10 p.m. And there is one small announcement on with regard to CME credit points. For ensuring CME credit points, I request all the participants to sign on the slip kept in near the two doors. Please sign it so that you will get the CME credits point for sure. Thank you. Please reassemble by 2:10 p.m.
ஃபோட்டோ எடுக்கணும். This.
Tis. 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 Tis.
Those who are present here, please ensure that you have signed for the CME credit points. The attendance is kept near the doors. Sir, எங்க இருக்குன்னு கேக்குறேன். எங்க sir? இது பக்கத்துல. It is kept near both the doors. Please sign to ensure your CMA credit points.
cheek, yes, cheek, yes, cheek.
சொல்லுங்க மேடம். ப்ரோஜன் 3 மணிக்கு, பூஜா 3:15. பூஜாவை சொல்லி
Okay, welcome all back. Now we'll have a video recording, which is day 1 session. It is about primary health care and NCD control, gaps and challenges by Dr. Tom Frieden. Vijay. So, Dr. Tom Frieden is a physician trained in internal medicine, infectious disease, public health, and epidemiology. He is a former director of US CDC, and now he is with Resolve to Save Lives, looking after NCD interventions program across India and also across different parts of the world. Now we'll move on to the video recording.
I'm delighted to be with you. Thank you so much for the invitation, and congratulations on 100 years of public health progress. As you've asked, I'll be discussing public health, primary health care, and non-communicable disease control. Since COVID emerged, heart attacks and strokes around the world have killed 2 or 3 times as many people as COVID, and at a younger age. So the pandemic of cardiovascular disease is deadly. Many factors affect health. At the base are socioeconomic factors. Above that, issues where we affect the default value. Above that, long-lasting protective interventions. Above that, clinical interventions, and then counseling and education. The most effective, the highest impact are things like reducing poverty, increasing education, increasing access to health care. But there are also critically important things that can affect the context for health, such as taxes on tobacco and alcohol and junk food, or eliminating trans fat. How is the world doing? There is, as you know, the Sustainable Development Goal of reducing death from the non-communicable diseases by 1/3 by 2030. That's just 7 years from now. The red line shows how the world is actually doing. It's going down, but not nearly fast enough. We'll have to double the pace of progress if we're, as a world, going to achieve the global SDG of 3.4.1, which is the core issue of how many people die from non-communicable diseases at a young age. We've analyzed what it would take to achieve that SDG. Not enough to just say we have a goal. We have to say, what's the plan to achieve it? This is what the world can do to achieve that 1/3 reduction. A big reduction in tobacco use, big reduction in sodium consumption, prevention of certain cancers, primarily through vaccination, treatment of hypertension, elimination of artificial trans fat, reduction of indoor air pollution, and reduction of harmful alcohol use. And in asterisk on this slide are items which qualify as a World Health Organization, quote-unquote, best buy. And what you can see is that overall tobacco control accounts for more than a third of the reduction. Tobacco remains the leading cause of death around the world. If you take together sodium reduction and hypertension treatment, it's over 10% reduction, the next highest. Then cancer, then trans fat, air pollution, and harmful alcohol use. India has made substantial progress reducing tobacco use. This is data from the global gold standard, what's called GATS, the Global Adult Tobacco Surveillance Surveys, in 2009-10 and 2016-17. Very substantial decreases in smokeless tobacco use, media use, and even more in cigarette use. So, as every country does, more to do, but lots of progress on tobacco control in India. India is also a leader eliminating artificial trans fat from the food supply. It's gaining independence from trans fat in food. It's the first lower income country to protect its people from this toxic chemical additive. Trans fat India by 2022 was the goal of the food safety entity, and that is being achieved with strengthening of existing regulations. And the next step is to ensure effective implementation of the government policy. In terms of use of solid fuel for cooking, the goal is a 25% reduction by 2030. What you can see, these are the global rates. And what you can see, there wasn't much progress going into about 2015. And then with India's substantial progress, expanding use of LPG through a public program, not only did that help India a lot, that actually was big enough to change the trajectory of this for India as a whole, for the world as a whole. And it's possible the world will meet this target in terms of reduction of use of solid food for cooking, fuel for cooking, but more progress is needed all over the world on this. Changing the context to make the default choices the healthy choices is the most effective way to promote health. That includes ending the tobacco epidemic, protecting people from unhealthy food by promoting wholesome, low-sodium, sustainable, farmer-supportive food production and distribution, promoting healthy physical activity, including community design to make it safer for people to walk and bicycle, reducing air and water pollution, reducing harmful alcohol use, and protecting our children from addiction to tobacco, alcohol, drugs, and predatory marketing from junk food companies. Robust, epidemic-ready primary health care needs to be the center of our healthcare system. Accountable, high quality, connected with public health, working as part of multidisciplinary teams so doctors can manage much larger numbers of patients where their skills are most needed, and patient-centered with convenient, affordable, culturally competent care equipped to prevent and manage infectious diseases, whether that's detection, treatment, or vaccination. I was delighted to travel a few months ago to India's health and wellness centers. And I have to say, I've been coming to India for close to 30 years. And the Health and Wellness Center initiative, although of course different in different states of India, since health is a state affair, is the most promising health intervention I've seen in my nearly 30 years of having the honor and privilege of working alongside health workers in India. It has enormous potential to improve population health. In the India Hypertension Control Initiative, patients treated at health and wellness centers are far more likely to have their blood pressure controlled. India's health and wellness centers, this is one of them in Varanasi, Uttar Pradesh. This is the community health officer, and this is a patient with hypertension. He is so happy. I was so delighted to hear what he had to say. He said, "She's our health provider, and she's better than the doctors in the big city. She's here for us. She gives us the medicines free. She knows what to do." He was so proud of her and so happy with the services. And that kind of dynamic can change the way healthcare is provided. What we've seen is that all around the world, of course, most governments need to spend more on healthcare, but governments also need to spend better. More investment in primary healthcare leads to better access, but even with similar levels of investment, some countries achieve much better outcomes. This is from the Lancet Commission on Financing of Primary Healthcare. What you can see, the different colors on the slides are different levels of income of the countries. Each dot reflects a country. But what I want you to notice here is the amazing difference at the same level of spending to the quality of healthcare delivered. You go from basically 40 to 75 on this index in 2 different lower middle income countries. I don't know which they are, but the point is that not only does each society need to spend what it takes to keep people healthy, but you need to spend smart, spend better. And programs like the Health and Wellness Center are a great example of that. Reforming primary health care, this is the global experience. As public health people, we tend to focus on the technical package, algorithms, which are important, medications, supplies, equipment, team-based care, patient-centered care, information systems. Fundamentally, good diagnosis, good treatment, and good monitoring. But none of that's going to happen unless financing changes. And the optimal for financing is a blended system with capitation at the center, where you're paying providers and holding them responsible and accountable and supporting them to support patients. That means adequate healthcare workers' salaries and benefits. That means paying for value, not volume. That means possibly using registration and licensing to ensure minimal standards. And patients should understand and see, and the reality be, that they're going to get same or better quality care at lower cost in primary health care, just like that situation I described in Varanasi. But that financing isn't going to change unless political will changes, so that primary care has the same or higher priority than specialty and hospital care, that rural, isolated, and disadvantaged populations are focused on, that there is the ability to withstand pressures from the specialists and hospitals that will always want more, so that primary health care can provide the services needed so that fewer specialist services are needed and they can be provided for the people who really need them. But this political will won't happen unless there's advocacy by political leaders, organizations, activists, healthcare workers, demonstration projects showing how it works, and monitoring with public accountability of how healthcare is doing. That is the global experience on strengthening primary healthcare. And what we see in countries like China is a virtuous cycle. There are more primary healthcare services. The community values and appreciates those services. Politicians take note. They increase funding for primary healthcare more. That expands services more, and the community values them more. And that cycle goes around and then reaches what I call escape velocity, escaping partisanship and becoming a national priority so that everyone recognizes that improving primary healthcare is in everyone's best interest. High blood pressure, hypertension, kills more people than any other condition and more than all infectious diseases combined. More than 10 million deaths a year. Every 20 millimeter increase in systolic blood pressure, starting at 115, doubles vascular mortality between the ages of 35 and 69. So lower is better, and we need, as a world, to do a much better job. Because of the approximately 1.4 billion people with hypertension in the world, only about 190 million, less than 1 out of 7, have it under control. Reaching a 50% global control rate would prevent about 1.7 million deaths per year. We looked at all adult primary healthcare interventions and found that controlling blood pressure in the US, and this is true in most countries in the world, would save more lives than any other adult primary healthcare intervention, and by a large margin. The World Health Organization has launched, along with ourselves and many other organizations, a HEARTS program to control hypertension as a pathfinder for PHC and UHC. It has 5 essential components: a drug and dose-specific protocol, quality-assured drugs and equipment, team-based care, patient-centered services, and systematic monitoring for continuous program improvement. This may be the single most important thing: to track performance, identify and solve problems, share positive lessons, encourage healthy competition among health facilities and areas, ensure the accuracy and up-to-date data so that there can be continuous, data-driven, patient-centered improvement based on feedback loops, supporting patients, supporting healthcare workers, empowering everyone to work together to improve health. Thank you so much for inviting me. Congratulations on 100 years of progress. And what I hope that all of us will see all around the world is accelerating progress, improving health, improving public health, improving primary health care, and bringing all of those together for a healthier future. Thank you.
we thank Dr. Tom Frieden for a wonderful
I'm
presentation.
delighted to be with you. Thank you so much for the invitation, and congratulations on 100 years of public health progress.
We thank Dr. Tom Frieden for a wonderful presentation. Though he cannot be here, he has helped us with this video presentation. Once again, thank you, sir. And now moving on to the next session. It is on artificial intelligence and machine learning systems in public health. I welcome Ms. Aparna Krishnan, Project Director, JPAL, to present on this topic. And about ma'am, she serves as a research advisor to the Global Alliance for Mass Entrepreneurship India. Apart from her work at JPAL, she has engaged as an independent consultant and monitoring and evaluation systems with the World Bank and other international organizations and non-profits. She has also worked at the Madras Institute of Development Studies and Center for Microfinance at IFMR in India and at the Institute of Southeast Asian Studies in Singapore. Aparna has a master's in international policy from University of California, San Diego, and a master's in economics from Gokhale Institute, India. Currently is a project director at JPAL. Welcome you, ma'am.
Thank you very much for this kind invitation, and it's really a pleasure and an honor to be here. I think it speaks to the vision and the goal of DPH to first organize a conference like this and have a topic that is on artificial intelligence and machine learning, where the world is still learning about these concepts. So congratulations from our side. And we've been engaged with the department for more than 7-8 years now. So we're looking forward to continuing to strengthening our collaboration. So I'll talk to you today a little bit about one of the projects we're doing with DPH. And your own director of DPH is also very closely involved in the study. So you'll hear more about it shortly. And I also want to thank the previous speaker. I was not looking forward to being the first speaker after lunch. So thanks to the virtual speaker, we can jump right into slides. Great. So let me see. Yes. Sorry. So I think Carl and a little bit better. I'm sorry. Great. So from the morning, I think we've heard data, artificial intelligence, machine learning. I was trying to count. Almost every speaker has made a mention of it. One thing all of us know is it is helping us read text faster. It is able to process images. During COVID, we saw things like cough sounds were being recorded to try and estimate what is the extent of pulmonary or lung damage. So it is really the ability to accelerate human capabilities to work with large volumes of data. It is by no means a replacement for what individuals can do. It is really the combination of how all of you in this room as doctors, practitioners, policymakers are able to leverage the advantages of artificial intelligence and machine learning and the advances in computing and statistical power. I think Dr. Soumya Swaminathan made this point really nicely in the morning, saying it is the clinical work matching with behavioral sciences and data as the underlying infrastructure. It is this combination of all these three things that will really help change how we respond as a society, as governments, to the emerging challenges of pandemics, of new vector-borne diseases, and all of the new types of health challenges that we may be facing in the near future. So very quickly, you can see AI, ML applications in public health across a number of sectors, a lot more now in the spread of diseases, in screening and testing particularly. And over time, I think there's work with genomics, with new forms of data, and understanding risk factors and how doctors can make decisions, especially with critical care patients. I like using this one infographic to make this point, essentially, that there's a lot of information and data that we have, and AI and ML and all of these fancy-sounding statistical techniques give us a way to organize the data. But it is the last two boxes, the insights and the wisdom, comes from people like you in this room. It is the 100 years of public health knowledge and public health practice that can actually use and interpret and apply the knowledge that we find. Why do people hesitate from getting vaccinations? Could networks play a role? Data helps you understand where the problems are and where you need to target solutions. But the kinds of solutions that are designed, what you learn from it is how we as individuals apply it. So three critical things, and you'll see a bit of this as I go forward as well, is on how to make data useful. Right, so I'm going to skip a little bit because I think I've seen many people in this room who I'm familiar with. You would have heard about JPAL, but just one line about the Poverty Action Lab. It's a research center. So unlike doctors, we are economists. It's an economics research group, but that has borrowed a methodology from medicine. We use randomized controlled trials to test whether new ideas are working, what is the impact, and what is the cost effectiveness of the impact. So 3 things go together, along with our research, is to work very closely with practitioners and policymakers to understand where the problems are, and also build capacity to use data and evidence better. So we'll go through RCTs. I don't have to explain to this audience. So you know that. So you'll see our health work actually goes across many areas. One side on maternal and child health and improving neonatal early childhood development. And on the other hand, non-communicable diseases, another topic we've heard from everybody this morning on how it is important to address NCDs coming up. So taking you back to a few years ago, I remember talking to many DPH officials saying one of the problems that the Tamil Nadu government has identified is a growing proportion of elderly, people over 65 years, and that proportion is only growing and will become at least 20% by 2050. Right. So at that point, while we knew that policy response has to address the changing demographic situation, we did not have enough data to understand what are the kinds of problems being faced by the elderly. We were hearing things from the public health system on inability to access healthcare, special kinds of geriatric care that would be needed. So first of its kind elderly panel survey was launched collaboratively with DPH as well as the Economics and Statistics Department. And in about 5 districts, a sample of households with elderly population were selected for a survey, and they would be tracked every 2 years. So 2 such surveys have happened, the baseline in 2019 and a follow-up survey in 2021. What this panel data set has done is it has provided a rich source of data which was collected, the socioeconomic information was collected by the Economics and Statistics Department, and excellent health data has been collected on the field by the DPH running through camps. And so that data, one part, and between the two survey waves, there were a few interventions that were tried to say how to solve problems. So during COVID 2020-21, we were able to observe the impact of cash transfers that were being given for the elderly. There was counseling. I think Shilpa ma'am talked about loneliness as a key challenge among the elderly. There were these counseling sessions that were done. Both of those had positive impacts on both reducing depression as well as increasing food security among the elderly. The other thing that came out, which all of you have already realized and are talking about extensively, is the gap between reported disease and the actual disease burden, especially for chronic conditions related to heart conditions, liver, kidney, and other things. So on the one side, we were able to inform policy by saying cash transfers are useful. The finance minister has made an announcement to review how the OAP scheme could be made more effective and reach more people. And on the other hand, the second point was to say, can we actually explore the idea of machine learning? And this is the advantage of DPH's history of collaborating with research. It is to start thinking while you're planning a program, not after doing a program and seeing whether it worked or not, is to start with research and pilots at the beginning itself. So while thinking about NCD treatment, and also on the other hand, what can the health department do to take health services to the people, right? So despite extensive public infrastructure in Tamil Nadu with hospitals, primary healthcare center, we find, especially among elderly, that people don't come to test as proactively. So what can we, so Makkal Thedi Marthuvam is essentially saying we will go to people, but it's how do we do this most efficiently? Because it's also an expensive program. You can't do door-to-door entries all the time everywhere. So what is the most effective way of reaching people? And through that, through the discussions with the department and some of our researchers, the idea came up on saying, could we try using machine learning for health screening? Could a simple set of mobile tests become better or at least as good as what we call the gold standard tests to detect underlying non-communicable disease conditions? So just a quick insight from the survey, the elderly panel survey that was done, and this should not come as a surprise to most of you who are in the field and in the business of providing healthcare. I don't know if you can see the colors, but it essentially shows that people's own understanding, or if you ask them, do you have cataract? 30% people reported yes, but when you actually tested for it, it was actually 50% of the sample that had cataract issues. So people may not even know unless it starts bothering them. Okay. So then the question comes to, and the other problem with elderly, but also the larger population, is the inability or unwillingness to be able to go to a healthcare center for testing until it becomes too late. So that is the problem which the study is trying to solve for. So collaborating with DPH officials, as well as Professor Esther Duflo and others from around the world, there is this one question we are asking on, can we detect cardiac, lung, and liver ailments? Why these three conditions? Because detection and testing for these three conditions requires infrastructure. It requires going to healthcare centers. Could we use machine learning here to try and predict who is most at risk? So what the project is, it will start this year or in 2023. What it attempts to do is to try and use about 6,000 as a sample, where the collaborations have been set up, where both the gold standard test, which I'll show you in a minute on what that is, as well as the mobile test. So just measuring, say, height, weight, arm circumference, or doing blood prick, HemoQ tests, BP tests, combination of those, when it is run through a machine learning algorithm, can it actually predict as much as your gold standard tests? So mobile tests are cheap to do, but they're not as specific. Gold standard tests are absolutely accurate, but expensive to do, right? It cannot be in every village, even though we may want to do that. So can we combine these two? And this is really a research study. If we do this on multiple iterations, the machine learning algorithm will get better and better at testing and at predicting who will be most at risk. What happens after that is some of those people you can send to actually get the echo or the ECG. Some people can actually do the liver function tests to be able to validate the result. If the prediction is highly accurate, they can immediately be sent for treatment protocols. So that's essentially the principle of the study. What happens is a few months has to be spent on looking at collecting existing data. So you look at both the mobile tests and the actual tests and validate the two results. And then based on that, you develop the algorithm which the department can then use. So if MTM, as it goes forward, could integrate some of these models to say, along with delivering medicines, could we also improve our testing capabilities on the field? And then you can do multiple studies with it to see where should you deploy it most, who will it be most useful for. So just to conclude, as the department thinks about using artificial intelligence and machine learning, there are 3 or 4 principles that I'd like to highlight, and this is across sectors, but more so for health. Data quality is paramount. Right from the field frontline worker who's collecting data needs to see the importance of how that data is used. And there need to be measures for ensuring reliability of the data. Second is data privacy and data protection. Health data is extremely sensitive. Tamil Nadu already has a data policy and an AI and ethics policy, which is quite advanced. But the real test of those policies come when departments like health actually use it and apply it. So there need to be safeguards, guidelines for how the data will be collected and stored securely and shared for further use, which is for public good. Ultimately, keeping this learning cycle, the work gets better, last mile problems are solved when some of it you can do in-house, some collaborate with researchers. The list of speakers on this conference itself is an indication of that. What can we learn from research as we do things and concurrently with our programs? And then finally, designing of systems, it's important. MIS systems are essentially created first to deliver a service, and that's what they need to do. A vaccination system tells you whether vaccines were procured and distributed. But if you want to use that data for things like machine learning and for prediction, then it is important to put in design principle. What types of data should we collect? How can they be interoperable or connected to other data sets? Do we want to collect climate data and compare it with health data? Then the definitions of those data systems are also important. So it is important when designing a health system to keep in mind the ultimate policy goals and objectives. That then makes the data ultimately usable, because these algorithms are only as good as the data that we collect. So if there is incomplete data or poor quality data, then those systems are not going to work. So there needs to be a fundamental change in both the process and the mindset of how we think about data. So I'll end there, and happy to continue to engage and speak later to any of you who may want to know more about the study. Thank you very much.
We thank you, ma'am, for introducing us to the concept of machine learning, and we thank J-PAL in this situation for taking up the research related to machine learning in our state. Thank you, ma'am. And now I request our Joint Director, NCD, Dr. Krishna sir, to felicitate the speaker with the memento. Thank you, sir. Thank you, ma'am. And the next session is on ethical dilemma and ethical considerations in decision making in implementing public health interventions. Please join me in welcoming Professor Brogan Singh Akoijam for delivering a presentation on this. And Professor Brogan Singh is Dean from Regional Institute of Medical Sciences, Imphal, Manipur, and he obtained his master degree in community medicine from AIIMS, New Delhi, and his MHSC in bioethics from the University of Toronto, and also a Feimer and Webb Fellow. He has been involved in various administrative and reform committees of the Institute and in research, and has published more than 90 scientific papers. Besides the routine teaching activities, he has taught interns on bioethics for the last 15 years, and he was instrumental in establishing the Institute's Ethics Committee 18 years back and held the post of Member Secretary, and currently he works as HOD of Community Medicine, Dean RIMS, Imphal. We welcome you, sir.
Thank you for the elaborate introduction. First of all, I am very happy to be here in this conference because Tamil Nadu has one of the best public health systems in the country. So I'll be just giving an overview of the ethical considerations in making public health interventions. And I will try to be very short because I was asked to do so. Okay, to just begin with, we have a continuum of health and wellness. As you see here, in one extreme, that's the death. On the other side, the green side, that is the wellness, very high level of wellness. And this is a concept of the John Travis, who came up in 1972. And most of our curriculum, medical curriculum, are focused towards the black end, that is towards the dead end. And between we have a point of no disease, that is no signs and symptoms, apparently person is healthy. And our curriculum is focused from that point towards the black side. Rather, in the public health, we should be focusing towards the green side, towards the high level of wellness. And so we need a change in our curriculum, so also in our expertise or the field of specialization. And when we talk about the high level of wellness, again, individual responsibility is more. Public involvement is going to be more than the other side. So when we talk about the public health intervention, it should be more towards the green side, covering, no doubt, a bit towards the black side. So when we talk about the ethics, again, whatever intervention we are aiming for, we need evidence that that intervention is good. And when we talk about that evidence again, it's doing good or the harm based on what intervention we choose. So that is a decision that we need to take. What sort of intervention, from where we got that evidence, that is very important for us. Second one would be a choice, because in life, or for that matter, even in the public health interventions everywhere, is all about choice. We have all alternatives. So we need a better choice. So it's about a priority setting again. So when we do that one, that choice, that the alternative we are talking about, is it a better one? That we need to decide. And again, for whom we are doing this intervention and who is going to decide, that is also equally important. That is about equality, that's about equity, that's about the universal access. And then we have individual liberty on the other side. For example, in quarantine, we keep people confined to a place, so that's about the individual liberty and the privacy and confidentiality when we talk about the data sharing and all. So that point is also important decision that we have to make. And on the whole, again, the decision, when we take it, the process, the procedure of taking that decision becomes very important, because why that decision needs to be taken, and who is going to take that decision, and what factors, what conditions we are taking these decisions, and how we are going to do it. All this procedure becomes very important. So having said that one now, in terms of the decision making in public health or the healthcare, from some premises I just want to put it. First one is, it has always been a problem, because the evidence that we're talking about, there is lack of strong evidence that intervention is good. For example, even during the COVID time, we talk about the vaccines, we talk about the COVID appropriate behaviors, all are questionable. Many people were questioning about the usefulness of these interventions. So lack of strong evidence is always a problem in public health. Second one is about the transparency, accountability, and the clarity of the procedure is there, because public are not knowing what things are going on. So that clarity, that transparency, and accountability is important. And there are a whole lot of conflict of interest in terms of the ethical values, in terms of the politics, for example, and the evidence we got, and the politics, and in terms of the legal and ethical issues. And we need to address this one. And secondly, this public health intervention is akin to health technology assessment. In the health technology assessment also we have science part, and then we have the society, economics, and ethics. On the background of that, we have to decide which is the better one. And of course, again, the procedure is very important. And one more problem is ethics is supposed to be sort of universal. That is, what is good is supposed to be good everywhere, but it is not in ethics. It is very contextual. What is good in my place may not be good in Tamil Nadu, for example. So it's very contextual. So that has been always a problem for all over the world. And again, many sectors, many organizations have come out, many of the models and the framework for decision making. Some of them are given here, great evidence to decision, WHO integrate, and accountability for reasonableness. These are some of the models, so I'll be talking a bit about the last one, is A4R, that is accountability for reasonableness. So in accountability for A4R, how decisions are made and why decisions are ethical are being dealt with. And in this one, there are 5 components. The first one is empowerment, then transparency, publicity, revision and appeals, compliance, enforcement, and relevance. These are very important components of the A4R. And if we follow this iteration, probably whatever decisions we are taking is going to be ethical. And one of the things, if we make it very transparent and accountable, the questions that has been asked since the last 2 days, I suppose that government is thinking something else, we are thinking something else, so decision making is very difficult. And that can also be, to some extent, overcome. So the first one is about the empowerment. So we need to facilitate effective participation of all affected stakeholders. That includes not only the scientists, not only the doctors, the politicians, the public, whoever is affected by that phenomenon or by that disease or condition. We need to involve in decision making, and we need to provide our staff, we need to provide training and support staff so that we follow this method all the time. Now, coming to the transparency and publicity, it's all about making the whole process transparent. So here, a formal communication plan is very important, why decisions are to be made, and then how decisions are going to be made, and who is going to take the decisions, and which criteria we are going to use to make this decision. All has to be made public. That has to be publicized. Of course, there are a few questions again. If we make, this must be transparent, whether will it be a problem for us in making a decision. That has not been there from the experience of the other countries. Now coming to the revision and the appeals again, whatever decision we are making, there should be some mechanism to revise and revisit the decisions, because once taken a decision doesn't mean that it's to be there all the time. It's not that way. We have to have a mechanism to revisit and revise whatever decisions that have been taken, and there should be, stakeholders should also be involved in doing so. When the time goes by, again, new evidence and arguments may be brought forward, and we need to think of it, we need to incorporate it, and again, we need to revise. Now, coming to the relevance, when we talk about the relevance, whatever decisions that we are going to take has to have an aims and scope and a priority setting. The priority setting that we have to see whether it is aligned to that priority setting, the priority we have in our hand. At the same time, we need to define explicitly our criteria, what criteria we're using it. And more importantly, when we talk about the organizational ethics, of course, medical department or the public health department can also be taken as an organization, and we have a policy, we have a mission, we have a vision, we have objectives. Whatever decision we are taking, is it aligned to that policy decision or policy values or the mission or mission? For example, the National Health Policy of 2017 states that attainment of high state of well-being for all citizens of the country through universal access by giving quality care with equitable distribution. That is what they said. So equity is one of the cornerstone or the values that policy talk about. Universal access is one of the value again the policy is talking about. So whenever we make these decisions again, we have to see whether we are aligned to that policy statement, to our organizational objectives or the core values. And of course, once we have to have compliance and enforcement, once we have this iteration, we have to lead by example. That means we have to stick to what it is there. We cannot go here and there. And again, we have to have a formal evaluation plan so that we can see whether it is working or not. If it is not working again, we need to review it and go for another one. So these are the iteration in the accountability for reasonableness. Now, to make it effective, again, we were talking about the political milieu. Politics and ethics, they are in loggerhead many a times. These public health decisions and the political decision making are quite different. When we talk about the public health, we are driven by science and evidence, whereas the political decision making is driven by multiple factors. It may be economic, because in pandemic, because of the tourist inflow, and because of the export-import, there are a whole lot of economic involved in it. And then ideological and very personal one again. So there could be a conflict between these two, so we should have a sustained, constructive engagement with the government, with the public health people, so that we can make the decision that we want. Now coming to the second one, the credibility of the scientific evidence again. That happened during the COVID time again. There were a whole lot of questions about the vaccine because it hasn't gone through the third phase of trial, how it is there for the people to be given. So a whole lot of evidence were not adequate for us to decide that way. So the credibility of the evidence is very important, so we should have a mechanism to search for the best evidence. And again, we have to weigh with the evidence and the weight of it. And coming to this, again, credibility, there is something called fair representation of the evidence. Many a time it might be that there could be misinformation and disinformation. Disinformation because we plan to say something or it is said something else by some people. Disinformation is distortion of the information intentionally, and misinformation is a misrepresentation of the facts that can happen from the government side, from the individual side, so that make an impact on decision making. Now is about the fairness, about the distributive fairness as well as procedural fairness. The whole thing is about the procedure that I was talking about. When we make a procedure in this way, make it accountable, transparent, that is going to be fair because it is subject to the scrutiny of the people. Now coming to consensus, that is about the solidarity. That is one of the things that we have seen. At the beginning we didn't see it, but at the end we saw it. Solidarity is an ethical value, which is very important. It's about the equity of duty. Everyone has an equal duty to perform in public, be it the science person or be it the public. So having said that one, these are the ethical values and the accountability for reasonableness. That's accountability, inclusiveness, everyone should be included, openness and transparency in whatever we do, reasonableness, whatever we do, there should be a reason and should be explainable and defensible and responsive to the change. Now these are again some of the extra values that we have in terms of the pandemic situation. There's a duty to provide care. There's a duty of care for especially for the health staff. And we have the equity that everyone knows about, reciprocity. That's about doctors were given the vaccine first, is the reciprocity. That means doctors are subject to a high risk. At the same time, they are the one doing most of the job during the COVID time. So we need to have them first. That was about reciprocity. And then privacy, that's about the confidentiality and proportionality. Whatever restrictions we put towards the public, it has to be to the minimum. We have to look at the individual liberty also to some extent. We cannot altogether do away with that one. No doubt, legal actions can also be taken up. Then protection from harm. That again, we have to weigh again the evidence of whatever we do. Again, and we have to share with the stakeholders. Then individual liberty, I have talked about, and then solidarity that I have talked about in the previous slide. And stewardship, that's something new which has been added during the COVID time, that we need leadership in public health. And lastly, of course, the trust. So these are the 10 extra ethical values that we need to consider while making a decision. In summary, decision making is a public health intervention. We have to search for the best evidence and we have to agree on that one, and defining the ethical values and addressing the conflicts in the light of the social, economic, legal and political milieu, and adopting a fair, transparent and accountable procedure. This is how we can go about in making decisions for public health interventions. Thank you.
Thank you for a much insightful presentation, sir. Now I request our Joint Director, Communicable Diseases, Dr. Sampath sir, to felicitate the speaker with the memento. Thank you. Thank you, sir. Moving on to the next session is on baseline assessment of cold chain points in the state 2021. And may I request Dr. Pooja Sangavi, State Consultant UNICEF, to come on stage to present. And she is currently the Public Health and Immunization Consultant with the UNICEF Office of Tamil Nadu and Kerala. And she has 8 years experience in program management, monitoring, evaluation and fundraising. She has also co-authored a study on critical factors influencing the acceptability of PPI-UCD done at 6 public and private institutions in India and published in Journal of Obstetrics and Gynecology. Welcome you. Over to you.
Thank you. Good afternoon, everyone. What a momentous occasion. So firstly, let me congratulate everyone out here on completing 100 years of progress in public health. And this occasion has come after such 2 momentous years where we saw a pandemic. We dealt with multiple challenges, not only with the pandemic, but with also other health programs that we were dealing with. So all this just shows that how evolving and dynamic the challenges that we face in public health are, and so do our solutions need to be. So we've seen that in the last couple of years, there have been quite a few milestones we've seen in immunization. Firstly, the event program for stock management and temperature monitoring was introduced in 2019. Then, of course, to deal with our ever omnipresent pandemic, the COVID-19 vaccination was started in January 21. And over a period of a year, we started with 2 antigens, Covishield and Covaxin, and we moved on, 3 more antigens were introduced. And a PCV vaccine was introduced in the routine immunization program. So all these milestones, all these events, clearly it entailed a massive demand on the storage capacity of the cold chain system, the immunization supply chain system. And now the system was supposed to cater to a much larger population base. Like routine immunization only caters to infants, but now we had an entire adult population as well as adolescents. So this only says and reiterates the point that we need periodic updates on the storage capacity of our cold chain system. What is the current sickness rate? What is the availability of human resource? What are the skill levels at? How prepared are they to meet with the challenges that have been rapidly coming in the last 2 years? And how well is our system adhering to the protocols and the guidelines that are already in place? So we have a couple of national assessments that have happened in the last 10 years or so, with the latest one that happened in 2018, not discounting the one that took place this year. So, but that EVM assessment, it was a national level assessment that focused at only a snapshot of the cold chain systems in all the states. So it assessed the cold chain system in Tamil Nadu at 6 cold chain points and 6 vaccine stores, which is just a small percentage, which is just a small representative of the cold chain system in the state. But to know how prepared our system is and what are the challenges, what is the scope of improvement that is there, the state needed a statewide, a comprehensive census of all the cold chain points in the state and customized as per the state's immunization ecology. The national level assessments are standardized as per different states, but we needed to know what exactly is going on with our immunization systems, where are we doing well and where do we need to improve. So to understand the preparedness of the existing cold chain system, we basically needed to this baseline assessment looked at all the essential components of the cold chain system. So what is the availability, what is the health of the equipment, how well placed are our human resource at all the levels of the cold chain system, what are the skill levels, what is the quality of our infrastructure and where do we need to improve, how is the equipment being maintained, and of course the most important bit is temperature monitoring. We all know that for a vaccine to be delivered safely from the manufacturer to the beneficiary and it needs to be effective, it needs to maintain its temperature throughout its journey. And so apart from that, how well the stock is being managed, how the vaccines are being stored at the cold chain points, how is the distribution mechanism, and after everything, how well are the practices being complied with and how they're being documented at the cold chain points. So this is what we studied. And where did we study? Now, since this was a comprehensive statewide census, we essentially looked at all the cold chain points in the state, starting with the state vaccine store at the top, the 10 regional vaccine stores, all the 43 vaccine stores in the health unit districts, and 2,632 cold chain points across 42 HUDs. And how did we go about it? So the tool that we essentially used to do this assessment was based on the NCC VMRC and the EVM assessment tool, which is a standardized tool and a globally recognized tool. We also used a digital method, a mobile application-based method to conduct our assessment to avoid any human errors. The checklist was in English as well as Tamil so that information could be gathered accurately and completely. And multiple quality assurance protocols were also set in place. The assessors that were who made this assessment possible were all experienced ones, and they were given hands-on training on how to collect the data. And a pilot was done at 16 cold chain points before we extended this assessment across the state. Now, the unique part of this assessment was that not only did we collect the data through a mobile application, but we also photo documented all the data that we collected. So each and every piece of equipment that is part of the state's inventory was photographed along with other essential documents and infrastructure bit, and it was matched with the data that was collected. And this is one of its kind of a photo reserve, a photo inventory, one of its kind photo inventory, and it's never been done before. And a couple of other, so this was our first line of quality check. The second line of quality check was that we had a Excel-based dashboard that every time the data came in, we checked like how complete was the data, how much it was making sense. And a real-time feedback loop was there between the assessors in the field and up to all the 4 levels of assessment. So the assessors had the supervisors who handheld them and who helped them throughout the assessment. And above them, we had the quality checkers, the data analysts, and the technical team. So with a 4-level quality check mechanism, we made sure that the data that we got from the state was complete, was accurate, and was contextual. So now let's come to what we came to know about the cold chain system. So the equipment, so we basically tried to find out what was the availability, what was the functional status, and what was the size, and what was the refrigerant of the equipment that was available across the state. So we found out that at cold chains, now coming from the base, at cold chain levels, we found out that 99% of the cold chain points in the state had at least one functional refrigerator to store the vaccines. About 95% of the cold chain points had a deep freezer to prepare the ice packs that would be used in the vaccine carriers. And 88% of the cold chain points had at least one large cold box to transport the vaccines and to serve as a backup in case of any equipment failure. About 66% of the cold chain points So apart from that, we also found out that 60% of the equipment in the state was CFC free. We know that the state is in the process of phasing out the equipment to more sustainable refrigerants. And we found out that, up to the level of district level cold chain points, the process has already made a lot of progress. More than 85% of the cold chain equipment is CFC free across all the vaccine stores. And now we are about to also extend the process at the cold chain points. Now coming to the human resource, we know that the last 3 years have been extremely challenging. There was a long gap in training, and because of the restrictions imposed, it was not possible to conduct any trainings. And there was a lot of turnover also in terms of the staff coming in and out and new staff being come into place. Across, we also studied the adherence to cold chain practices, vaccine management, temperature monitoring, how well the equipment was being maintained, and what was the response how well the cold chain handlers and the cold chain technicians responded in the event of breakdown, and how well the documentation of the processes was done. And when we looked at infrastructure across the cold chain points, we saw that did each and every cold chain point and vaccine store have the space earmarked for storing equipment, for storing electrical equipment, dry goods, for repair and so on. And we also assessed what was the adequacy of the space at all the levels, what was the quality of the infrastructure, and what was the availability and preparedness of the equipment supporting infrastructure. And last but not the least, we know that of late urban health program is becoming an area of interest. Extension of programs to the urban population is becoming our prime concern now. So we also extended our assessment to urban cold chain points. There are about 811 cold chain points in the state, which form about 31% of the cold chain points. And looking at them separately with a different eye is very important, because there are certain challenges that the urban cold chain points face which are unique to them. Being situated in an urban or a peri-urban area, these cold chain points cater to a much larger population base. Although the quality of infrastructure is better, but the space constraints is also a reality, and human resource and practical challenges are also unique to urban cold chain points. So coming to looking at all the challenges that we faced, the state has already started the process of utilizing this information and implementing solutions to address them. First challenge was regarding the availability and getting periodic updated information on the equipment. So these equipment related the information that was derived from the assessment, it has been utilized, it has been rationalized with the existing inventory bases that the state has, being the NCC, MIS and the EVIN. And this information is being utilized to guide deployment of any new equipment that is coming into the state. And apart from that, in terms of human resource, earlier like about 18 refrigeration mechanics were available and were addressing the maintenance need across the state. And now their deployment has been extended to 32. And the first batch of their training in cold chain management and maintenance is underway. And more importantly, this process has been set in motion. So now that the baseline assessment has been done, we know that we will continue to need information periodically, dynamically, to tell us where is the cold chain preparedness at. So the supportive supervision mobile application that was launched in April earlier this year, it's already yielding action. About 750 cold chain points have already been visited since then, from April to November. And these cold chain visits are yielding updated information about the cold chain points. And they're also proving to be a very useful platform for on-the-job training. So whenever officials like you, they go for a visit, you can use this opportunity to find out the gaps, discuss the gaps with the cold chain staff, and use this platform to give them on-the-job training and strengthen the practices. Apart from this, resources are also being developed on what are the essential and what are the desirable cold chain requirements at all the levels of the cold chain system. So I'm happy that with this assessment, foundation has been set for evidence-based approach to strengthening the immunization system, and I hope this continues in the same spirit. Thank you. Thank you so much for your time.
Thank you, Pooja, for the assessment and also for your presentation. We also thank UNICEF for their continuous support in improving ourselves in all our maternal child health services, especially immunization activities. And now I request our additional director, Dr. Deva Parthasarathi sir, to present a memento to the speaker. Thank you, Dr. Pooja. And now moving on to the next session, which is on quality improvement interventions in healthcare facilities through TNHSRP. May I welcome Dr. R. M. Meenakshi Sundari ma'am, Team Leader, Quality Improvement Wing, Tamil Nadu HSRP. I welcome you, ma'am. She is a medical graduate from Stanley College, she did her PG from IOG, and she has work experience in PHC, CMONG centers, and Nodal Officer, National Quality Assurance Scheme, Kayakalp and Bio-Waste Management. She has been awarded with many awards like Doctor's Day Award, Best Doctor Award in Admin Cadre, entered into the Guinness Book of Records for motivating maximum students in organ donation, Best Women Outstanding Performance from TNHSRP and Thiruvallur District. Welcome you, ma'am. Over to you, ma'am.
Thank you, Vidya. மனிதன் இருக்கும் வரை மருத்துவம் இருக்கும், மருத்துவம் இருக்கும் வரை பொது சுகாதாரம் மற்றும் நோய் தடுப்புத்துறை இருக்கும். இத்துறையால் மருத்துவமும் மனிதமும் தழைக்கும். Good afternoon, one and all. I go immediately to my presentation. Thanks for the opportunity to all the dignitaries over there. This is about quality improvement interventions in healthcare facilities through TNHSRP, Tamil Nadu Health System Reform Program. We have spoken about 3 days on all these SDG goals, which have 17 goals. Third goal is good health. As our project director pointed out in the morning, we have to work towards the targets to be achieved, which are marked in red, the non-communicable diseases, mental health and trauma, with also a special emphasis on towards the target communicable diseases also. So this is Tamil Nadu's definition of health, quality of care in health, people-centered. People are our bosses, so people-centered, safe. Any health service should be very safe to the healthcare provider as well as the healthcare seeker. Timely, if time is of so much essence, even a microsecond matters in healthcare, and integrated health services in line with established quality standards. Here we have benchmarking. We do have NHSRC standards as of now. The culture of quality. Tamil Nadu Health System Program is calling something a culture of quality. The difference between a habit and a quality you all know. We are there committed to build a culture of quality. That is through transparency, teamwork and leadership for quality at all levels, and also with the active feedback loop for improvement, with meaningful engagement between staff, service user and the community. And also we believe in empowering individuals while also recognizing complex health system. I'll be explaining more in the future slides to come. The 4 pillars which we have as interventions, that is prioritized interventions, is universal action number 1, governance for quality. Henceforth, it was all in bits and pieces. The 3 directorates and all the other support systems were working in silos, wherein we built in a governance for quality. And the second thing is redesigning service delivery to optimize quality. For example, the CMONG and THAI system which we had, we already were doing all those services prior, but we have a nomenclature of redesigning everything into a single plane. The next thing is transforming the health workforce. Like we give special trainings, we have dedicated people for NCD, we have dedicated people for CMONG, so that the vertical programs will be carried simultaneously along with the other services we render. The fourth thing is a very important thing, the first of its kind, igniting population demand for quality of care through our health assemblies. As you all know, health assemblies are being carried out since last year. This year we are going to plan for 16 more districts to go. This is the quality of care priorities: safe, avoiding injuries to everyone who is in the system, effective, patient-centered, timely. The aim of the system is to become a comprehensive, contextual, contemporary system which is also user-friendly, which is scientifically evidence-based, which is flexible, balanced, transparent. The more the necessity is the resilience. The system, whichever strain it has or whatever difficulties endures, it will bounce back to normality. That's called the resilience. Example, our COVID. The motto there is doing the right things right the first time and every time. That's what is quality about. It is not that we act only on crisis. It is not that we do only in our routine and we forget that in a crisis. So everywhere we do it right time, and every time we do it in the right way. So that's what its quality is about. So, what are the interventions we are going to do? So, in quality, we have quality committee meetings, facility scorecarding, state governance structure for quality, NQAS, our National Quality Assurance Standards, NABH, National Accreditation Board for Hospitals and Healthcare Providers. In NCD, we have the NCD, IK47, that is Innur Kapom 48 Mani Nerathirkul, TAEI, that's Trauma and Accident and Emergency Initiative, Mental Health. Everyone has detailed that in NCD. RCH, we have the Operational Research Program and the SBCC. And cross-cutting, we have our environmental strategy. The next slides will be illustrating of what this is about. Example, governance of quality. We have quality scorecards being done in 570 PHCs and 248 hospitals. Institutional arrangements in almost the same number. NQAS in 300 PHCs and 75 district hospitals. NABH in 4 medical colleges. Trauma registries for Thai centers. All districts we are going to conduct health assemblies, and also a state health assembly will be there. NCD, we have a social behavior change strategy being studied upon. And for improve work environment, we have the TANQUAS, the Tamil Nadu Quality Enhanced Structured Training. So these are all the targets there, and what are we are going to read there. And the governance for quality at all the different levels in the state, the district committees and the facility committees there are for you all to see. So these are all the red colored ones in terms of quality certification in NQAS, pre-TNHSRP, that is before the project period. We had only 4 primary health centers and 6, only a total of 10 were there. In 2019, we had this 28 more. So you can see the one in green, that's our target. And the grand total, we have achieved 122. Remember, we had COVID and almost 1.5 years were lost. Nothing was done in those periods, but even then, our system picked up, and these 122 institutions are being accredited in the project period. So that's a great achievement there. And NABH in the 4 medical colleges. So these are all the activities, other things which are completed. All the green ones are completed. The mid ones are ongoing and upcoming. And quality managers, we never had a cadre of quality managers in any of our institutions. Because of TNHSRP, quality managers were there in 14 medical colleges, and 22 the other left out medical colleges will also be having quality managers. And the aim of these managers is to look on quality indicators alone, so that the dean and the other hospital superintendent, etc., will be taking care about the quality of care services, other services on. So this is an annual working program or NCD. NCD we have spoken more about, and Makalitedi Maruthuvam there. Field level surveillance is going on for MTM scheme, whether it is how it is moving on and what is there plan ahead and all. So these are all the things which is there, and this is the emergency department which is being created in 25 medical colleges. Our project director elaborated this in the morning. So establishment of trauma registry, which was not there before. The quality service is being done there in creating 90 trauma registries across the state in 36 medical college institutions and 2 medical college attached institutions, and also 52 secondary healthcare institutions. These are all placed in the grid of the golden quadrilateral, so that the trauma centers will be strategically placed to take care of this. So these are the trauma life support training which was available. Total number of 3,315 doctors and 5,671 paramedics were trained. So ambulances were from pre-project, it was only 65 ambulances in advanced level, and now it is 130. Totally we have a fleet of 1,353 BLS and 132 advanced life supporting ambulance services. So this is about the Thai registry, which was previously in manual mode. Now it is a IT-based Thai registry with real-time portal updates. So this is what this monitoring and evaluation daily is about. We evaluate scripts, STEMI, and all the everything in the Thai app. So this is MD Emergency Medicine course GO obtained. Nammai Kakum 48 there explained in detail, so that the linkage, the absolute budgetary certainty will be there with the trauma care patients there. So this covers everything. Also we take care about definitive care and rehabilitation. So this is it. Almost some 1,12,586 beneficiaries in the government hospitals, private hospitals 11,816, to the total of 1,24,402 victims of RTA were treated and benefited out of this Namme Kakum Napathettu scheme. So cross-cutting activities are there. Environmental strategy, which is a very new concept to the health system. We are going to do this biomedical waste management compliance audit in 4 districts. Energy efficiency audits in 2 hospitals. Anna University Guindy is going to take this audit. And also this liquid waste management, STP and ETP, which was not done before in 3 of DME institutions and 3 of DMS institutions. And the state assemblies are planned also this year. So this is some improvement which we attained. Timely, the response time, the average response time has come down from 18.09 to 13.53 in the state. In Chennai city alone, just imagine our neck-to-neck, bumper-to-bumper traffic. Even then our ambulance response system has come down by 4 minutes. Post-delivery complications is reduced by 5%. So this is a thing which we can boast. The last slide looks like a volley diagram, but this states that systems do change for improved health outcomes. And of course, it's the cross-sector connections. 1, core areas of improvement in clinical, team-based care and link of community resources. So thank you very much for this opportunity. Tamil Nadu is always committed for health-oriented quality activities, and TNHSRP plays a very crucial and cornerstone in these activities. Thank you one and all. Thank you, sir.
Thank you, ma'am, for enlightening us on the quality improved interventions undertaken through TNHSRP. I request our Joint Director, HEB section, Dr. Shanmugasundaram sir, to felicitate the speaker with a memento. Thank you, sir. Thank you, ma'am. And next session is the final session of the day. It is a session for media, for which Tamil Nadu Model of Public Health என்ற தலைப்பில் பேசுவதற்காக வீக் பத்திரிகையிலிருந்து மூத்த பத்திரிகையாளர் திருமதி லக்ஷ்மி சுப்பிரமணியம் அவர்களையும், பொது சுகாதாரம் மகளிர் நலன் என்ற தலைப்பில் பேசுவதற்காக விகடன் குழுமத்திலிருந்து சீஃப் ரிப்போர்ட்டர் திருமதி ஜெனி ஃப்ரீடா அவர்களையும், பொது சுகாதாரத்தின் ஆணிவேர் ஆரம்ப சுகாதார நிலையம் என்ற தலைப்பில் பேசுவதற்காக வின் டிவியிலிருந்து திரு அன்பழகன் அவர்களையும், பொது சுகாதாரம் காலநிலை மாற்றம் என்ற தலைப்பில் பேசுவதற்காக இந்து தமிழ் திசை இருந்து திரு கண்ணன் அவர்களையும் மேடைக்கு வருமாறு அழைக்கிறேன். முதலில் தமிழ்நாடு மாடல் ஆஃப் பப்ளிக் ஹெல்த் என்ற தலைப்பில் பேசுவதற்காக லக்ஷ்மி சுப்பிரமணியம் மேடம்.
Good evening, everyone. Thank you for inviting me to speak among you. Indeed, it is a pleasure because this is an international conference. I never knew that it is going to be so big before I came in here. Thank you so much for inviting me. And my special thanks to Minister, Health Minister, for inviting me here. I want to touch upon certain points because we in the media have been looking into the department for a very long time, and I have had a long career in the media. So I've been looking into it from a different perspective because you all have been working in the department and you all know what actually is happening. But for us, it is a different experience looking at it critically, and also at times we look at it with different perspective. So I just want to touch upon certain things which I felt is important. Please pardon me if I'm wrong or if I make any mistakes. Thank you. With that disclaimer, I just start my speech. Actually, in 2001, Nobel laureate Amartya Sen, in his book Development as Freedom, he mentioned about Tamil Nadu's healthcare model. And today, Tamil Nadu has come, is among the lowest, Tamil Nadu has the lowest maternal mortality rate, leave alone the infant mortality rate. As Professor Sen said or wrote in his book, the same factors, an active but cooperative family planning program is what stands out. Most people might not understand it, but it is the result of a well-crafted policy. Among emergency obstetrics and newborn centers are our own centers are fully equipped with operation theaters, blood storage units, and they are staffed by obstetricians, pediatricians, anesthetists, and other specialists. Our schemes like Dr. Muthulakshmi Reddy Maternity Assistance Scheme, Ramamardam Ammayar Nenevu Marriage Assistance Scheme, these are the most basic two schemes that help the health intakes grow. The other, I would say, is the efforts of the successive Dravidian governments in instituting strong accountability measures at grassroots level, that is the well-built infrastructured public health centers. The PHC network in Tamil Nadu is one of the best, as Dr. Meenakshi Sundari was mentioning here. Ours is the best model and it is being celebrated across the globe. The PHC network is established well. I understand that there are about 1,200 to 2,000 PHCs which are serving us, and they are serving a population of around 30,000 people in each block. These PHCs provide round-the-clock services also. And very recently, Niti Aayog also ranked Tamil Nadu as one of the best performing states in terms of health index. More than all this, I would like to touch upon reservation and its social implications in the health sector to say how and why Tamil Nadu has been successful. The introduction of scheme reserving 50% of the postgraduate and super specialty medical seats for government doctors ushered in a tectonic shift in providing tertiary health care in government hospitals. As a result, in the expansion of public health infrastructure in the state, we have grown so much. This progressive reform paved way for ensuring the availability of all specialists in multidisciplines such as gynecology, anesthesia, general medicine, pediatrics, orthopedics, and general surgery. This was unthinkable of in any other department, and this was unthinkable or sparse in our own state for till 4 decades ago. That is in the 1960s or the 70s, we would have never thought of this. And then came super specialty departments like urology, neurology, nephrology, cardiology, etc. This came up in the late 70s and in the this came up in the late 60s and in the early 70s. It came in our Madras Medical College, if I'm correct. So the provision of reservation actually helped our health sector grow, and our government doctors in the super specialty hospitals also make a mark. And it also made a steady rise in the expert doctors available in the multi-speciality hospitals. This was in the late 80s. But slowly in the tier 2 cities also, and then later even in the smaller towns also, we got specialists at every level. Today our public health system has more than 900 super specialty specialists in different disciplines, if I'm right. In just tier 2 cities, it has more than 900 super specialists. This number, I would say, can't be compared with any of the European model of healthcare system. Our policymakers in Tamil Nadu are always far-sighted, which is why we have come a long way ahead of every other state in India. One such important aspect is introduction of superannuation bonds for the government doctors to ensure that those who secure post-graduation or super specialty seats by availing in-service reservation will serve for the government until retirement. So the main aim of this bond was to prevent brain drain in the healthcare system and in certain specialties. However, now as we all know, the introduction of NEET and Regulation 9 by the Medical Council of India, that the admission policy has undergone a sea change. So the weightage of the government doctors who serve in rural areas might also go down. So my request, and also I request that our government's voice against NEET is heard by the center, and our healthcare system remains intact. Thank you. Thanks so much.
Thank you, ma'am. Thank you for your motivational and appreciative speech. Next, I request Chief Reporter Jenny Frida, madam, for delivering a speech on Podu Sugadharam Magalir Nalan.
அனைவருக்கும் வணக்கம். தமிழகத்தில் முதல் H1N1 கேஸ் வந்ததிலிருந்து தொடர்ந்து ஒரு 15 ஆண்டுகளாக பொது சுகாதாரத்துறையோடும் சுகாதாரத்துறையோடும் இணைந்து பணியாற்றுவதற்கும் ஒரு ஹெல்த் கரஸ்பாண்டண்ட்டாக ஒர்க் பண்ணுறதுக்கு ஒரு சான்ஸ் கிடச்சிருக்கு. ஸோ அந்த எக்ஸ்பீரியன்ஸில் நான் கேதர் பண்ண சில விஷயங்களை தான் நான் உங்க கூட ஷேர் பண்ணுறான்னு இருக்கேன். ஸோ ஹெல்த் சிஸ்டமை பொறுத்த வரைக்கும் தமிழ்நாடு எவ்வளோ பயனியர் அப்படின்னு நமக்கு சொல்லவே வேண்டாம். நிறைய மைல் ஸ்டோன்ஸை நம்ம வந்து ஃபிக்ஸ் பண்ணியிருக்கோம் அதர் ஸ்டேட்ஸ்க்கு. இப்போ ரீசெண்டாக பார்த்தோம் அப்படின்னா கோவிட் அவுட்பிரேக்ஸோட ஃபஸ்ட் வேவில் பெர் டேக்கு 7,000 கேசஸ் வந்து மேக்ஸிமம் ட்ரீட் பண்ணியிருந்தோம். ஸோ நெக்ஸ்ட் வேவ் வரும்போது பார்த்தீங்க அப்படின்னு சொன்னால் 7,000 விட 41,000 கேசஸ் பெர் டே வந்து நம்மளால் ஹேண்டில் பண்ண முடிஞ்சிருந்தது. ஸோ அந்தளவுக்கு நம்மளோட இன்ஃப்ராஸ்ட்ரக்சரும் சரி மேன் பவரும் சரி அதுக்கு ஹெல்ப் பண்ணியிருந்தது. ஸோ இதெல்லாம் சாதனைகள் ஒரு பக்கம் இருந்தாலும் சவால்கள் நமக்கு என்ன இருக்குது அப்படிங்கிறத பார்க்க வேண்டிய கட்டாயத்தில் இருக்கிறோம். முதல்ல நான் நினைக்கிறது வந்து வேக்சினேஷன் ஹெசிடன்சி அப்படிங்கிறது ஒரு பெரிய ப்ராப்ளமாக நான் நினைக்கிறேன். எஸ்பெஷலி சோஷியல் மீடியாஸில் வேக்சினேஷன்ஸ்க்கு எதிராக நிறைய பிரச்சாரங்கள் தொடர்ந்து மேற்கொள்ளப்பட்டுகிட்டே வருது. எந்த ஒரு நோயில் யார் இறந்தாலும் அதை வந்து டைரெக்டாக கொண்டு போய் வேக்சினேஷனோட கனெக்ட் பண்ணுற சிச்சுவேஷன் இப்போ நடந்துகிட்ருக்கு. ஸோ கவர்மெண்ட் வந்து வேக்சினேஷன் ஸ்கீம்ஸை நம்ம எடுத்துகிட்டு போகிறத விட அதை வந்து ப்ராப்பராக ஒரு விழிப்புணர்வு ஏற்படுத்த வேண்டிய கட்டாயமும் நமக்கு இருக்குது. குறிப்பாக பெண்கள் மத்தியில் பெண்கள்கிட்ட வேக்சினேஷன் பற்றி நம்ம எடுத்துகிட்டு போகும்போது அது இன்னும் எஃபெக்டிவாக ஃபேமிலிஸில் வந்து அது ரிஃப்ளெக்ட் ஆகும். ஸோ அந்த ஹெசிடன்சி கொஞ்சம் குறையும் அப்படின்னு நம்புகிறேன். அடுத்த கட்டமாக பார்த்தோம் அப்படின்னு சொன்னால் நம்மளோட பப்ளிக் ஹெல்த் சிஸ்டமோட மெயின் பில்லர்ஸாக பார்க்குறது இன்ஃப்ராஸ்ட்ரக்சர் அண்ட் மேன் பவர். இந்த இன்ஃப்ராஸ்ட்ரக்சர்லாம் நமக்கு இப்போ எந்த பிரச்சனையுமே இல்லை. பட் இப்போ இந்த மேன் பவர் அப்படிங்கிற விஷயத்தை எடுத்துக்கிட்டோம் அப்படின்னு சொன்னால் இப்போ ரீசெண்டாக நம்ம கேள்விப்பட்டிருப்போம் சிவகங்கை டிஸ்ட்ரிக்டில் டாக்டர் அனுஷா அப்படிங்கிற 33 years old டாக்டர் ஒருத்தங்க மாரடைப்புனால உயிரிழந்தாங்க ஒரு ஃபியூ டேஸ் பேக். ஸோ இது தொடர்பாக நம்ம நிறைய டாக்டர்ஸ் கிட்ட ஆக்டிவிஸ்ட் கிட்டலாம் பேசிகிட்டே இருக்கும்போது ஒரு விஷயத்தை திருப்பி சொன்னாங்க. தமிழ்நாட்டில் மொத்தமே வந்து அரவுண்ட் ஒரு 19,500 கவர்மெண்ட் டாக்டர்ஸ் தான் இருக்கிறாங்க. பட் அதுக்கான தேவை அதிகமாக இருக்குது, பணிச்சுமை ரொம்ப அதிகமாக இருக்குது. ஒரு டாக்டராகட்டும் ஒரு மருத்துவ பணியாளராகட்டும் ஒரு ஆள் 4 ஆட்குள்ள வேலையை பார்த்துட்டே இருக்கிற கட்டாயம் ஏற்படுது அப்படின்னு சொல்லிகிட்டு இருந்தாங்க. டாக்டர்ஸை பொறுத்த மட்டும் ஒரு 24 hours டியூட்டி அப்படிங்கிறதும் ஒரு கால் டியூட்டி அப்படிங்கிறதும் பெரிய ஸ்ட்ரெஸ்ஃபுல்லாக இருக்குது. ஸோ அதை விட செவிலியர்கள் உட்பட்ட இதர மருத்துவ பணியாளர்களுக்கும் பணிச்சுமை வந்து ரொம்ப அதிகமாகவே இருக்குது அப்படிங்கிறத வந்து தொடர்ந்து பதிவு பண்ணிக்கிட்டே இருக்காங்க. ஸோ இந்த விஷயத்துலையும் நம்ம கவனத்தில் கொள்ளணும்னு நான் இந்த நேரத்தில் கேட்டுக்கிறேன். வெறும் இன்ஃப்ராஸ்ட்ரக்சரை மட்டுமே வச்சு பப்ளிக் ஹெல்த் சிஸ்டம் கண்டிப்பாக டெவலப் ஆகாது. ஸோ அந்த மேன் பவருக்கு கொடுக்க வேண்டிய மரியாதையும் அவங்களுக்கான அவங்க பக்கங்களில் என்ன தேவைகள் இருக்குது அப்படிங்கிறதையும் நம்ம பார்த்து அதுக்கான விஷயங்களை சரி பண்ணணும்னு நினைக்கிறேன். இப்போ ரீசெண்டாக அடுத்து பார்த்தீங்க அப்படின்னா எம்எம்ஆரில் வந்து 58லேருந்து 54க்கு வந்து நம்ம அதை குறைச்சிருக்கோம். இது பெரிய மைல்ஸ்டோன். இன்னொரு பக்கம் பார்த்திங்க அப்படின்னா செயற்கை கருத்தரிப்பு மையங்கள் வந்து தனியார் மையம் வந்து பெருகிக்கிட்டே இருக்குது. ஸோ இந்த செயற்கை கருத்தரிப்பு மையங்கள் வந்து ஒரு இன்ஃபர்டிலிட்டி ட்ரீட்மெண்ட் அப்படிங்கிறதும் ஒரு எலைட் கிளாஸ்க்கான ட்ரீட்மெண்ட்ங்கிற மாதிரி மாறிக்கிட்டே வருது. சாமானியர்களுக்கான ட்ரீட்மெண்ட் வந்து கவர்மெண்ட்டில் இன்னும் இந்த இன்ஃபர்டிலிட்டி ட்ரீட்மெண்ட் ஆகட்டும் ஐவிஎஃப் போன்ற விஷயங்களாக இருக்கட்டும் கவர்மெண்ட் செக்டரில் நம்ம இன்னும் எஃபெக்டிவாக எடுக்கணும்னு நினைக்கிறேன். கீழ்பாக் மெடிக்கல் காலேஜ் அப்படி ஃபியூ மெடிக்கல் காலேஜஸில் இதுக்கான இனிஷியேட்டிவ் ஸ்டார்ட் பண்ணியிருக்காங்கன்னு தெரியும். பட் ஆல் ஓவர் தமிழ்நாடு இது இன்னும் எஃபெக்டிவாக கொண்டு போகணும் நல்லாயிருக்கும்னு ஃபீல் பண்ணுறோம். அடுத்ததாக பெண்களுக்கு பார்த்தோம் அப்படின்னு சொன்னால் ஹார்மோனல் இம்பேலன்ஸ்ங்கிறது ஒரு பெரிய இஷ்யூவாக இருக்குது. தைராய்டாக இருக்கட்டும் பிசிஓஎஸாக இருக்கட்டும் அவங்களுக்கு வந்து அவங்களோட குழந்தை பேராகட்டும் எல்லாத்துக்கும் இது ஒரு பெரிய இஷ்யூஸாக இருக்குது. என்சிடி ப்ரோக்ராம்ஸ் நம்ம நிறையா முன்னெடுத்துட்ருக்கோம், அதில் மாற்றுக்கருத்து இல்லை. ஆனால் பெண்களுக்கு மையப்படுத்தி இந்த தைராய்டு, பிசிஓடியான அந்த மாதிரியான ஹார்மோனல் இம்பேலன்ஸ்க்கான திட்டங்களை அறிவித்து அதுக்கான விஷயங்களே முன்னெடுக்க வேண்டிய கட்டாயமும் இருக்குது அப்படின்னு நினைக்கிறேன். கடைசியாக ஒரே ஒரு பாயிண்ட் சொல்லிக்கிறேன். நான் லாஸ்ட் மந்த் வந்து கர்நாடகாவில் கஸ்தூரி அப்படிங்கிற தமிழகத்தை சேர்ந்த ஒரு பெண் வந்து அந்த மாநிலத்துக்கான ட்ரீட்மெண்ட் கார்டு இல்லை அப்படின்னு சொல்லிட்டு அவங்கள ஹாஸ்பிட்டலில் அட்மிட் பண்ணல, கர்நாடகாவில் கவர்மெண்ட் ஹாஸ்பிட்டலில். அதனால் அவங்களும் அவங்களோட இரட்டை குழந்தையும் வந்து இறந்துட்டாங்க. ஸோ தமிழகத்தில் இருக்கிற மக்களை பாதுகாக்கிற அரசு அதுக்கான முன்னெடுப்புகள் எடுக்கிறவங்க வெளிநாடுகளில் இருக்கிற நம்மள மாதிரி தமிழ் மக்களுக்கான சிகிச்சைக்கான முன்னெடுப்புகளையும் எடுக்கணும் அப்படின்னு நான் கேட்டுக்கிறேன். நம்ம பயணியராக இருக்கோம், அதில் மாற்றுக்கருத்தே இல்லை. சாதனைகளை சரித்திரம் பேசட்டும், சவால்களை நோக்கி நம்ம வீர்நடை போடுவோம் அப்படின்னு கேட்டுக்கிறேன். தேங்க்யூ.
Thank you, ma'am. Definitely we are working and we'll work on the challenges we are facing. Now I request பொது சுகாதாரம் காலநிலை மாற்றம் என்ற தலைப்பில் பேசுவதற்காக இந்து தமிழிசை திரு கண்ணன் அவர்கள்.
சுகாதாரத்துறை அமைச்சர் அவர்களுக்கும் அனைத்து பொது சுகாதாரத்துறை ஊழியர்களுக்கும் இன்ற நூற்றாண்டு தினவாற்றில் என்னுடைய வாழ்த்துக்களை தெரிவித்துக் கொள்கிறேன். இப்போ வந்து கிளைமேட் சேஞ்ச் வந்து இருக்கிறதுலே பெரும் பிரச்சனையாக மாறிட்டு இருக்கு. இங்கே இருக்கிற எல்லா டாக்டர்ஸும் கிளைமேட் சேஞ்சை பற்றி பேசியிருப்பீங்க, பண்ணியிருப்பீங்க, பழகியிருப்பீங்க. ஆனால் நான் வந்து ஃபீல்டில் இது பண்ண 2 எக்ஸ்பீரியன்ஸில் நான் ஷேர் பண்ணலான்னு நினைக்கிறேன். நான் ஒரு 5 வருஷமாக சென்னை கார்பரேஷன் வந்து கவர் பண்ணிக்கிட்டு இருக்கேன். போன வருஷம் செகண்ட் வேவில் கோவிட்டில் வந்து ஒரு எஸ்ஐட்டை நாங்கள் டெய்லி ஒரு எஸ்ஐ கால் பண்ணுவோம். சார் இன்றைக்கி எவ்வளோ கேஸ் இருக்குது சார், இந்த ஜோனில் எவ்வளோ கேஸ் இருக்குது சார் அப்படின்னு சொல்லுவோம். அன்றைக்கி ஒரு நாள் அந்த எஸ்ஐ வந்து என்கிட்ட என்ன சொன்னார்னா, சார் உங்களுக்கு கேஸு தான் சார் முக்கியம், எங்களுக்கு ஃபுல்லாக வேலை இருக்குது சார், என்ன சார் பண்ண முடியும் நாங்கள் அப்படின்னு கேட்டார். அதுக்கப்புறம் நான் அவர்கிட்ட போய் உட்காந்து தனியாக பேசினேன். அவர் என்ன சொல்கிறாருன்னா, சார் ஒருத்தர் காய்ச்சல் வந்தால் நாங்கள் கொரோனா டெஸ்ட்டும் பண்ண வேண்டியது இருக்குது, டெங்கு டெஸ்ட்டும் பண்ண வேண்டியது இருக்குது. இப்படி வந்து எங்களால் வந்து சமாளிக்கவே முடியல சார். எங்களோட மென்டல் ஸ்ட்ரென்த்து வந்து ரொம்ப ரொம்ப கஷ்டமாக இருக்குது சார். காலையில் 6 மணிக்கு நாங்கள் வேலையை ஆரம்பித்தோம்னா சாயங்காலம் 10 மணிக்கு நாங்கள் வீட்டுக்கு போக வேண்டியிருக்கு சார். எங்களால் முடியவே இல்லை சார். சென்னை கார்பரேஷனில் வந்து 200 எஸ்ஐஸு ப்ளஸ் பெத் அண்ட் டெத்தோட சேர்த்து 220 எஸ்ஐ இருப்பாங்க சார். ஆனால் 100 எஸ்ஐ தான் ஸ்ட்ரென்த் இருக்குது. ஒருத்தவங்க வந்து நாங்கள் 2 பேரை சேர்ந்து பார்த்துக்கிட்டு இருக்கோம் அப்படின்னு சொல்லிட்டு அவர் என்கிட்ட ரொம்ப ரொம்ப கஷ்டப்பட்டு பேட்டினார். இதே தான் ஒன்று நான் கொரோனா இதுலையும் பார்த்தேன். ஏன்னா கொரோனா வந்து இப்போ வந்து செகண்ட் வேவ், தேர்ட் வேவ் சொன்னாங்க. நான் வந்து கொரோனா ஃபஸ்ட் வேவ்லேயே பாதிக்கப்பட்டேன். என்னுடைய கேஸ் நம்பர் இன்னும் ஞாபகம் இருக்குது, 1357. இன்றைக்கி கொரோனா கேஸ் நம்பர் வந்து 35 லட்சம். என்னுடைய கேஸ் நம்பர் 1357. ராஜீவ்காந்தி ஹாஸ்பிட்டலில் டீன் மேம் ஜெயந்தி இருக்கும்போது ரொமட்டாலஜி பிளாக்கில் வந்து 3rd ஃப்ளோரில் எனக்கு ட்ரீட்மெண்ட் கொடுத்தாங்க. கரெக்டாக எனக்கு வந்து ஞாபகம் இருக்குது. அப்போ அந்த கொரோனா ட்ரீட்மெண்ட் அப்போ நாங்கள் ஒவ்வொரு டெய்லி காலையிலையும் ஒவ்வொரு ஹாஸ்பிட்டலுக்கும் கால் பண்ணி இன்றைக்கி எவ்வளோ டெத்து சார் அப்படின்னு கேட்போம். அப்போ வந்து ஒரு டாக்டர் வந்து என்னை வந்து பிடிச்சி கத்தி விட்டார். சார் உங்களுக்கு உசுறு போகிறத மட்டும் நீங்கள் கேட்டுக்கிட்டு இருக்கீங்க, நாங்கள் உசுரை காப்பாற்றிட்டு இருக்கோம் சார் அப்படின்னு கேட்டார். அதுக்கப்புறம் நான் போய் அவர்கிட்ட போய் தனியாக உட்காந்து பேசினேன். அவர் சொல்கிறாரு, சார் நாங்கள் ஒரு நாளைக்கு காலையில் டியூட்டிக்கு வந்தோம்னா எங்களுக்கு முடிச்சு போகிறதுக்கு வந்து நைட்டு 10 மணி 11 மணி 12 மணி ஆகுது சார், எங்களால் சமாளிக்கவே முடியல சார், அது தெரியாமல் சார் நாளைக்கு உங்கள்கிட்ட கத்திட்டேன் இப்படின்னு சொல்கிறாரு. இப்படி இந்த காலநிலை மாற்றத்தால் வந்து ஒரே நேரத்தில் உங்களுக்கு கொரோனாவும் வருது, டெங்கு வருது, மலேரியாவும் வருது, டிசாஸ்டரும் வருது. இப்படி கிளைமேட் சேஞ்சால் நீங்கள் என்ன இது வந்தாலும் அதுக்கு ஃபஸ்ட்டு போய் நிற்க போகிற டிபார்ட்மெண்ட்டாக வந்து சுகாதாரத்துறை டிபார்ட்மெண்ட்டு தான் இருக்குது. ஆனால் வந்து சுகாதாரத்துறை டிபார்ட்மெண்ட்டு மேலே இருக்கிற கண்ணு வந்து அதை யாரும் அதிகமாக பேசுறதில்லை. கார்பன் எமிஷனை குறைக்கிறதுக்கு வந்து நாங்கள் என்ன பண்ணுறோன்னு பேசுகிறாங்க. அதே மாதிரி நிறைய நிறைய இது பொல்யூஷனை குறைக்கிறதுக்கு என்னென்னு பேசுகிறாங்க. ஆனால் காலநிலை மாற்றத்தால் சுகாதார டிபார்ட்மெண்ட்டில் இருக்கிற பாதிப்பு வந்து என்ன ஆகுதுன்னு இன்னை வரைக்கும் தமிழ்நாட்டில் கூட இது வரைக்கும் பேசுனது கிடையாது. தமிழ்நாட்டில் ரீசெண்ட் டேஸில் வந்து தமிழ்நாடு கிளைமேட் சேஞ்ச் கவர்னிங் கவுன்சில்னு ஒரு போட்டாங்க. அதில் முனிசிபல் டிபார்ட்மெண்ட் இருக்குது, டிரான்ஸ்போர்ட் டிபார்ட்மெண்ட் இருக்குது, எல்லா டிபார்ட்மெண்ட் இருக்குது. ஹெல்த் டிபார்ட்மெண்ட் பேரை மட்டும் காணோம். இன்றைக்கி வந்து தமிழ்நாட்டோட கிளைமேட் சேஞ்ச் சம்மிட் நடக்குது. அதுலேயே முனிசிபல் ஹெல்த் டிபார்ட்மெண்ட்டுக்கு ஒரு செஷன் இருக்குது, ஹெல்த் டிபார்ட்மெண்ட் செஷன் இருக்குது, எல்லா டிபார்ட்மெண்ட் மித்த டிபார்ட்மெண்ட் செஷன் இருக்குது. ஹெல்த் டிபார்ட்மெண்ட்டுக்கு அந்த செஷனே கிடையவே கிடையாது. இப்போ வந்து நீங்கள் ஹீட் ஸ்ட்ரெஸ் வருது, அந்த ரீசெண்டாக வந்த யூனிசெஃப் ரிப்போர்ட்டில் வந்து கிளைமேட் சேஞ்ச் டிசாஸ்டர்னால வந்து மால் நியூட்ரிஷன் வந்து ரொம்ப அதிகமாக இருக்குன்னு சொல்லியிருக்காங்க. குறிப்பிட்ட இந்தியாவில் வந்து அந்த மால் நியூட்ரிஷன் வந்து ரொம்ப அதிகமாக இருக்குன்னு சொல்லியிருக்காங்க. அதனால் வந்து மாண்புமிகு அமைச்சர் வந்து எவ்வளவோ பண்ணிகிட்டு இருக்காரு. இந்த சுகாதார 100 வருஷம் நம்ம வந்து இதில் கடந்துட்டோம். பொது சுகாதாரத்துறையின் முன்னோடின்னு நம்ம சொல்லிகிட்டு இருக்கோம். ஆனால் இதை நம்ம முன்னோடியாக இருக்கிறதுக்கு காலநிலை மாற்றத்தால் சுகாதாரத்துறையில் வந்து என்னென்ன பாதிப்பு ஏற்படணும் அதை வந்து கணிச்சு அதுக்குன்னு ஒரு தனியாக குழு அமைச்சு அதெல்லாம் தமிழ்நாடு அரசு செயல்படணும்னு நான் வந்து கேட்டுக்கிறேன். நிறைய இடத்துல நான் வந்து எனக்கு தெரிஞ்சு ராஜஸ்தான் போயிருக்கேன், அஸ்ஸாம் போயிருக்கேன், எல்லா டிபார்ட்மெண்ட்டுக்கும் போயிருக்கேன், எல்லா 10-15 ஸ்டேட்டுக்கு போயிருக்கேன். அந்த ஸ்டேட்டில் நம்மளை மாதிரி இன்ஃப்ராஸ்ட்ரக்சர் வந்து இன்றைக்கும் கிடையாது. ஆனால் காலநிலை மாற்றத்தால் அந்த இன்ஃப்ராஸ்ட்ரக்சரும் ரொம்ப பாதிக்கப்படும் சொல்லியிருக்காங்க. ரீசெண்டாக சென்னை சிட்டியோட கிளைமேட் ஆக்ஷன் பிளான் வந்துச்சு. அந்த கிளைமேட் ஆக்ஷன் பிளானை நிறைய பேர் படிச்சிருப்போம் நான் நினைக்கிறேன். அந்த கிளைமேட் ஆக்ஷன் பிளானால் சீ லெவல் ரைஸ்னால சென்னை சிட்டியில் இருக்கிற பிரைமரி ஹெல்த் சென்டர் ஒரு 10-15 பிரைமரி ஹெல்த் சென்டர் அடுத்த 50 ஆண்டுகளில் கடலுக்குள்ளே மூழ்குன்னு அந்த கிளைமேட் ஆக்ஷன் பிளானில் வந்து சொல்லியிருக்காங்க. அந்த கிளைமேட் ஆக்ஷன் பிளான் நிறைய பேருக்கு தெரிஞ்சிருக்குன்னு நினைக்கிறேன். அதே மாதிரி என்ன சொல்கிறாங்கன்னா, ஒரு இடத்துல வந்து இப்போ வந்து பிரைமரி ஹெல்த் சென்டர் வந்து கடலுக்குள்ளே ஒரு வேளை பாதிக்கப்பட்டுச்சுன்னா அந்த இடத்துல இருக்கிற மக்கள் வந்து அடுத்த ஏரியாவுக்கு போகிறதுக்கு ஒரு ஹெல்த்துக்காண்டி ஒரு மைக்ரெண்ட்டாக போவது இருக்கும். ஹெல்த்து ஒரு இதுக்குனாலே ஒரு அகதியாக அங்கே போக வேண்டிய நிலைமை வந்து வரும்னு சொல்லிட்டு அந்த சென்னை சிட்டி கிளைமேட் ஆக்ஷன் பிளானில் வந்து ரிப்போர்ட்டில் சொல்லியிருக்கு. இதெல்லாம் கவனத்தில் வச்சு தமிழக அரசு வந்து இனி வரும் காலத்தில் வந்து காலநிலை மாற்றத்தை எதிர்கொள்ள ஒரு இதில் வந்து சுகாதாரத்துறையை வந்து ஒரு முக்கியமான துறையாக சேர்க்கணும்னு வந்து நான் வந்து கோரிக்கை வச்சுருக்கிறேன். ரெண்டாவது நான் பார்க்குற முக்கியமான டாபிக் வந்து ஏர் பொல்யூஷன். இப்போ சென்னை வந்து ஏர் பொல்யூஷன் வந்து ரொம்ப அதிகமாகிட்டுருக்கு. ஏர் பொல்யூஷன்னால ஏகப்பட்ட டிசீஸ் வரும்னு சொல்லியிருக்காங்க. குறிப்பாக வந்து அந்த குப்பை மேடுகளுக்கு பக்கத்தில் இருக்கிறவங்களுக்கும் அந்த இண்டஸ்ட்ரிக்கு பக்கத்தில் இருக்கிறவங்களுக்கும் அவங்க எவ்வளவு ஏர் பொல்யூஷனால் பாதிக்கப்படுறாங்கன்ற ஒரு கிளியர் டேட்டா பிக்சரே வந்து தமிழ்நாடு அரசில் வந்து இது வரைக்கும் கிடையவே கிடையாது. ரீசெண்டாக இப்போ தமிழ்நாடு பப்ளிக் ஹெல்த் ஜேர்னலில் வந்து ஒரு ரிசர்ச் பேப்பர் வந்துருந்துச்சு. மெட்ராஸ் மெடிக்கல் காலேஜோட கம்யூனிட்டி மெடிசன் ஸ்டூடெண்ட்ஸ் வந்து பண்ணியிருந்தாங்க. வாணியம்பாடி பக்கத்தில் இருக்கிற குப்பை கிடங்குல அந்த குப்பை கிடங்குல இருக்கிற சுற்றி வந்து அவங்களுக்கு வந்து ஏர் பொல்யூஷனோட பாதிப்பு வந்து எப்படி இருக்குது, அவங்க வந்து ஏர் பொல்யூஷனை பற்றி என்ன நினைக்கிறாங்க அப்படின்னு சொல்லிட்டு ஒரு ரிசர்ச் பேப்பர் சொல்லி வெளியிட்டாங்க. ரிசர்ச் பேப்பரை நான் படித்தேன். அந்த ரிசர்ச் பேப்பரில் வந்து அந்த பொதுமக்கள் எல்லாமே சொல்கிறாங்க, இந்த குப்பை கிடங்குனால தான் எங்களுக்கு வந்து ஏர் பொல்யூஷன் வந்து அதிகமாகுது. அங்கே ஒரு அம்மா அந்த என்ன சொன்னாங்கன்னு நேரடியாக அங்கே பேசும்போது எனக்கு டென்ஷன் ஏன் ஆகுதுன்னே தெரிய மாட்டேங்குது, அப்படி எனக்கு மென்டல் ப்ரெஷராக இருக்குது. அந்த குப்பை கிடங்கு இருக்கிறதுனால அங்கே இருக்கிற நிறைய மக்கள் வந்து அடிக்கடி டென்ஷன் ஆகுறாங்க. அவங்களுக்கு உண்டான வந்து இது வந்து கேன்சர் வந்து அதிகமாகிட்டுருக்கு, கேன்சர் வந்து அதிகமாகிட்டுருக்குன்னு சொல்லிட்டு அந்த பேப்பரில் வந்து தெளிவாக குறிப்பிட்டிருக்கு. எனவே சுகாதாரத்துறை அமைச்சர் வந்து இந்த குப்பை காற்று மாசால இருக்கிற பாதிப்பை வந்து குறைக்கிறதுக்கு நடவடிக்கை எடுக்கணும்னு கேட்டுக்கினேன். முக்கியமாக குப்பை கிடங்குகளுக்கும் இந்த இண்டஸ்ட்ரிக்கும் பக்கத்தில் இருக்கிற மக்களுக்கு வந்து காற்று மாசால குறைக்க இருக்கிற பாதிப்பை வந்து நடவடிக்கை எடுக்கணும்னு கேட்டுக்கிறேன். அந்த பேப்பர்லேயே வந்து ஒரு குறிப்பிட்ட என்ன சொல்லியிருந்தாங்கன்னா, குப்பை கிடங்கு இருக்க பக்கத்தில் இருக்கிற மக்களோட வந்து மக்களுக்கு வந்து ஒரு மந்த்லி ஒன்ஸ் வந்து ஒரு ஹெல்த் ஸ்க்ரீனிங் பண்ணணும், வீக்லி ஒன்ஸ் ஒரு ஹெல்த் ஸ்க்ரீனிங் பண்ணணும், அவங்களோட இதை வந்து கண்டினியூஸாக வந்து மானிட்டர் பண்ணணும் அப்படின்னு வந்து சொல்லியிருந்தாங்க. அதை வந்து தமிழக அரசு வந்து சீக்கிரமே செயல்படுத்துன்னு சொல்லி நான் கேட்டுக்கொண்டு வாய்ப்புக்கு நன்றி கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
Thank you, sir. Thank you for sharing your views. And now I request Anbalagan sir to deliver speech on Podu Sugadharathin Aniver Aramba Sugadhara Nilayam.
அனைவருக்கும் வணக்கம். ஆரம்ப சுகாதார நிலையம் நம்ம எப்படி இன்னைக்கு கல்லூரி வந்தாலும் கூட ஆரம்ப பள்ளியை மறக்க முடியாது. அது மாதிரி இன்னைக்கு எவ்வளோ மருத்துவர்கள் பல்வேறு சாதனைகள் படைத்திருந்தாலும் அதற்கு மூல காரணம் அந்த ஆரம்ப சுகாதார நிலையம் தான். இங்கே நிறைய பேர் மருத்துவர்கள், இளம் மருத்துவர்கள் ஆரம்ப சுகாதார நிலையத்தில் இருந்திருக்கிறீங்க. உங்களுக்கு வாழ்த்துக்கள், பாராட்டுக்கள். ஏன்னா இந்த சின்ன வயசில் நீங்களாம் கடவுளுக்கு நிகர். ஏன்னா கிராமப்புறத்தில் இருக்கிற ஒவ்வொருவருக்கும், ஏன்னா கிராமப்புறத்தில் இருக்கிற விவசாயி தான் எல்லாத்துக்கும் சாப்பாடு கொடுக்குறான். அவன் எல்லாரும் நல்லா இருக்கணும் சாப்பாடு கொடுக்குறான், அவன் நல்லா இருக்கணும் நீங்கள் கொடுக்குறீங்க பாருங்க அந்த மருத்துவ சேவை. இதை விட என்ன வேணும்? ஏன்னா கிராமப்புறத்தில் தொட்டு இன்று வந்து நூற்றாண்டு சாதனைகள் படைத்திருக்கீங்கன்னா அது காரணம் அந்த ஆரம்ப சுகாதார நிலையம் தான். இதற்கு அற்புதமான இந்த மாநாட்டை ஏற்பாடு செய்த அந்த தமிழ்நாடு அரசுக்கு நன்றி, முதல் சுகாதாரத்துறை அமைச்சருக்கு நன்றி தெரிவித்துக்கிறேன். ஏன்னா அவரும் உங்களோடு சேர்ந்து சுற்றி வருகிறார். எனக்கு தெரிஞ்சு ஒரு சுகாதாரத்துறை அமைச்சர் பல மாவட்டங்களுக்கு, குறிப்பாக ஆரம்ப சுகாதார நிலையத்திற்கு அதிகம் சுற்றுப்பயணம் போனவர் அவராக தான் இருக்கும். அதற்கு காரணம் நேரடியாக நீங்கள் மக்களுக்கு சேவையாற்றுவது தான். ஏன்னா எல்லாருமே அந்த ஆரம்ப சுகாதார நிலையத்தில் இருக்கக்கூடிய செவிலியர் முதற்கொண்டு அனைத்து டாக்டர், நான் இந்த நேரத்தில் சொல்றது மருத்துவ பணியாளர்கள் அனைவருமே, ஈவன் டிரைவர் முதற்கொண்டு உங்கள் மருத்துவத்துறையில் இருக்கக்கூடிய அனைவருமே அவர்கள் பாதம் தொட்டு வணங்குகிறேன். ஏனென்றால் நீங்கள் இணைந்த உலகமே கிடையாது. இது வந்து உங்களை வந்து புகழ்ச்சி பேசுறதுக்காக கிடையாது. நான் அனுபவபூர்வமாக தொடர்ந்து உங்களோட பயணிச்சுட்டு இருக்கிறேன். நிறைய பேருக்கு தெரியும், அதிகமாக கேள்வி கேட்பவன் நான் சுகாதாரத்துறையில். நான் வந்துட்டாவே போதும், அங்கே என்னடா பிரச்சனைன்னு தான் பார்ப்பாங்க. ஏன்னா ஆரம்ப சுகாதாரம், நான் ஒரு கிராமத்தில் வீட்டில் பிறந்தேன். எனக்கு வந்து எங்கள் வீட்டில் எங்கள் அம்மாவுக்கு பிரசவம் பார்த்தது யாரு? ஒரு கிராமம், இந்த மேட்டன் சொல்லுவாங்களே அந்த அம்மா, அவங்க தான். அதுவும் இல்லாமல் உங்கள் சேவை வந்து பல்ஸ் போலியோவில் வந்து பெரிய பெரிய லைன்ஸ் கிளப் ஆகட்டும், நானும் லைன்ஸ் கிளப் இருந்தேன். நாங்கள்லாம் வந்து இந்த பல்ஸ் போலியோ போட்டு ரோட்டரி கிளப்பில் வந்து பல்ஸ் போலியோ வந்து ஒரு கேம்ப் போட்டோ போட்டு, அதாவது சொட்டு வந்து விட்டு போட்டோ எடுத்துகிட்டு போயிடுவோம். ஆனால் அதுக்கப்புறம் என் சகோதரி செய்கிறா பாருங்க, அந்த பேக்கை தூக்கிட்டு விட்டு போன ஒவ்வொரு வீடாக தேடி போய் பல்ஸ் போலியோ போட்டு வர்றா பாருங்க. அவர்கள் ஏன்னா இன்னைக்கு பல்ஸ் போலியோவை வந்து மாற்ற முடியாது. நிறைய பேர்த்துக்கு சிக்கன் குடியா பற்றி தெரிஞ்சிருக்கிறதுக்கு வாய்ப்பு இல்லை. 2000 திருப்பி போட்டது சிக்கன் குடியா பொது சுகாதாரத்துக்கு அரசு மருத்துவமனை பலரையும் வர வைத்தது. அது ஏன்னா அரசு மருத்துவமனையில் தான் சிறப்பாக மருத்துவம் பார்ப்பார்கள், உயிரை காப்பாற்ற முடியும்னு போட்டு வந்தாங்க பாருங்க அன்றைக்கு சிக்கன் குடியா. அப்போ ஒவ்வொரு பணக்காரன் நான் பார்த்தேன். இதே கரூர் மாவட்டத்தில் பின்பக்கம் அந்த ஆஸ்பத்திரி வந்தாங்க, பெரிய பெரிய காரை நிறுத்திட்டு உள்ளே போய் அந்த மாத்திரை வாங்கிட்டு வந்தாங்க. ஏன்னா அரசு மருத்துவமனை எப்பொழுதுமே சிறப்பான சேவை தான் பண்ணாங்க. தவறாக புரிஞ்சுக்கிட்டாங்க மற்றவங்க. அதை விட என்னன்னா, நீங்களும் உங்களை நீங்கள் புரிஞ்சிக்கவே இல்லைன்னு தான் சொல்லுவேன். நீங்கள் பவர்ஃபுல்லான ஆளுங்க, உங்கள் பவர் என்னன்னு உங்களுக்கு தெரியல. இன்னுமே தாழ்வு மனப்பான்மையில் இருக்க, வெளியே வாங்க. கிராமப்புறத்தில் இருக்க ஒவ்வொருவரும் நீங்கள் தான் பெரிய ஆளு, நம்ம தான் பெரிய ஆளு. உயிரை காப்பாற்றக்கூடிய நீங்கள் மட்டும்தான் பெரிய ஆளுங்கிற முதல்ல தெரிஞ்சுக்குங்க. ஏன்னா உங்களை மட்டும்தான் கிராமப்புறத்தில் போனேன் கையெடுத்து கும்பிடுறான், அம்மா நல்லா இருக்கீங்களான்ட்டு. முதல்ல கிராமப்புறத்தில் வந்த மருத்துவத்துக்கும் சரி எல்லாத்துக்குமே ஒரு மரியாதை இருக்கும். இன்னைக்கு என்னதான் பெரிய பெரிய ஆஸ்பத்திரியில் உள்ள போனாலும் யாரும் கண்டுக்க விட மாட்டாங்க. ஆனால் கிராமத்துக்கு போய் பாருங்க. ஏன்னா எனது சகோதரிகளுக்கு நீங்கள் மாத்திரை கொடுக்குறீங்க பாருங்க, அனுமிக்கா இருக்கும் போதும் அதே போல எப்போ வந்து அந்த 3 மாதம் அந்த பிரசவம் ஆனது தாய்மை அடைந்த உடனே அவங்கள தொடர்ந்து ஃபாலோ பண்ணிட்டு இருக்கிறீங்க பாருங்க. ஒரு அற்புதமான அடுத்த உயிரை கொண்டு வந்து கீழே விட்டு வைக்க பாருங்க. அடுத்த உயிரை வர வைக்கிற வரைக்கும் நீங்க படக்கூடிய அந்த ஃபாலோ அப் தான் முக்கியம். அதுவும் இல்லாம பிரசவம் ஆனதுக்கு அப்புறம் அந்த மாத்திரையும் அந்த மருந்தும் கொடுக்கறது, குறிப்பா அந்த ஊசி, இத்தனை மாசத்துல இந்த ஊசி போடணும், அத்தனை மாசத்துல அந்த ஊசி போடணும், ஒரு கார்டை கொடுத்தீங்க பாருங்க. ஏன்னா என் பிள்ளைய பத்தி கையோட நான் தொடர்ந்து உங்களோட பயணிச்சுட்டு வர்றேன். அதனால தான் சொல்றேன், ஏன் ஆரம்பத்துக்கு ஆணிவேர்னா, ஆணிவேர் பலருக்கு தெரியாது. ஆனா ஆணிவேர் இல்லைன்னா எதுவுமே கிடையாது. என்ன சொல்லுவாங்க, பில்டிங் ஸ்ட்ராங்கு பேஸ்மெண்ட் வீக்கிற ஒரு படத்தை சொன்ன மாதிரி இங்கே வந்து பேஸ்மெண்ட் ஸ்ட்ராங்கா இருக்கு. தமிழகத்தை பொறுத்தவரை ஆரம்ப சுகாதார நிலையங்கள் பயங்கர ஸ்ட்ராங்கா இருக்கு. என்ன புயல் வந்தாலும் அடிச்சா கவலைப்பட மாட்டோம். நிறைய பேர் சொன்னாங்க, நண்பர்கள் சொன்னாங்க வேலைப்பளு அதிகம். எனது சகோதர சகோதரிகள் வேலைப்பளுவை கவலைப்படாமல் செய்தார்கள், செய்து கொண்டிருக்கிறார்கள், இன்னும் செய்வார்கள். அதனால தான் அமைச்சர் நாங்கள் ஒரு வேண்டுகோள் வைக்கிறோம், உடனடியாக இந்த காலி பணியிடங்களை நிரப்புங்க. ஏன்னா மருத்துவத்துறையில் இருக்கக்கூடிய அனைத்து காலி பணியிடங்களும், டாக்டர் மட்டும் கிடையாது, மருத்துவ பணியாளர்களுடைய அனைத்து காலி பணியிடங்களையும் தயவு செய்து நிரப்புங்கள். 24 மணி நேரமும் பணிபுரியக்கூடிய அடுத்த ஜீவன் ராணுவத்துக்கு அப்புறம் இருக்கிறது சுகாதாரத்துறை மட்டும்தான். ஏன்னா 108 எனக்கு இன்னும் நினைவு இருக்குது, கரூரில் 108 ஆம்புலன்ஸ் 1 இயர் செலிப்ரேஷனில் என்னை பேச சொன்னாங்க. டைம் ஆயிடுச்சு, இந்த மாதிரி தான் நான் எப்போவுமே கடைசியாக தான் பேசுவேன். 1 நிமிஷம் பேசினாலும் பேசிட்டு போயிடணுன்ட்டு. அப்போ பேசும்போது ஒரே ஒரு தடவை சொன்னேன். என்ன சொன்னேன்னா, கடவுள்கிட்ட கும்பிட்டு இருந்தேன். கடவுள்கிட்ட காலைல கும்பிடும் போது சொன்னேன் அந்த ஆள்கிட்ட, என்னைய வர உன்னை பார்க்கவே முடியலன்னு. அது கடவுள் சொன்னார், நீ ஏன் சிரமப்படுற, 108க்கு ஃபோனை போடுனாரு. 108க்கு போனப்பட்ட கடவுளாக வந்து நிற்கிறீங்க நீங்கள். என்ன ஒவ்வொரு முறையுமே அந்த 108ங்கிற ஆம்புலன்ஸில் அவ்வளோ சார். எனக்கு இன்னொரு கோரிக்கை அமைச்சர்கிட்ட வைக்கிற என்ன காரணம்னா, பல இடங்களில் முதல்ல அந்த பைபாஸ் ரோட்டில் அந்த மருத்துவ சேவை இருந்தது, விபத்து ஏற்பட்டால் உடனடியாக தீர்ப்பதற்கு. அதை கொஞ்சம் கொண்டு வாங்க. அதே போல் நான் சென்னை வந்து 4 ஆண்டு ஆகுது. சென்னை வந்ததிலிருந்து தொடர்ந்து உங்களோடு பயணிச்சிட்ருக்கிறேன். குறிப்பாக டிஎம்எஸ் வளாகத்தில் சேர்ந்து டெங்கிலிருந்து ஆரம்பித்ததுங்க பஞ்சாயத்து. டெங்கிலிருந்து கொரோனா இன்னும் ஓய்வு எடுக்காமல் இருக்கீங்க பாருங்கள். இந்த 2 நாள் வேணால் நீங்கள் ஓய்வு இருந்தீங்க, வெளியே போனால் புயல் வெள்ள ஆரம்பிச்சிருச்சு. ஆனால் இருந்தாலும் இந்த உங்களுக்கு அந்த சிறிய ஓய்வை கொடுத்தாங்க பாருங்கள், அவங்களுக்கு ஒரு நன்றி சொல்லணும். பல மாவட்டங்களிலிருந்து நண்பர்கள் வந்திருந்தீங்க. எல்லோருக்கும் குறிப்பாக இளம் மருத்துவர்களுக்கு ஒரு வேண்டுகோள் என்னன்னா, நிறைய பேர் கிராமப்புறத்துக்கு போகிறதுக்கு வந்து வருத்தப்படுறதா சொல்கிறாங்க. எல்லாம் அப்படியே நினைக்காதீங்க, எல்லாருமே கிராமத்திலேருந்து வந்தவர்கள் தான். அங்கே இருக்கிற மரியாதை எங்கேயும் இல்லை. அதை தயவு செய்து கிராமப்புறத்திற்கு பணியாற்றுங்கள். இங்கெல்லாம் 101 தான் இருப்பீங்க, அங்கே நீங்கள் தான் ராஜாவாக இருப்பீங்க. ஆரம்ப சுகாதார நிலையத்துக்கு வேணுங்க, அடிப்படை வசதி வேணுமா நம்ம கேட்டுருவோம். கேட்கலையா சொல்லுங்க, நாங்கள் கேட்குறோம். என்ன கேள்வி கேட்குறோம், அதையும் கேட்டு வைக்கிறோம். ஆரம்ப சுகாதார நிலையத்துக்கு எப்படி வந்து நகர்ப்புறத்தில் இருக்கக்கூடிய ஆரம்ப சுகாதார நிலையங்களில் மருத்துவ அறுவை சிகிச்சைலாம் கொண்டு வந்தீங்களா, அது மாதிரி இன்னும் கிராமப்புறத்தில் கொண்டு வாங்க. கிராமப்புறத்தில் ஒரு 24 மணி நேரம் இருக்கக்கூடிய மட்டும் அறுவை சிகிச்சை இருக்குது. ஆரம்ப சுகாதார நிலையம், பகுதி நேர ஆரம்ப சுகாதார நிலையத்திலையும் மீண்டும் அங்கேயும் போதுமான வசதி கொண்டு வாங்க. போதுமான வசதி கொண்டு வரும்போது அதுக்கு தேவை ஆட்கள் பலம், அந்த பலத்தையும் கொடுங்க. எத்தனையோ செவிலியர்கள் காத்திருக்காங்க, மருத்துவர்கள் காத்திருக்காங்க, மருத்துவ பணியாளர்கள் காத்திருக்காங்க. உடனடியாக காலி பண்ணுங்களை நிரப்புங்க. எப்படி இந்த மாநாடு நடத்துனீங்களோ அது மாதிரி நடத்தணும். மீண்டும் மீண்டும் கோரிக்கை வைப்பது என்னவென்றால், அதாவது குழந்தை பிறக்கும் போதிலிருந்து, பிறப்பதற்கு முன்பிருந்து கல்லறை சேரும் வரை அனைவரையுமே ஒரு கண்காணிப்போடு நீங்கள் பார்த்துட்டு இருக்கிறீங்க. கருத்து என்ன சொல்கிறேனே தெரியல உங்களையெல்லாம். நான் மீண்டும் ஏன்னா நான் பேசுவேன் பவர் பாயிண்டில் வச்சுருந்தேன். அப்புறம் தான் யோசிச்சு பார்த்தேன், இதுக்கு எதுக்கு பவர் பாயிண்ட், பவர்ஃபுல் பாயிண்டாக பேசுவேன். எதுக்கு பவர் பாயிண்ட், நமக்கு பவர் பாயிண்ட்டை போட்டு அது பொம்மை மாதிரி யாரும் அவனுக்கு பிடிக்காது. எண்ணத்தில் மனசில் என்ன தோணுதோ பேசிட்டு போயிட்டே இருக்கணும். ஏன்னா உங்களோட பயணிச்சு எல்லா பிரச்சனையும் அனுபவிச்சு சொன்னேன். கொரோனா தொற்றப்போ கூடவே வந்து என்னை பார்த்தாங்க, பார்த்து போங்க சீக்கிரம் போயிடுவீங்க என்னாங்க. ஏன் உடம்பு செய்து எப்போ சத்தாலும் சுடுகாடு தான், எப்போ போனால் தான் என்ன. ஆனால் என்னை பொறுத்தவரை உங்களோடு பயணிக்கிறதில் பெருமையாக உள்ளது. உங்களோடு சேர்ந்து நாங்களும் இன்று வந்துள்ளோம் என்று நினைக்கும் பொழுது என்ன சொல்கிறேனே தெரியல. இருந்தாலும் மீண்டும் நீங்கள் பல்வேறு சாதனைகள் படைக்க வேண்டும். உங்களுக்கான அனைத்து வசதியும் கண்டிப்பாக மருத்துவத்துறை அமைச்சர் செய்து தருவார். ஏனென்றால் பல்வேறு பணிகளை அவர் தொடர்ந்து செஞ்சிட்டு இருக்காரு. மீண்டும் உங்களுக்கு ஒரு முறை மனமார்ந்த நன்றியையும் பாராட்டுகளையும் வாழ்த்துக்களையும் தெரிவித்து விடைபெறுகிறேன். நன்றி, வணக்கம்.
Thank you, sir, for the encouraging speech. Now I request our OSD Dr. Chitra ma'am and OSD Dr. Vadivelan sir on stage to honor the speakers. Thank you all the speakers. And now we have come to the end of the scientific session. And now the stage is open for the valedictory function. Thank you one and all.
ஹலோ. நிறைவு விழா நிகழ்ச்சி தொடங்குகிறது. வெளியே உள்ள தோழர்கள் அனைவரும் உள்ளே வருமாறு, நிகழ்ச்சி அரங்குக்கு வருமாறு அழைக்கிறோம். அனைவருக்கும் வணக்கம். பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை 100 நிறைவு விழா சீரும் சிறப்புமாக மாமல்லபுரத்தில் நடைபெற்று வருகிறது. இந்த சிறப்பான மாநாட்டில் பேரறிஞர்கள், பேராசிரியர்கள் பல்வேறு தலைப்புகளில் உரை நிகழ்த்தி உள்ளார்கள். 4 நாளாக நடைபெறும் இந்த 100 மாநாடு நிறைவு விழா நாளில் பத்திரிகையாளர் பார்வையில் என்ற வகையில் நிகழ்வை நடத்த வாய்ப்பளித்த மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்களுக்கும், அரசு முதன்மை செயலாளர் அவர்களுக்கும், பொது சுகாதாரத்துறையின் இயக்குனர் அவர்களுக்கும், மக்கள் தொடர்பு அலுவலர் என்ற முறையில் மனமார்ந்த நன்றியை தெரிவித்துக் கொள்கிறேன். இந்த பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை 100 நிறைவு விழா நிகழ்ச்சி தற்போது தொடங்குகிறது. இந்த இனிய நிகழ்ச்சிக்கு பொது சுகாதாரத்துறை இயக்குனர் அவர்கள் தலைமையில் நடைபெறும் இந்த இனிய நிகழ்ச்சி விழா பேருரையாற்ற மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்கள் வருகை புரிந்துள்ளார்கள். இந்த இனிய நிகழ்ச்சி தமிழ் தாய் வாழ்த்துடன் தொடங்குகிறது.
நீராறும் கடலொடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிதில் தெக்கணமும் மதிசிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறன் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
பொது சுகாதாரத்துறையின் இணை இயக்குனர் மருத்துவர் சண்முக சுந்தரம் அவர்கள் வரவேற்று பேசுமாறு அழைக்கிறோம்.
அனைவருக்கும் மாலை வணக்கம். 3 நாட்களுக்கு முன்னதாக இந்த நூற்றாண்டு விழாவை நமது மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறையின் அமைச்சர் அவர்கள் தொடங்கி வைத்தார்கள். 3 நாட்களும் அறிவுபூர்வமான சிந்தனைகளுக்கு வித்திட்ட பேராசிரியர்களுக்கும் எக்ஸ்பர்ட்ஸ் அனைவருக்கும் எனது வணக்கத்தையும் அவர்களை வரவேற்பதிலும் பெருமகிழ்ச்சி அடைகிறேன். மேலும் இந்த நிறைவு விழாவிற்கு வருகை தந்து சிறப்பு விழா பேருரை ஆற்றவிருக்கின்ற நமது மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்களையும், தலைமையுரை ஆற்றி சிறப்புரை செய்யவிருக்கின்ற நமது இயக்குனர் அவர்களையும், என்னுடன் இணைந்து பணியாற்றி கொண்டிருக்கின்ற இணை இயக்குனர்கள், கூடுதல் இணை இயக்குனர்கள், டிபிஹெச் ஓஎஸ்டிஸ் மற்றும் என்னுடன் பணியாற்றி சோதனைகளை சாதனைகளாக்கி குறைகளை நிறைகளாக்கி 100 ஆண்டுகள் கடந்து வர உதவிய அனைத்து உள்ளங்களுக்கும் நன்றியை தெரிவித்துக் கொண்டு அவர்களை வரவேற்பதில் பெருமகிழ்ச்சி அடைகிறேன். நன்றி, வணக்கம்.
அடுத்ததாக பொது சுகாதாரத்துறை இயக்குனர் அவர்களை தலைமை உரையாற்றுமாறு அன்புடன் அழைக்கிறோம்.
மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர்களுக்கும், எங்களோட என்டையர் ஓஎஸ்டி, ஜேடி, டிடி எல்லா அஃபிஷியல்ஸ்க்கும், இது என்னென்னா, நம்ம ஏற்கனவே சொன்ன மாதிரி நம்மகிட்ட ஒரு 184 கேடர் அஃபிஷியல்ஸ் இருக்காங்க, ஒரு 75,000. நேத்திக்கே 2 லேப் டெக்னீஷியன் வந்து என்கிட்ட ரொம்ப குறைபட்டுட்டாங்க, எங்கள் கேடர் மட்டும் விட்டுட்டீங்க அப்படின்னு. ஸோ அந்த மாதிரி எந்த எண்ணங்களும் கிடையாதுங்க. சில டைமில் அந்த நேரம் கருதி மிஸ் பண்ணிவிடுவோம். ப்ளஸ் நம்ம எல்லாமே ஒரு டீம். ஸோ நமக்குள்ள எந்த வேறுபாடுகளுமே கிடையாது. நம்ம எல்லாமே ஒன்றா சேர்ந்து தான் இந்த என்டையர் ஜேர்னி ஆஃப் 100 years we are all travel together. இது அப்படியே இந்த சக்ஸஸும் வந்து நம்ம எல்லாரும் சேர்ந்தது தான், தனிப்பட்ட யாருக்கும் இல்லை. we are work as a team. சொல்லும்போது டாக்டர், நர்ஸு, விஹெச்என், ஹெச்ஏ அப்படின்னு சொல்லிட்டு இருக்குமே ஒழிய இட்ஸ் ஆல் டீம், வில் கண்டினியூ த சேம் திங். அமைச்சரை பொறுத்த வரைக்கும் இந்த இந்த ஆக்டிவிட்டியை நாங்கள் 2ஆக பிரிச்சுக்கிட்டோம் சார். ஒன் பார்ட் வந்து இட்ஸ் செலப்ரேஷன்ஸ் வந்து டிஸ்ட்ரிக்ட் லெவலில் அவங்கள லெவலில் ஸ்போர்ட்ஸு, கல்ச்சுரல், மெனி ஆக்டிவிட்டீஸ் பண்ணாங்க. இந்த பர்டிகுலர் கான்ஃபரன்ஸ் வந்து we want to focus on academic part, the evidence parts, the research aspect. இது எங்களோட இன்னொரு கோர் ஸ்ட்ரென்த்து. இந்த கோர் ஸ்ட்ரென்த்து வளர்ந்தால் மட்டும்தான் அடுத்த லெவல் அடுத்த கட்ட வளர்ச்சி. இப்போ நம்ம நேத்திக்கெல்லாம் நம்ம ஃபுல்லாக என்ன பேசிகிட்டு இருந்தோம், 1980 எப்படி சானிட்டரி அவேக்கனிங் இருந்தது, எப்படி யூகே மாடல் இருந்தது, பப்ளிக் ஹெல்த் ஆக்ட் வந்தது, பப்ளிக் ஹெல்த் கோடு வந்தது, 100 years ஆஃப் ஜேர்னியை பேசிகிட்டு இருந்தோம். பட் பழம்பெருமை தேவை, பட் அது மட்டும் நம்மளோட அடுத்த கட்டத்துக்கு கொண்டு போகாது. ஸோ அந்த அடுத்த கட்ட வளர்ச்சி வேணும்னா ஒரு ஸ்ட்ராங் எவிடன்ஸ் பேஸ்டு பப்ளிக் ஹெல்த் இன்டர்வென்ஷன்ஸ் பண்ணணும். தட் இஸ் த இன்டென்ஷன் ஃபார் திஸ். இதை பண்ணியிருக்கோம் சார். எங்களோட ஒரே உறுதி என்னங்க சார்னா, ஸோ மக்களுக்காக நீங்கள் எவ்வளோ தூரம் ஓடி இருக்கின்றது, வி ட்ராவல் வித் யூ, சீன் வித் யூ. வேக்சினேஷன் போகும்போது ராமநாதபுரத்தில் ஆரம்பித்து பை ரோடு 5 டிஸ்ட்ரிக்ட் முடித்து கோயம்புத்தூரில் போய் முடிச்சிருக்காரு. கன்னியாகுமரியில் ஆரம்பித்து தென்காசியில் முடிச்சிருக்காரு. இந்த மாதிரி ஒரு நாளைக்கு 600-700 கிலோமீட்டர்ஸ்லாம் 4 மாவட்டம் 5 மாவட்டங்கள்லாம் கடந்து வந்திருக்கீங்க சார். எங்கள் துறையிலேருந்து டெஃபினட்டாக இந்த மக்களுக்கு நீங்கள் ஆற்றக்கூடிய இந்த சேவையில் நாங்கள் எப்போதும் உங்களோட இருக்கிறோன்ற உறுதியை எங்கள் எல்லாரோட சார்பாகவும் கொடுக்குறோம் சார். சார் அடுத்தது, இப்போ இந்த ஒரு 4 daysல நிறைய ஆஸ்பெக்ட்ஸை பார்த்தோம் சார். எங்களோட வளர்ச்சி எப்படிலாம் வந்துட்டு இருக்குன்றதையும் பார்த்தோம் சார். இப்போ அடுத்து என்னென்னா, எங்களோட இலக்கு என்ன சார், அடுத்து அனதர் 50 years 100 years எங்கே ஃபோக்கஸ் பண்ணணும், ஒரு 4-5 கோர் ஏரியாவில் நாங்கள் ஃபோக்கஸ் பண்ணால் மட்டும்தான் எங்களோட வளர்ச்சி தொடர்ந்து இருக்கும், எங்களோட அடுத்த லெவல் வரும். இப்போ இந்த கோவிட் வந்து துறைக்கு ஒரு முக்கியத்துவத்தை கொடுத்துச்சு, ஒரு ப்ராமினன்ஸை கொடுத்துச்சு. அதுக்கு காரணம் என்னென்னா, நம்ம மக்களோட மக்களாக சேர்ந்து அவங்களுக்கான சேவையை தொடர்ந்து கொடுத்ததோட எஃபெக்ட் தான். இது கண்டினியூ ஆனோன்னா we need to develop the entire system. ஸோ ஒரு 2-3 ஆஸ்பெக்டில் மட்டும் பார்த்துக்கிறேன் சார். இப்போ அன்பழகன் மீடியாவில் பேசும்போது சொன்னார் வேக்கன்சி, ஹெச்ஆர். எஸ், இட் இஸ் ட்ரூ. இப்போ சாரு வந்த பிறகு இந்த ஹெச்ஆர் பாலிசியில் எங்களுக்கு ரொம்ப சப்போர்ட்டிவாக இருந்திருக்காரு. நியர்லி ஒரு 5,000 டிரான்ஸ்பரண்ட் ட்ரான்ஸ்ஃபர் கவுன்சிலிங்.
See, most of you got benefited in this. So இந்த மாதிரி நிறைய இன்டர்வென்ஷன் பண்ணிகிட்டே இருக்காங்க. இது தொடர்ந்து பண்ணுவார். ஸோ இது ஒன்று வந்து இப்போ எம்ஆர்பிக்கு இப்போ நம்மளோட ஒவ்வொன்றுத்துக்கும் இப்போ எங்கிட்ட டேட்டா இருக்குது. 1021 மெடிக்கல் ஆஃபீஸர் வேகன்சி, 1451 விஹெச்என் வேகன்சி, 677 ஹெச்ஐ வேகன்சின்னு எடுத்துட்டு இன்ஃபேக்ட் இது அமைச்சர் ரிவ்யூ பண்ணிகிட்டே இருக்காரு. வெரி சூன் திஸ் ஹெச்ஆர் பார்ட் வில் பி டேக்கன் கேர். அடுத்து இப்போ எங்கள் அமைச்சரோட என்னன்னா நம்ம கேட்கறதுக்கு முன்னாடி சொல்கிறாரு, உங்களுக்கு இன்னும் கூடுதலாக தேவை இருக்கா, அடுத்து எப்படி இதை எக்ஸ்பேண்ட் பண்ண போகிறீங்க. ஸோ அதுக்கு அமைச்சரே டீட்டெயில் கொடுப்பாரு. பட் எங்களோட ஒரே ரிக்வஸ்ட் என்னென்னா, இதுவரையும் நம்ம இத்தனை வேணும் அத்தனை வேணும் அப்படின்னு தான் கேட்டுட்ருக்கோம். வெறும் வேணும்னு சொன்னால் கவர்மெண்ட்டில் கிடைக்காது. ஸோ வி ஷுட் ஹேவ் அ எவிடன்ஸ், வி ஷுட் ஹேவ் அ நார்ம்ஸ் ஃபார் இட். ஸோ இப்போ மெடிக்கல் காலேஜ்லாம் என்எம்சின்னு ஒரு நார்ம்ஸ் இருக்குது. அவங்க அந்த நார்ம்ஸ் போட்டு எனக்கு காலேஜ் வேணும்னா இவ்வளோ ப்ரொஃபஸர் வேணும், இவ்வளோ அசிஸ்டன்ட் வேணும், இவ்வளோ ஃபேக்கல்ட்டி வேணும் கேட்குறாங்க. அதுக்காக தான் வி ஆர் கோயிங் டு டாக் அபவுட் ஐபிஹெச்எஸ் ஸ்டாண்டர்ட். ஸோ இனிமேல் நாங்கள் கேட்குறோன்னா இந்த ஐபிஹெச்எஸ் ஸ்டாண்டர்ட் பிரகாரம், இந்தியன் பப்ளிக் ஹெல்த் ஸ்டாண்டர்ட் 2022 ரிலீஸ்டு. ஸோ இந்த ஸ்டாண்டர்ட் பிரகாரம் எனக்கு இத்தனை ஹெச்ஆர் வேணும், ஒரு ஹெச்எஸ்சினா எனக்கு ஒரு விஹெச்என் வேணும், ஒரு மேல் காம்பனண்ட் வேணும், 4 ஆஷா வேணும், 2 ஃபீல்டு ஒர்க்கர் வேணும். இது இருந்தால் மட்டும்தான் எங்களால் பண்ண முடியும். சரி, இதை நாம்ஸ் பிரகாரம் எதிர்பார்க்கும். டெஃபினட்டாக அவங்க பர்ஃபார்மன்ஸ் கேட்பாங்க. அந்த பர்ஃபார்மன்ஸை டெஃபினட்டாக நம்மளால் தர முடியும். ஸோ இதில் எந்த சேலஞ்சும் கிடையாது. இதே மாதிரி தான் பிஹெச்சி, இதே மாதிரி தான் ஹெச்எஸ்சி, இதே மாதிரி தான் சிஹெச்சி நம்மளால் கொடுக்க முடியும். ஸோ நம்ம கோர் வந்து பப்ளிக் ஹெல்த் ஸ்டாண்டர்ட் 2022 இதை வச்சு தான் நம்ம முன்னு போகிறோம். இதோட இன்னொரு சேலஞ்ச் என்னென்னா இன்ஃப்ராஸ்ட்ரக்சர். ஸோ இப்போவும் நிறைய என்னோட 16th எவ்ரி 16th நம்ம எல்லா அசோசியேஷனும் மீட் பண்ணுறோம். பெரும்பாலோட குறைபாடுகள் என்ன, நான் தங்கணும்னு நினைக்கிறேன் சார், எனக்கு போதுமான கோட்டஸ் இல்லை, சரியான இல்லாத கோட்டஸில் நான் வாடகை கட்டுறேன், என்னோட இந்த குறைஞ்ச சம்பளத்தில் இது ஒரு 2000 ரூபா 3000 ரூபா கூடுதலாக செலவாகுது. ஸோ இதெல்லாம் நாங்கள் அட்ரஸ் பண்ணுறோம் சார். இப்போ என்னென்னா, இது ஒரு பெரிய அளவில் அசஸ்மெண்ட் எடுத்து ஒரு நியர்லி 1400 இன்ஸ்டிடியூஷன்ஸை இம்மீடியட்டாக அப்கிரேட் பண்ணால் மட்டும்தான் நம்மளால் இந்த ரியல் சர்வீஸாக ஃபீல்டில் கொடுக்க முடியும். அது செப்பரேட் ப்ரப்போசல்ஸ் மூவ் பண்ணிட்டு இருக்கோம் சார். இதையும் வந்து ஐபிஹெச்எஸ் ஸ்டாண்டர்ட் உள்ள நார்ம்ஸில் ஃபிட் இன் பண்ணுறோம். சரி, அவங்க திருப்பி எதிர்பார்க்கறது வெதர் யூ கேன் டெலிவர் சர்வீஸ். பட் என்னோட கான்ஃபிடென்ட் என்னென்னா, வித் யூ பீப்புள் இன் த ஃபீல்ட் டெஃபினெட்லி வி கேன் டெலிவர் த சர்வீஸ். ஈவன் பியாண்ட் தர் எக்ஸ்பெக்டேஷன் யூ கேன் டெலிவர் த சர்வீஸ் சார். அடுத்து இதே ப்ராப்ளம் என்னென்னா, எங்களோடது எல்லாமே அந்த கலப்பணி. சரி, கலப்பணிக்கு நமக்கு மெயினாக தேவை மொபிலிட்டி. ஸோ மொபிலிட்டி வெறும் டிஏடிஏ மட்டும் இல்லாமல் வாகனங்கள். சரி, இப்போ ஒரு தனிப்பட்ட ஆளுக்கு வாகனம் இல்லைனாலும் நம்ம குழுவாக போகிறதுக்கு வாகனங்கள் வேணும். ஸோ அதுக்கான இதுவும் ப்ரப்போசல் கொண்டு வந்திருக்கோம் சார். அரௌண்ட் 500 vehicles we are planning. இதெல்லாம் வந்து ஒரு ஸ்டேஜில் நம்ம துறைக்கு அலாட் பண்ணி கண்டமாகி ரீப்ளேஸ் பண்ண முடியாமல் இருக்கக்கூடிய வெஹிக்கிள் இந்த இதையும் கொண்டு வர போகிறோம் சார். செகண்ட் பார்ட் வந்து திஸ் அபவுட் இன்ஃப்ராஸ்ட்ரக்சர். இது ஒரு வேர்டில் சொல்லிட்டேன். இது ஹெச்ஆர், பில்டிங்கு எல்லாம் சேர்ந்தது தான் இன்ஃப்ராஸ்ட்ரக்சர் டெவலப்மெண்ட் ஐபிஹெச்எஸ் ஸ்டாண்டர்ட். செகண்ட் காம்பனண்ட் நம்மளோட ஃபோக்கஸ் ஐடி. சரி, இப்போ எல்லாருமே ஐடி பேசினாங்க. இனிமேல் நம்மளால் மேனுவல் ரிப்போர்ட்டாக எல்லாத்தையும் கொண்டு வர முடியாது. சரி, இப்போ நம்ம அடுத்த லெவல் என்ன பேசுகிறோம், ஆர்டிஃபிஷியல் இன்டெலிஜென்ஸ், விஷுவல் ரியாலிட்டி, டிசிஷன் சப்போர்ட் சிஸ்டம், அடுத்த லெவலுக்கு போயிட்டோம். சரி, இப்போ நீங்கள் சாதாரணமாக மொபைலில் டைப் பண்ணிட்டா கூட அது உங்களுக்கு ப்ரிடிக்ட் பண்ணுது. ஸோ இந்த மாதிரி நீங்கள் பண்ணுற ஒவ்வொரு ஆக்டிவிட்டியும் நம்ம மெஷினில் கொண்டு போக ஆரம்பித்தோம்னா திஸ் வில் கிவ் யூ டிசிஷன் சப்போர்ட். இதெல்லாம் ஈஸியாக அடாப்ட் பண்ண முடியும். ஸோ திஸ் இஸ் அவர் நெக்ஸ்ட் லெவல். இது ஏன் பண்ண முடியுமானா தாராளமாக பண்ண முடியும். இப்போ 2 வருஷமாக அமைச்சர் வந்த உடனே நம்மளோட டிபிஹெச்சோட நியூஸ் லெட்டர் ரிலீஸ் பண்ணார். 15 நாளைக்கு ஒரு முறை ரிலீஸ் பண்ணுறோம். உங்களோட ஆக்டிவிட்டி தான் ஃபோக்கஸ் பண்ணுறோம். நவ் இட் இஸ் 2 years சக்ஸஸ்ஃபுல் இட் இஸ் ரன்னிங். இதே மாதிரி நிறைய விஷயங்கள் நம்மளால் பண்ண முடியும். அண்ட் அனதர் ஈஸியஸ்ட் ரீச் இஸ் த சோஷியல் மீடியா. இந்த ஐடியை நம்ம யூட்டிலைஸ் பண்ணோம். நம்மக்கிட்ட 2 தான் இப்போதைக்கு இருக்குது. நம்ம தாய்மைன்ற ஒரு அப்ளிகேஷன் டு ட்ராக் த மதர் அண்ட் யுவர் சிஆர்எஸ். ஸோ இதை தாண்டி நம்ம பண்ணணும். இதில் நமக்கு அட்வான்டேஜ் என்னென்னா, எல்லாரும் இப்போ மொபைல் யூஸ் பண்ணுறாங்க, ஆண்ட்ராய்டு இருக்குது, பெனட்ரேஷன் இஸ் பெட்டர். வாட்ஸ்அப்பில் எல்லா அப்ளிகேஷன் யூஸ் பண்ணும்போது அந்த எம்பவர்மெண்ட். சி, ஃபார் எக்ஸாம்பிள் உன்னோட ஏன் மதர்ஸை எப்பப்பெல்லாம் செக்அப் பண்ணணும், எப்பப்பெல்லாம் உனக்கு கவர்மெண்ட்டோட பெனிஃபிட்ஸ் கிடைக்கணும், இது கிடைக்கலன்னா என்ன பண்ணணும், எங்கெங்கெல்லாம் உனக்கு டேஞ்சர் சைன், இது இருந்தால் யார் அப்ரோச் பண்ணணும், இந்த மெசேஜ் வந்து அவங்க மொபைலில் ஆட்டோமேட்டிக்காக தேவையான நேரத்தில் வர வச்சுட்டோம்னா தட்ஸ் எண்ட் ஆஃப் இட். ஈஸியாக நம்மளால் பண்ண வைக்க முடியும், பண்ணலாம். ஸோ அடுத்த லெவல் வந்து ரிசர்ச், எவிடன்ஸ் பேஸ் தான். இப்போ ஒவ்வொரு துறையும் வளர்றதுக்கு காரணமே அவங்கக்கிட்ட அந்த ஸ்ட்ராங் எவிடன்ஸ் பேஸ் இருக்குது. நம்மக்கிட்ட நிறைய டேட்டா இருக்குது, பட் நம்மளால் அதை இன்டெலிஜென்ட்டாக கன்வெர்ட் பண்ண முடியல. ஸோ இந்த பார்ட் தான் அக்செப்ட் பண்ண முடியும். இன்ஃபேக்ட் நம்மளோட துறையோட அமைச்சரும் சரி, செக்ரட்டரியும் சரி, உங்களோட எந்த கேட்டகரி ஆஃப் லெவல் ஸ்டாஃபாக இருந்தாலும் இப்போ இவங்க ரிசர்ச் ஆர்டிகல் சப்மிட் பண்ண போனாவோ இல்லை ஏதாவது ஒரு ஆக்டிவிட்டி டெவலப் பண்ண போனாவோ, ஈவன் இப் இட் இஸ் ஃபார் எ ஃபாரின் ட்ராவல், டெஃபினெட்லி he said he will accept it. ஸோ இதுக்கு அடுத்த வளர்ச்சி என்னென்னா, நாமளும் இதை டாக்குமெண்ட் பண்ணோம். ஸோ இப்போ இன்றைக்கி நாங்கள் எதிர்பார்த்தோம் ஏதோ ஒரு 50 பேர் வருவாங்கன்னு, ஆயிரக்கணக்கில் வந்தாங்க. ரிசர்ச் பேப்பர் யார் போட போகிறாங்க அப்படின்னு நினச்சோம். இட் ஹஸ் கிராஸ்ட் 250 or 280. ஸோ இது ரெகுலர் ஸ்பெஷாலிட்டி கான்ஃபரன்ஸில் கூட இவ்வளோ வராது. அதுவும் நாங்கள் ரொம்ப ஷார்ட் டைம் தான் கொடுத்தோம். இப்போ இன்னும் டைம் கொடுத்து இன்னும் கொஞ்சம் மோட்டிவேட் பண்ணி ஃபெசிலிட்டி பண்ணியிருந்தோம்னா அவர் நம்பர்ஸ் குட் ஹவ் பீன் எக்ஸப்ஷனல். ஸோ இதை நம்ம எப்படி ஃபர்தராக டேப் பண்ணுறதுன்னா, இப்போ அமைச்சரோட ரிக்வஸ்ட் எங்களுக்கு என்ன கொடுக்க போகிறோம்னா, எவ்ரி இயர் இது ஒரு ஆனுவல் ஈவெண்ட்டாகவே வைக்கணும். ஸோ இட் நீட் நாட் டு பி 4 நாள் 5 நாள் இல்லைன்னாலும் ஈவன் ஃபார் 2 days அந்த அகடமிக் இன்ட்ரெஸ்ட் உருவாக்கணும். அண்ட் இன்னொரு பெரிய விஷயங்கள்னா, இது ஒரு இடம் தான் நம்ம எல்லாரும் ஒன்றா சேர்ந்து ஒரு 24 hours நம்மளால் ஃப்ரீயாக பேசி எக்ஸ்சேஞ்ச் பண்ணி ஒரு டீமை பில்ட் பண்ண முடியும். இந்த ஆப்பர்ச்சுனிட்டியை we will see to that we are having it on every year. அடுத்து இன்னும் ஒரு ஏரியா வந்து நமக்கு நல்ல எலிமினேஷனுக்கு நல்ல ஒரு பிளாட்ஃபார்ம் இருக்குது. வெதர் இட் இஸ் மீசல்ஸ், ருபெல்லா ஆர் லெப்ரசி ஆர் டிபி. சரி, நமக்கு கிடைச்சிக்கிற இந்த ஆப்பர்ச்சுனிட்டி நமக்கு சுச்சுவேஷன் மட்டும் இல்லை, ஒரு பெரிய பொலிட்டிக்கல் அட்வான்டேஜ் இருக்குது. சி, என்ன ஒரு ஹெல்த் அஜெண்டாவை மூவ் பண்ணனாலும் யூ நீட் ஏ பொலிட்டிக்கல் சப்போர்ட், யூ நீட் ஏ மினிஸ்ட்ரியல் சப்போர்ட். இப்போ நம்ம கூட வந்து நம்ம அமைச்சர் வந்து தொடர்ந்து செயல்படுறாரு, ஊக்குவிக்கிறார். இந்த மாதிரி ஒரு ஆப்பர்ச்சுனிட்டி யூ வில் நாட் கெட் இட். வி வில் டேப் திஸ் ஆப்பர்ச்சுனிட்டி ஃபார் திஸ் எலிமினேஷன். அடுத்து இன்னும் 2-3 ப்ரோக்ராம் இருக்கிறதால ஐ ஜஸ்ட் சிம்பிளி வாண்ட் டு சே தட் நம்மளோட துறையோட முக்கியத்துவம் நம்ம கஷ்டப்பட்ட 2 வருஷம் இல்லைன்னு சொல்லலை. பட் திஸ் இஸ் வாட் இஸ் கிவன் டு த ஃப்ரண்ட் லைன். உங்களோட டிஸ்ட்ரிக்டில் நீங்கள் எல்லாம் பார்த்தீங்கன்னா யூ கேன் சிம்பிளி கால் அப் ஆன் த கலெக்டர் அண்ட் ஹேவ் எ டீ வித் ஹிம். ஸோ இந்த அக்சசிபிலிட்டி வந்தது காரணம் நம்ம செஞ்ச வேலை. ஸோ இது இந்த வேலையை நம்ம வேலையாக நினைக்காம இப் யூ ஆர் ஏபிள் டு கீப் அப் யுவர் ப்ராமினன்ஸ் பை கண்டினியூஸ்லி ஃபோக்கஸ் ஆன் பப்ளிக் சர்வீஸ். ஸோ அந்த பப்ளிக் சர்வீஸ், பப்ளிக் ரீச் மட்டும் தொடர்ந்து பண்ணிகிட்டே இருந்தோம்னா we can do wonders. See, இப்போ நம்ம வெளியில் நம்ம ட்ராவல் பண்ணி வரோம்ல, அவங்க எல்லாரும் என்ன கேட்குறாங்க, எனக்கு மெடிக்கல் காலேஜ் வேணும்னு யாரும் கேட்க மாட்டாங்க. எல்லாரும் எனக்கு HSC வேணும், PHC வேணும். இதுதான் வந்து எவர்ஒன்ஸ் டிமாண்ட். ஏன்னா யூ ஆர் த ஒன் ஹூ ஆர் ரீச்சிங் த பப்ளிக். உங்கள்கிட்ட தான் அந்த மக்களோட தொடர்பு இருக்குது. பொலிட்டீஷியன் நல்லா தெரியும் எது எதெல்லாம் மக்கள் தொடர்பு இருக்கோ அதுதான் தேர் டிமாண்ட். ஸோ இது நல்ல சுச்சுவேஷனை வில் யூஸ் இட். அப்புறம் ஃபைனலி ஜஸ்ட் டு கம்ப்ளீட் இட், இதெல்லாம் நிறைய விஷயங்களாக தெரியலாம், பட் ஆல் பாசிபிள் இப் யூ டூ இட். இது எனக்கு ஜஸ்ட் ஒரு மெசேஜ் அனுப்பிச்சிருந்தார் ஒரு ஃப்ரெண்டு. சி, வானளவு லட்சியம், கடலளவு நம்பிக்கை, மலையளவு முயற்சி, இதெல்லாம் தொடர்ந்து பண்ணோம்னா விண்ணை தாண்டி வரும் வெற்றி உனக்கு. வாழ்த்துக்கள். தேங்க்யூ.
அடுத்ததாக நூற்றாண்டு நிறைவு மாநாட்டு சிறப்பு மலர்களை மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நலத்துறை அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். முதலாவதாக மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை தமிழகத்தில் பிறப்பு இறப்பு பதிவு செயல்பாடுகள் குறித்த வரலாற்று பதிவு பற்றிய புத்தகத்தை மாண்புமிகு அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். மேடையில் உள்ள முன்னணியினர் அனைவரும் பெற்றுக்கொள்கிறார்கள். அடுத்ததாக 2013-2022 முதல் பிறப்பு இறப்பு பதிவு தொடர்பான அரசு மற்றும் பொது சுகாதாரத்துறையின் செயல்பாட்டு நடைமுறைகள் ஆணைகள் அடங்கிய தொகுப்பு 1 மற்றும் தொகுப்பு 2 புத்தகங்களை மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்கள் வெளியிட மேடையில் உள்ள முன்னணியினர் அனைவரும் பெற்றுக்கொள்கிறார்கள்.
எவ்ரி நம்பர் கவுண்ட்ஸ் அப்படின்னு இந்த ஸ்டாட்டிஸ்டிக்கல் புக்கு வந்து இப்போ ஜேடி எஸ்பிஹெச்ஏ அண்ட் டீம் அவங்க சேர்ந்து பண்ணியிருக்காங்க. 5 வருடங்களாக நம்ம மாநிலத்தில் என்னென்ன நடந்ததோ அதை வந்து நம்பர்ஸும் கிராஃப்ஸ் இன்ஃபோகிராஃபிக்ஸாக அவங்க போட்டிருக்கிறாங்க. அதான் இந்த புக்கு.
அடுத்ததாக பொது சுகாதாரத்துறையுடன் இணைந்து யூனிசெஃப் தயாரித்துள்ள ஸ்டேட்டஸ் ஆஃப் கோல்ட் செயின் பாயிண்ட்ஸ் இன் தமிழ்நாடு பேஸ்லைன் அசஸ்மெண்ட் புக் மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நலத்துறை அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். அடுத்ததாக தமிழகத்தில் கோவிட்-19 தொற்றை எதிர்கொண்டு அதனை கட்டுப்படுத்திய செயல்பாடுகள் பற்றிய பதிவு ப்ராசஸ் டாக்குமெண்ட் அடங்கிய ஆவணத்தை மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நலத்துறை அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். அடுத்ததாக பொது சுகாதாரத்துறையில் பல்லாண்டுகளாக அறிவிக்கப்பட்ட சுற்று அறிக்கைகள் மற்றும் அரசு ஆணைகள் அடங்கிய தொகுப்பு புத்தகங்கள் மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நலத்துறை அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். அடுத்ததாக பொது சுகாதாரத்துறையில் செயல்படுத்தப்படும் திட்டங்கள் பற்றிய 1 பேஜர் என்ற திட்டங்களின் தொகுப்பு புத்தகத்தை மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நலத்துறை அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். அடுத்ததாக பொது சுகாதாரத்துறையில் அலுவலர்கள் மற்றும் பணியாளர்கள் 100 கொண்டாட்டத்தை சிறப்பு செய்யும் விதமாக தங்களுடைய வாழ்த்துக்களையும் எண்ணங்களையும் கவிதை கட்டுரை மூலமாக வெளிப்படுத்திய தொகுப்பு புத்தகம் மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்கள் வெளியிடுகிறார்கள். அடுத்ததாக மாண்புமிகு அமைச்சர் அவர்கள் டிபிஹெச் ஐகான் 2022 வின்னர்ஸ் லிஸ்ட் ஓரல் பிரசன்டேஷனில் சிறப்பாக செயல்பட்ட டாக்டர் விது வர்ஷா இன்ஸ்டிடியூட் ஆஃப் சைல்டு ஹெல்த் ஹாஸ்பிட்டல் ஃபார் சில்ட்ரன் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அவர்களுக்கு மாண்புமிகு அமைச்சர் அவர்கள் சான்றிதழையும் நினைவு பரிசையும் வழங்குகிறார்கள். செஷன் 2 டிஆர் செந்தில் டிபிஹெச் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 3 ஹிர்லேகா ஸ்டான்லி மெடிக்கல் காலேஜ் சென்னை அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 4 டாக்டர் பி நிர்மலா தேவி திருநெல்வேலி மெடிக்கல் காலேஜ் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 5 டாக்டர் சுனிதா தூத்துக்குடி மெடிக்கல் காலேஜ் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 6 சுதாகர் நடராஜன் ஐசிஎம்ஆர் நேஷனல் இன்ஸ்டிடியூட் ஆஃப் ரிசர்ச் இன் டியூபர்குலோசிஸ் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 7 ராதா லட்சுமி டைரக்டரேட் ஆஃப் பப்ளிக் ஹெல்த் அண்ட் பிரிவென்டிவ் மெடிசன் சென்னை அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 8 இமானுவல் ஜோஷ்வா பனாரஸ் இந்து யூனிவர்சிட்டி வாரணாசி அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 9 டாக்டர் விக்னேஸ்வர் எஸ்ஆர்எம்சி அண்ட் ஆர்ஐ ஸ்ரீஹேர் சென்னை அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 10 டாக்டர் சங்கர் பிரசாத் சண்முகநாதன் டிபிஹெச் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். செஷன் 11 டாக்டர் பாக்யலட்சுமி டிபிஹெச் விழுப்புரம் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அடுத்ததாக டிபிஹெச் ஐகான் 2022 வின்னர்ஸ் லிஸ்ட் போஸ்டர் பிரசன்டேஷனுக்கான விருதுகள் சிறப்பிக்கப்படுகிறது. டாக்டர் ஷஹனா ஸ்ரீ பெங்களூர் மெடிக்கல் காலேஜ் அண்ட் ரிசர்ச் இன்ஸ்டிடியூட் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அவரை தொடர்ந்து டாக்டர் அகிலன் ரமணி தனசேகரன் ஐசிஎம்ஆர் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அஸ்கர் டஸ்டேக்கர் நேஷனல் இன்ஸ்டிடியூட் ஃபார் ரிசர்ச் இன் டியூபர்குலோசிஸ் சேட்பட் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். டாக்டர் மகாதேவன் ஜிப்மர் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். மிஸ்ஸஸ் அம்பிகா டிஎம்சிஹெச்ஓ மயிலாடுதுறை அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். Quiz Winners PG டாக்டர் கொஸ்டான்ஷியா டுபிட்டா எம்எம்சி டாக்டர் கீர்த்தனா ஆகியோரை மேடைக்கு வருமாறு அழைக்கிறோம். அடுத்ததாக ஜிப்மர் டாக்டர் அனுராக் கோலா டாக்டர் கார்த்திக் ராஜன் ஆகியோரை மேடைக்கு வருமாறு அழைக்கிறோம். எம்எம்சி டாக்டர் சரத் டாக்டர் வினோத்குமார் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அவரை தொடர்ந்து குவிஸ் பின்னர்ஸ் மெடிக்கல் ஆஃபீஸர் டிபிஹெச் டாக்டர் விஜயானந்த் டாக்டர் சங்கர் பிரசாத் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அவர்களை தொடர்ந்து டிபிஹெச் டாக்டர் ஏ பிரசன்னா டாக்டர் எம் மணிரத்னம் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அடுத்ததாக டிபிஹெச் டாக்டர் பொன் பார்த்திபன் டாக்டர் தினேஷ் பாபு அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அவர்களை தொடர்ந்து குவிஸ் பின்னர்ஸ் ஸ்டாஃப் நர்ஸ் ஜேஎம் ஷர்மிளா அவர்களை பி சுபத்ரா அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். ஜே சௌபகையா சரஸ்வதி அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். சபிதா குமாரி விக்டோரியா வெர்னிகா கிரிம்ஸ் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். அடுத்ததாக குவிஸ் பின்னர்ஸ் ஹெல்த் இன்ஸ்பெக்டர் ரகுபதி அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். திரு மதுரம் பிரைட்டன் அவர்களையும் திரு எம் செந்தில்குமார் அவர்களையும் மேடைக்கு வருமாறு அழைக்கிறோம். அடுத்ததாக திரு என் பாலாஜி திரு சிவசங்கர் அவர்களை மேடைக்கு வருமாறு அழைக்கிறோம். நன்றி ஐயா. தற்போது நூற்றாண்டு நிறைவு கொண்டாட்டம் 101வது பிறந்த நாளை பொது சுகாதாரத்துறை கொண்டாடும் வகையில் மாண்புமிகு அமைச்சர் அவர்கள் பொது சுகாதாரத்துறை சார்பாக கேக் வெட்டி கொண்டாடும் தருணம் இது. மாண்புமிகு அமைச்சர் அவர்கள் தலைமையில் 101வது பொது சுகாதாரத்துறை பிறந்தநாள் கொண்டாட்டம் தொடங்குகிறது. மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்கள் விழா பேருரை ஆற்றுமாறு அன்புடன் அழைக்கிறோம்.
பொது சுகாதாரம் மற்றும் நோய் தடுப்புத்துறை நூற்றாண்டு நிறைவு விழா நிகழ்ச்சியின் நிறைவு பகுதிக்கு நாம் வந்திருக்கிறோம். கடந்த 4 நாட்களாக மிகுந்த எழுச்சியுடனும்
ஆரவாரத்துடனும் மிக சிறப்பான வகையில் நடைபெற்ற நிகழ்வுகளின் இறுதி பகுதி. இந்த நிகழ்ச்சிக்கு வருகை தந்து இங்கே சிறப்புரையாற்றி சிறப்பித்து விட்டிருக்கிற பெருமதிப்பிற்குரிய டிபிஎச் மரியாதைக்குரிய மருத்துவர் செல்வ விநாயகம் அவர்களே, ஓஎஸ்டி திருமதி சித்ரா அவர்களே, மருத்துவர் வடிவேலன் அவர்களே, கூடுதல் இயக்குநர்கள் சேகர் அவர்களே, சேரன் அவர்களே, சோமசுந்தரம் அவர்களே, திருமதி பவானி அவர்களே, தேவபார்த்தசாரதி அவர்களே, ஜெரால்டு மதிய செல்வம் அவர்களே மற்றும் வருகை தந்து சிறப்பித்துக் கொண்டிருக்கிற இணை இயக்குநர்களே, துணை இயக்குநர்களே, நகர்நல மருத்துவ அலுவலர்களே, மருத்துவ அலுவலர்களே, செவிலியர்களே, மருந்தாளுநர்களே, ஆய்வக நுட்புணர்களே, களப்பணியாளர்களே, வருகை தந்து சிறப்பித்துக் கொண்டிருக்கிற பத்திரிகையாளர்களே, ஊடகவியலாளர்களே, பல்வேறு ஆராய்ச்சி கட்டுரைகளை வழங்கி உரை நிகழ்த்தி சிறப்பித்திருக்கிற பெருமதிப்பிற்குரிய துறை சார்ந்த அலுவலர் பெருமக்களே, உங்கள் அத்துணை பேருக்கும் முதற்கண் என்னுடைய நன்றி கலந்த வணக்கத்தினை தெரிவித்துக் கொள்கின்றேன். தமிழகத்தில் எனக்கு தெரிந்து அரசு துறைகளின் சார்பில் இதுபோன்ற மாநாடுகள் அல்லது கலந்தாய்வு நிகழ்ச்சிகள் அல்லது கருத்தரங்க நிகழ்ச்சிகள் அல்லது துறை சார்ந்த விவாதங்கள் என்கின்ற வகையில் பலவற்றை நான் நேரிலும் பார்த்திருக்கிறேன், கேட்டறிந்தும் கொண்டிருக்கிறேன். ஆனாலும் கூட ஒரு 4 நாட்கள் 1586 பேர் பதிவு செய்து ஒரு துறையை சார்ந்தவர்கள் மட்டுமே, மருத்துவர்கள், செவிலியர்கள், மருந்தாளுநர்கள், சுகாதார ஆய்வாளர்கள், தன்னார்வலர்கள், WHO, யுனிசெஃப், உலக வங்கி, சிடிசி போன்ற பல்வேறு அமைப்புகளைச் சேர்ந்த இவ்வளவு பேர் ஒருங்கிணைந்து ஒரு நிகழ்ச்சியை நடத்துவதென்பது சாதாரணமான விஷயம் அல்ல. அது இன்றைக்கு சாத்தியமாகி இருக்கிறது. சாத்தியப்படுத்துதலை வெற்றிகரமாக நிறைவேற்றியிருக்கிற பெருமதிப்பிற்குரிய டிபிஎச் மருத்துவர் செல்வ விநாயகம் அவர்களுக்கு முதலில் நம்முடைய பாராட்டுக்களையும் வாழ்த்துக்களையும் தெரிவித்துக் கொள்கிறோம். அண்மையில் நானும் துறையின் செயலாளரும் நம்முடைய டிபிஎச் அவர்களும் வணக்கத்திற்குரிய தமிழகத்தின் முதல்வர் அவர்களின் வழிகாட்டுதலின்படி சிங்கப்பூரில் நடைபெற்ற வேர்ல்டு ஒன் ஹெல்த் காங்கிரஸ் என்கின்ற ஒரு மாநாட்டில் பங்கேற்கிற ஒரு சிறப்பான வாய்ப்பு கிடைத்தது. அதில் இதே போன்றதொரு அமர்வினை தொடங்கி வைக்கும் வாய்ப்பும் கிடைத்தது. உலகில் பல்வேறு நாடுகளைச் சேர்ந்த 100 அறிவியல் ஆய்வாளர்கள் அந்த மாநாட்டில் கலந்து கொண்டு உலகில் நாம் எதிர்கொள்ள வேண்டிய பேரிடர் மற்றும் இன்றைக்கு எதிர்கொண்டு சமாளித்து முடித்திருக்கிற பேரிடர் போன்ற பல்வேறு விஷயங்கள் குறித்து தங்களுடைய ஆய்வு கட்டுரைகளை சமர்ப்பித்து மிகப்பெரிய அளவில் உரை நிகழ்த்தினார்கள். அங்கேயும் ஒரு 100 பேர் அளவில் மட்டுமே 4 நாட்கள் அந்த மாநாடு நடைபெற்றாலும் எங்கள் உள்ளிட்ட ஒரு 100 பேர் மட்டுமே அங்கே உரையாற்றுகிற அந்த வாய்ப்பு அந்த மாநாட்டில் கிடைத்தது. உலக அளவில் பல நாடுகளைச் சேர்ந்த பிரதிநிதிகள் பங்கேற்ற அந்த மாநாட்டிலேயே 100 பேர் மட்டுமே கலந்து கொள்ள முடிந்தது, பேச முடிந்தது. ஆனால் இன்றைக்கு நம்முடைய இந்த மாநாட்டில் இந்த டிபிஎச்சின் 100ஆண்டு நிறைவு விழா நிகழ்ச்சியில் 81 அமர்வுகள் நடைபெற்று முடிந்திருக்கிறது. 81 செஷன்ஸ் என்று சொல்லக்கூடிய அமர்வுகள் இன்றைக்கு நடைபெற்று முடிந்திருக்கிறது. இந்த 81 அமர்வுகளிலும் 154 பேச்சாளர்கள் உரை நிகழ்த்தி இருக்கிறார்கள்.
நான் சொன்னதைப் போல உலகளாவிய மாநாட்டிலேயே 100 பேர் மட்டுமே உரை நிகழ்த்தியிருக்கிறார்கள். ஆனால் நம்முடைய டிபிஎச்சின் நூற்றாண்டு நிறைவு விழாவில் 154 பேர் உரை நிகழ்த்தி சிறப்பித்திருக்கிறார்கள். அதோடு மட்டுமல்லாது நம்முடைய டிபிஎச் அவர்கள் இங்கே பேசும்போது எடுத்து சொன்னதைப் போல 283 ஆராய்ச்சி கட்டுரைகள் சமர்ப்பிக்கப்பட்டிருக்கிறது. அறிவியல் பூர்வமான ஆதாரங்களோடு 283 ஆராய்ச்சி கட்டுரைகள் இங்கே சமர்ப்பிக்கப்பட்டு அதில் 178 ஆய்வுரைகள் இந்த மேடைகளில் நிகழ்த்தப்பட்டிருக்கிறது. 178 ஆய்வுரைகள் நிகழ்த்தப்பட்டதோடு மட்டுமல்லாது 105 போஸ்டர் டிஸ்பிளே என்கின்ற வகையில் அவர்களுடைய சிறு சிறு கருத்துக்களும் இங்கே பதிவிக்கப்பட்டிருக்கிறது. ஆக 154 பேருடைய உரைகள், 283 ஆராய்ச்சி கட்டுரைகள், அதில் 178 ஆய்வு உரைகள், 105 போஸ்டர் டிஸ்பிளே என்கின்ற வகையில் ஒரு மகத்தான ஒரு மாநாடு. இந்த நிறைவு விழா ஒரு மாநாடாகவே இன்றைக்கு நடைபெற்று முடிந்திருக்கிறது. ஆக இதுவரை எனக்கு தெரிந்து என் வாழ்நாளில் ஒரு மாநில அரசு ஒரு துறையின் சார்பில் நடத்தப்பட்ட மாநாடுகளில் இவ்வளவு அமர்வுகள், இவ்வளவு உரைகள் வேறு எங்கும் நடைபெற்றிருக்குமா என்றால் நிச்சயம் இருக்காது. அது இன்றைக்கு இது ஒரு சாதனை படைத்த நிகழ்வாகவே இதை நாம் பார்க்கிறோம். ஏதோ வந்திருப்பவர்களை மகிழ்விக்க வேண்டும் என்பதற்காகவோ நடத்தி கொண்டிருக்கிற இந்த துறையின் மிக முக்கிய அலுவலர்களை குளிர்விக்க வேண்டும் என்பதற்காகவோ சொல்லப்படுகிற வார்த்தைகள் அல்ல. உண்மையிலேயே மன நெகிழ்ச்சியோடு சொல்லுகிறேன், இந்த மாநாடு வெற்றிகரமாக நடைபெற்று முடிந்திருக்கிறது. இதற்காக ஒத்துழைத்த அனைவருக்கும் என்னுடைய நெஞ்சம் நிறைந்த வாழ்த்துக்களையும் பாராட்டுக்களையும் தெரிவித்துக் கொள்கிறேன். ஒவ்வொரு அலுவலரும் நான் முதல் நாளிலும் இந்த கடைசி நாளிலும் கலந்து கொள்ளும் வாய்ப்பை பெற்றிருந்தேன். வெவ்வேறு மருத்துவ பணிகள் சென்னையிலும் இருந்ததால் நான் இதில் முழுமையாக பங்கேற்க இயலவில்லை. இல்லை என்றால் 4 நாட்களும் உங்களுடன் இங்கேயே இருந்திருப்பேன். ஆனால் இந்த 2 நாட்களிலேயே உங்கள் ஒவ்வொருவருடைய உழைப்பையும் நேரடியாக பார்க்கிற அந்த வாய்ப்பை பெற்றேன். பெரிய அளவில் 4-5 டிகிரி பெற்ற மருத்துவர்களும் கூட அவர்கள் ஓடியாடி இந்த மாநாடு வெற்றி பெற உழைத்த உழைப்பை நேரில் பார்க்கும்போது தங்கள் குடும்பத்தில் ஏதாவது ஒரு சுபகாரியம் நடைபெற்றால் எந்த அளவுக்கு ஒரு ஈடுபாட்டு உணர்வுடன் அதை வெற்றி பெற செய்வதற்கு உழைப்பார்களோ அதே மாதிரியான உழைப்பை இந்த மாநாடு வெற்றி பெறுவதற்கு நீங்கள் தந்தது என்பது மகிழ்ச்சிக்குரிய ஒன்றாக இருந்தது. நம்முடைய டிபிஎச் அவர்களுடைய தந்தையின் நினைவு நாள் இன்று என்று நான் சமூக வலைதளத்தின் மூலம் தெரிந்து கொண்டேன். அவருடைய நினைவு நாள் திதி என்று சொல்லுவார்கள். அந்த நினைவு நாளில் அவர் பங்கேற்பதற்கு சென்னைக்கு அவசரமாக போய் அதிலும் கலந்து கொண்டு விட்டு இந்த மாநாட்டில் 1-2 மணி நேரம் இல்லாமல் போனதற்காக அவர் மனம் புழுங்கிக் கொண்டே இங்கே ஓடி வந்ததையும், அவர் வந்து இந்த மாநாட்டில் பங்கேற்கிற போது அவருக்கு ஏற்பட்ட அந்த மகிழ்ச்சி உண்மையிலேயே அவருக்கும் இந்த மாநாடு வெற்றி பெற செய்வதற்கு அவர் கொண்ட ஈடுபாட்டிற்கும் இதை உதாரணமாக சொல்லலாம். அந்த அளவுக்கு எல்லோருமே ஒன்றிணைந்து உழைத்ததால் தான் இந்த மாநாடு மிகப்பெரிய அளவிலான வெற்றி பெற்றிருக்கிறது. தமிழகத்தை பொறுத்தவரை இன்றைக்கு 286 ஆரம்ப சுகாதார நிலையங்கள் மற்றும் நகர்ப்புற சுகாதார நிலையங்கள் இருக்கிறது. 2286 2286 ஆரம்ப மற்றும் நகர்ப்புற சுகாதார நிலையங்கள் இருக்கிற ஒரு மிக சிறந்த இந்த கட்டமைப்பு என்பது இந்தியாவில் அநேகமாக வேறு எந்த மாநிலத்திலும் இருக்க முடியாது. இந்தியாவில் தமிழகத்தை விட கூடுதல் மக்கள் தொகை இருக்கிற மாநிலங்களில் கூட 2286 ஆரம்ப சுகாதார நிலையங்கள் இருக்குமா என்றால் நிச்சயமாக நான் கேள்விக்குறி என்றுதான் இங்கே பதிலளிக்க வேண்டி வரும். அதேபோல் இங்கே இருக்கிற துணை சுகாதார நிலையங்கள் 8713. 8713 துணை சுகாதார நிலையங்கள் இருக்கிறது. நான் நம்முடைய டிபிஎச் அவர்களிடம் பேசும்போது ஏற்கனவே ஆரம்ப சுகாதார நிலையங்கள் இன்னமும் வேண்டும் என்று ஒன்றிய அரசிடம் நாம் கோரிக்கை வைத்து ஒரு 5-6 ஆண்டுகளுக்கு பிறகு தமிழகத்தில் புதிதாக ஒரு 25 ஆரம்ப சுகாதார நிலையங்களும் 25 நகர்ப்புற ஆரம்ப சுகாதார நிலையங்களையும் கடந்த ஆண்டு கேட்டு பெற்று வந்தோம். மாண்புமிகு தமிழக முதல்வர் அவர்களின் வேண்டுகோளினை ஒன்றிய அரசு பரிசீலித்து நமக்கு புதிதாக 50 ஆரம்ப மற்றும் நகர்ப்புற சுகாதார நிலையங்களுக்கு அனுமதி அளித்திருக்கிறது. அவை எங்கெங்கே அமைய வேண்டும் என்கின்ற வகையிலான பட்டியலும் கடந்த 2 மாதங்களுக்கு முன்னால் வெளியிடப்பட்டு அதற்கான பணிகளும் கூட நடைபெற்றுக் கொண்டிருக்கிறது. ஆனால் துணை சுகாதார நிலையங்கள் 8713 என்று இருக்கிற நிலையில் இது போதுமா என்று நம்முடைய டிபிஎச் அவர்களிடம் கேட்டபோது துணை சுகாதார நிலையங்களை பொறுத்தவரை அவை அமைவதற்குரிய மக்கள் தொகை விதிமுறைகளை பற்றி சொன்னார். 5000 மக்கள் தொகை இருந்தால் ஒரு துணை சுகாதார நிலையம் கிராமப்புறங்களில், அதுவே நகர்ப்புறங்கள் என்று எடுத்துக்கொண்டால் ஒரு 10,000 மக்கள் தொகை இருக்க வேண்டும் என்று. இப்பொழுது 5000 என்கின்ற வகையில் ஒரு துணை சுகாதார நிலையம் தமிழகத்தில் ஒட்டுமொத்தமாக இருப்பது என்பது 8713. இப்படி இந்த மக்கள் தொகை அடிப்படையில் இன்னமும் நமக்கு எவ்வளவு துணை சுகாதார நிலையங்கள் வந்தால் தமிழ்நாடு துணை சுகாதார நிலையங்களில் முழுமை பெறும் என்று கேட்டேன். அவர் சொன்னார், இன்னும் ஒரு 2000 வந்தால் சரியாக இருக்கும். 2000 2500 என்கின்ற அளவில் வந்தால் நமக்கு 12525 ஊராட்சி அமைப்புகள் இருக்கிறது, கிராம ஊராட்சிகள். இந்த 12525 கிராம ஊராட்சிகள் என்று வருகிற போது கண்டிப்பாக இந்த 5000 மக்கள் தொகை என்று சராசரி வைத்துக் கொண்டாலும் ஒரு 10,000த்திற்கும் மேற்பட்ட துணை சுகாதார நிலையங்கள் வேண்டும். ஆனால் தமிழகத்தில் தற்போது இருப்பது 8713. இன்னும் ஒரு 2500 துணை சுகாதார நிலையங்கள் வந்தால் தமிழகத்தில் ஒட்டுமொத்தமாக இந்த 5000 மக்கள் தொகைக்கு ஒரு துணை சுகாதார நிலையம் என்கின்ற அளவில் நாம் முழுமை பெறலாம், தன்னிறைவு அடையலாம் என்று சொன்னார். நிச்சயம் மாண்புமிகு தமிழக முதல்வர் அவர்களின் அறிவுறுத்தலை பெற்று அடுத்தடுத்து நாம் ஒன்றிய அரசை அணுகும் போது, ஒன்றிய அமைச்சரை அணுகும் போது இன்னமும் கூடுதல் துணை சுகாதார நிலையங்கள் ஏறத்தாழ 2000த்திற்கும் மேற்பட்ட துணை சுகாதார நிலையங்கள் மக்கள் தொகை அடிப்படையின் கீழ் அமைந்திட வேண்டியதன் அவசியத்தை ஒன்றிய அரசிடம் எடுத்து சொல்லி நிச்சயம் பெற்றுத் தருவதற்கான முயற்சிகளை இந்த துறை மேற்கொள்ளும் என்பதை இந்த நூற்றாண்டு நிறைவு விழாவில் ஒரு மிக முக்கியமான செய்தியாகவே தெரிவித்துக் கொள்வதில் பெருமை அடைகிறோம். நூற்றாண்டு விழா நிறைவு விழாவை கண்டு கொண்டிருக்கிற நாம் 101வது பிறந்த நாள் விழாவையும் கண்டிருக்கிற நாம் இன்னமும் எதிர்கொள்ள வேண்டிய சவால்கள் ஏராளமாக இருக்கிறது. எனவே இதனுடைய கட்டமைப்பை மேம்படுத்துவது என்பது அவசியமான ஒன்று என்பதாலே தான் இந்த 8713 என்பது 10,000 தொட வேண்டும், 10,000 தாண்டியும் போக வேண்டும் என்கின்ற வகையில் நம்முடைய கோரிக்கையை ஒன்றிய அரசிடம் வைக்கவிருக்கிறோம். அதேபோல் ஆரம்ப மற்றும் நகர்ப்புற சுகாதார நிலையங்கள் 2286 என்று இருக்கிற போது அதற்கு கிராமப்புறங்களில் 30,000 மக்கள் தொகை இருக்க வேண்டும், மலைப்பகுதிகளில் 20,000 மக்கள் தொகை இருக்க வேண்டும், நகர்ப்புற பகுதிகளில் 50,000 மக்கள் தொகை இருக்க வேண்டும். இப்படி இருந்தால் ஒரு ஆரம்ப சுகாதார நிலையம் என்று கணக்கு இருக்கிறது. அப்படி இருக்கும்போது நம் தமிழகத்தில் இருக்கிற இந்த ஆரம்ப சுகாதார நிலையங்கள் மற்றும் நகர்ப்புற ஆரம்ப சுகாதார நிலையங்கள் எண்ணிக்கை இது நிறைவு அடைந்து விட்டதா, முழு நிறைவடைந்து விட்டதா என்றால் அதிலும் கூட இன்னமும் கொஞ்சம் குறை இருக்கிறது. இந்தியாவிலேயே அதிகமான சுகாதார நிலையங்கள், துணை சுகாதார நிலையங்கள், ஆரம்ப சுகாதார நிலையங்கள் என்று அதிகமாக இருந்தாலும் கூட முழுமையான மக்கள் தொகைக்கு ஏற்ப ஏற்கனவே இருக்கிற அந்த விகிதாச்சார அடிப்படையில் 20,000 மலை கிராமங்கள், 30,000 சாதாரண பகுதி மக்கள், 50,000 நகர்ப்புற பகுதி மக்கள் இருக்கிற இடங்களில் ஒரு ஆரம்ப சுகாதார நிலையம் வேண்டும் என்கின்ற அந்த கோரிக்கைக்கு அது முழுமை அடைவதற்கு இன்னமும் ஒரு 200-250 ஆரம்ப சுகாதார நிலையங்கள் வேண்டும் என்கின்ற நிலை இருக்கிறது. கடந்த ஆண்டு நமக்கு ஒரு 50 கிடைத்திருக்கிறது. நிச்சயம் இந்த ஆண்டும் நாம் டெல்லிக்கு போகிற போது வணக்கத்திற்குரிய தமிழகத்தின் முதல்வர் அவருடைய அறிவுறுத்தலை பெற்று எதிர்வரும் ஆண்டுக்கும் இந்த 200-250 புதிய ஆரம்ப மற்றும் நகர்ப்புற சுகாதார நிலையங்கள் தமிழகத்தில் அமைவதற்குண்டான நடவடிக்கைகள் மேற்கொள்ளப்படும் என்பதை இங்கே தெரிவித்துக் கொள்ள கடமைப்பட்டிருக்கின்றேன். தமிழகத்தின் மருத்துவ கட்டமைப்பு நான் தொடக்க விழாவிலேயே சொன்னேன். தினந்தோறும் 6 லட்சம் புறநோயாளிகள் தினந்தோறும் நம் மருத்துவ சேவையை பயன்படுத்தி கொண்டிருக்கிறார்கள். 70,000 பேர் உள்நோயாளிகளாக இன்றைக்கு பயன்பெற்று வருகிறார்கள். தினந்தோறுமான அறுவை சிகிச்சைகள் சற்றொப்ப 10,000 என்கின்ற அளவில் இருந்து கொண்டிருக்கிறது. எனவே ஒவ்வொரு நாளும் 10,000 அறுவை சிகிச்சைகளும் 70,000 பேர் உள்நோயாளிகளாக இருந்து பயன்பெறுவதும் ஒவ்வொரு நாளும் 6 லட்சத்திற்கும் மேற்பட்டவர்கள் புறநோயாளிகளாக வந்து மருத்துவ சேவையை பயன்படுத்திக் கொள்வது என்பதும் இந்தியாவில் தமிழகத்தில் மட்டும்தான் இந்த மிகப்பெரிய மகத்தான மருத்துவ சேவை என்பது உங்களால் இன்றைக்கு சாத்தியமாகி இருக்கிறது. இந்த விஷயத்தில் இங்கே எனக்கு முன்னால் பத்திரிகையாளர்கள் உரையாற்றினார்கள், மாணவர்கள் பேசியிருக்கிறார்கள், தன்னார்வலர்கள் பேசியிருக்கிறார்கள், உலக சுகாதார மையத்திலிருந்து வந்து பேசியிருக்கிறார்கள், யுனிசெஃபிலிருந்து வந்து பேசியிருக்கிறார்கள், சென்டர் ஃபார் டிசீஸ் கண்ட்ரோல் என்று சொல்லப்படுகிற அமெரிக்க நாட்டு அட்லாண்டா பகுதியிலிருந்து வந்த பிரதிநிதி பேசியிருக்கிறார். நம்முடைய மருத்துவர் பெருமக்கள் ஆய்வு கட்டுரைகளை சமர்ப்பித்து பேசியிருக்கிறீர்கள். ஏராளமான பேர் பேசிய போதும் எல்லோரிடத்திலுமிருந்து ஒரு கருத்து சிறப்பாக வெளிப்பட்டது என்பது தமிழகத்தில் கொரோனா பேரிடர் மிக திறமையாக கையாளப்பட்டது. கொரோனா பேரிடரில் நம்முடைய மருத்துவர்களும் செவிலியர்களும் மருத்துவம் சார்ந்த களப்பணியாளர்களும் மிக திறமையாக பணியாற்றி அந்த பேரிடரிலிருந்து இன்றைக்கு நாம் மீண்டு வந்திருக்கிறோம் என்கின்ற அந்த செய்தியை சொன்னார்கள். முதல் கொரோனா நோயாளி எப்பொழுது தமிழகத்தில் கண்டறியப்பட்டார் என்றால் 2020 மார்ச் 7ஆம் தேதி முதல் நோயாளி தமிழகத்தில் கண்டறியப்பட்டார். முதல் தொற்று உடையவர் மார்ச் 7, 2020 அன்றைக்கு கண்டறியப்பட்டார். அதுதான் முதல் அலையின் தொடக்கம். முதல் நபர் கண்டறியப்பட்ட நாள். அது எப்பொழுது அந்த முதல் அலை ஒரு கடைசியான ஒரு பெரிய அளவில் பல்லாயிரக்கணக்கானோர் தினந்தோறுமாக பாதிக்கப்பட்டு கடைசியாக அந்த அலை எப்பொழுது முடிவுக்கு வரும், கடைசியா லோயஸ்ட் அந்த பாதிப்புக்குள்ளானவர் எவ்வளவு பேர் என்று சொன்னபோது பிப்ரவரி 20, 2021 பிப்ரவரி 20 அன்றைக்கு 438 பேர் முதல் அலையில் 2020 மார்ச் 7 அன்றைக்கு முதல் நபர் கண்டறியப்பட்டு 2021 பிப்ரவரி 20 ஏறத்தாழ 11 மாதங்களுக்கு பிறகு அது 438 என்கின்ற அளவில் ஆயிரக்கணக்கில் ஏறி கடைசியாக 438 குறைந்தபட்ச எண்ணிக்கையாக இருந்தது. பிறகு 2வது அலையின் தொடக்கம் தொடங்கி 2வது அலையும் கூட உங்களுக்கு நன்றாக தெரியும், மிகப்பெரிய அளவில் உயர்ந்து நாளொன்றுக்கு 30,000 25,000 என்கின்ற அளவில் போய் அது கடைசியாக 2021 டிசம்பர் 24 அன்றைக்கு 597 என்பது லோயஸ்ட் நம்பர் என்கின்ற அளவிலே இருந்தது. 2வது அலையிலும் கூட 597 தான் அந்த கடைசியாக குறைந்தபட்ச அளவில் தொற்று பாதிப்புக்குள்ளானவர்கள் எண்ணிக்கை என்று இருந்தது. இப்பொழுது 3வது அலையின் இறுதியில் இருக்கிறோம். இன்றைக்கு கொரோனா தொற்றின் பாதிப்பு எண்ணிக்கை எவ்வளவு என்றால் நீங்கள் மகிழ்ச்சி அடைவீர்கள். ஏனென்றால் தினந்தோறும் நம்முடைய துறையின் செயலாளர் இந்த எவ்வளவு பேர் பாதிப்புக்குள்ளாகி இருக்கிறார்கள், எந்தெந்த மாவட்டத்தை சேர்ந்தவர்கள் பாதிப்புக்குள்ளாகி இருக்கிறார்கள், எவ்வளவு பேருக்கு RT-PCR பரிசோதனை மேற்கொள்ளப்பட்டது என்று அவர்கள் கணக்கெடுத்து அந்த விவரங்களை அனுப்புகிற போது நாங்களும் தினந்தோறும் பரீட்சை எழுதுகிற மாணவனைப் போல் நாம் எழுதிய தேர்வுக்கு கிடைத்த மதிப்பெண் என்னவாக இருக்கும் என்று தினந்தோறும் பார்க்கிற ஒரு கடைநிலை மாணவனைப் போல் நானும் தினந்தோறுமாக பார்த்து கொண்டிருக்கிறேன். இன்றைக்குத்தான் அது ஓர் இலக்கமாக மாறி இருக்கிறது. 9 என்கின்ற அளவில் இன்றைக்கு இந்த தொற்றின் பாதிப்பு வந்திருக்கிறது. நேற்றைக்கு 11ஆக இருந்தது ஈரிலக்கம், இன்னைக்கு அது 9ஆக மாறி இருக்கிறது. ஆக இன்னைக்கு கொரோனா தொற்றின் பாதிப்பு எண்ணிக்கை 9. ஆக இப்பொழுது நாம் ஒரு மனநிலைக்கு வரலாம். 2020 மார்ச் 7 எப்படி ஓர் இலக்கமாக தொடங்கியதோ அது இன்றைக்கு 3 அலைகளை கடந்ததற்கு பிறகு மீண்டும் ஓர் இலக்கத்திற்கு வந்து ஒரு முடிவுக்கு வந்திருக்கிறது. ஏன்னா 4வது அலையெல்லாம் வருமா வராதெல்லாம் தெரியாது, வரக்கூடாது, வராது. ஏன்னா அது ஒரு பெரிய அளவிலான பாதிப்பு 3ஆம் அலையில் இல்லை. ஆல்ஃபா முதல்ல கொரோனா என்று தொடங்கி ஆல்ஃபா வந்தது, பீட்டாவும் நமக்கு வந்தது, லண்டனிலிருந்து வருகிற ஒருத்தருக்கு பீட்டா வந்தது, அப்புறம் டெல்டா யூகேலிருந்து வந்தவருக்கு தான் வந்தது, டெல்டா ப்ளஸ் யூஎஸ்லேருந்து ஒருத்தருக்கு வந்தவருக்கு இங்கே நம்ம தமிழ்நாட்டில் கண்டுபிடிச்சோம். அது மாதிரி கொரோனா, அதுக்கப்புறம் ஆல்ஃபா, பீட்டா, டெல்டா, டெல்டா ப்ளஸ், கம்மா, கப்பா, ஒமிக்ரான், ஒமிக்ரான்லேயே ஒரு 7-8 வகைகள். இவ்வளவு அந்த கொரோனாவுடைய உருமாற்றங்கள் நிகழ்ந்ததற்கு பிறகும் இன்றைக்கு நாம் நிம்மதி பெருமூச்சு விட்டுக் கொள்ளலாம் என்கின்ற வகையில் 9 என்கின்ற எண்ணிக்கையில் நாம் இன்றைக்கு இருந்து கொண்டிருக்கிறோம். இது மிகப்பெரிய அளவில் மகிழ்ச்சி. நீங்கள் 1526 பேர் அமர்ந்திருக்கிற அரங்கில் ஓரிருவரை தவிர மற்ற யாரும் முகக்கவசங்கள் அணியவில்லை என்கின்ற பாதுகாப்பு நிலை இன்றைக்கு நமக்கு ஏற்பட்டிருக்கிறது. ஆனால் இதுக்காக நான் சொல்லிட்டேங்கிறதுக்காக முகக்கவசங்கள் அணியவே வேண்டியது இல்லை என்பது இல்லை. ஜப்பான், நான் இந்த கொரோனா வருவதற்கு முன்னால் 2020 மார்ச்சில் தான் முதல் பேஷண்ட் நாம் இங்கே பார்த்தோம். 2019 இறுதியில் நான் ஜப்பானில் இருந்தேன். நானும் நண்பர்களும் ஜப்பானில் ஒரு 3-4 நாட்கள் அங்கே இருந்தோம். அப்போது அங்கே இருக்கிற அந்த ஜப்பான் பன்னாட்டு தமிழர் சங்கம் அவங்களோடு நிகழ்ச்சிகளில் கலந்து கொண்டோம். நாங்கள் மட்டும்தான் அப்போ மாஸ்க் இல்லாமல் இருந்தோம். இப்போ கொரோனா பாதிப்பே இல்லாமல் தான் இருந்தது. கொரோனான்னா என்னன்னு யாருக்கும் தெரியாது. 2019 இறுதியில் அப்போதுதான் ஊகானில் தொடங்கி இருந்தது, ஜப்பானில் எல்லாம் பரவவில்லை. அந்த நேரத்திலும் கூட அவர்கள் எல்லோருமே முகக்கவசம் அணிந்து கொண்டு தான் இருந்தார்கள். ஏனென்று நாங்கள் அவர்களை விசாரித்த போது சொன்னார்கள், சுற்றுச்சூழல் பாதிப்புகளிலிருந்து எங்களை தற்காத்துக் கொள்ள முகக்கவசங்கள் எப்போதும் அணிவதை வாடிக்கையாக கொண்டிருக்கிறோம் என்றார்கள். எனவே கொரோனா போன்ற தொற்றுகளிலிருந்து பாதிப்பதற்கு மட்டும் முகக்கவசம் பாதுகாப்பு கவசம் அல்ல, சுற்றுச்சூழல் பாதிப்புகளிலிருந்தும் நம்மை தற்காத்துக் கொள்வதற்கு இந்த முகக்கவசங்கள் அவசியமான ஒன்றுதான். எனவே சுப்பிரமணியே சொல்லிவிட்டார் முகக்கவசம் அணிய வேண்டியதில்லை என்று என்கின்ற ஒரு விமர்சனம் நாளைக்கு வரக்கூடாது என்பதால் முகக்கவசம் அணிவது என்பது எப்போதுமே எல்லோருக்குமே பாதுகாப்பு என்பதை இந்த நேரத்தில் மகிழ்ச்சியோடு தெரிவித்துக் கொள்வதில் நான் பெருமை அடைகிறேன். இன்றைக்கு நம்முடைய இந்த மாநாடு என்பது மிகப்பெரிய அளவிலான வெற்றியினை பெற்றிருக்கிறது. இந்த மாநாட்டின் இறுதி செய்தியாக நாம் மகிழ்ச்சியோடு இங்கே பெருமையோடு நான் ஏற்கனவே சொன்னதைப் போல 101வது ஆண்டை தொடங்கி இருக்கிற இந்த பொது சுகாதாரத்துறை இன்னமும் ஒரு 2000 துணை சுகாதார நிலையங்கள் கேட்டு பெற வேண்டியிருக்கிறது. அதேபோல் இன்னமும் ஒரு 200க்கும் மேற்பட்ட ஆரம்ப சுகாதார நிலையங்கள் கேட்டு பெற வேண்டியிருக்கிறது. இவைகளெல்லாம் தமிழகத்திற்கு வந்துவிட்டால் 100க்கு 100% தன்னிறைவு பெற்ற துறையாக நம்முடைய மக்கள் நல்வாழ்வுத்துறை இருக்கவிருக்கிறது என்பதை மகிழ்ச்சியோடு தெரிவித்துக் கொள்கிறேன். அதற்கான பணிகளை இந்த துறை செய்யும். இங்கே உரையாற்றிய பத்திரிகையாளர்கள் சொன்னார்கள், பணியிடங்கள் முழுமையாக நிரப்பப்பட வேண்டும் என்று சொன்னார்கள். அதில் நிச்சயம் நானும் அந்த கருத்துக்கு உடன்பட்டவன் தான். அதனால்தான் மாண்புமிகு தமிழக முதல்வர் அவர்கள் இந்த துறையில் காலி பணியிடங்களை நிரப்புவதற்குரிய நடவடிக்கைகளை உடனடியாக எடுக்க சொன்னார்கள். இந்த துறையின் செயலாளர் கூட அந்த துறை சம்பந்தப்பட்ட ஆணையர், எம்ஆர்பியின் ஆணையர், மெடிக்கல் சர்வீசஸ் ரெக்யர்மெண்ட் போர்டு ஆணையர் இங்கே பேசும்போது நீங்கள் கேட்டீர்கள். 4308 பணியிடங்கள் நிரப்புவதற்கு 1021 மருத்துவர்கள் உட்பட 4308 பணியிடங்கள் நிரப்புவதற்கு அவரிடத்தில் பணி ஒப்படைக்கப்பட்டிருக்கிறது. அவரும் மிக வேகமாக செய்து கொண்டிருக்கிறார். சர்டிஃபிகேட் வெரிஃபிகேஷன், தேர்வுகள் போன்ற பல்வேறு நடைமுறைகள் வேகமாக போய்கொண்டிருக்கிறது. ஒரு 300க்கும் மேற்பட்டவர்கள் பணி நியமனம் முடிந்திருக்கிறது. இப்பொழுதும் ஒரு 700-800 பேருக்கான ஆணைகள் தயார் நிலையில் இருக்கிறது. மிக விரைவில் அந்த பணியிடங்கள் நிரப்பப்படும். அதோடு மட்டுமல்லாது ஏற்கனவே 2000க்கும் மேற்பட்ட செவிலியர்கள் இந்த துறைக்கு மீண்டும் பணியில் அமர்த்தப்பட வேண்டும் என்கின்ற அந்த கோரிக்கை இருக்கிறது. ஒன்றும் இல்லை. முதல்ல வெடிச்சது நூற்றாண்டு நிறைவு, இது 101க்கு. இது 101க்கான தொடக்கம். இப்ப அந்த 4308 இந்த 2000 செவிலியர்களையும் கடந்து எவ்வளவு காலி பணியிடங்கள் இருக்கிறது என்கின்ற பட்டியல் துறைகளின் சார்பில் தயாரிக்கப்பட்டு கொண்டிருக்கிறது. வெறும் இது ஒரு துறை ரீதியான ஒரு ஆய்வுகள் நடத்தப்பட்டு எவ்வளவு எக்ஸாக்டாக எவ்வளோ காலியாக இருக்குங்கிற அந்த பட்டியல் ஒவ்வொரு துறையிலிருந்தும் தயாரிக்கப்பட்டு கொண்டிருக்கிறது. நிச்சயம் தயாராக இந்த காலி பணியிடங்கள் முழுமையாக நிறைவேற்றும் பணியினை இந்த துறை மேற்கொள்ளும். ஒரு 709 நகர்ப்புற நலவாழ்வு மையங்களை மாண்புமிகு தமிழக முதல்வர் அவர்கள் டெல்லிக்கு சென்று அங்கே இருக்கிற ஆம் ஆத்மி மொபுல்லா கிளினிக் என்கின்ற ஒரு மருத்துவமனையை பார்த்துவிட்டு அதே போன்றது மருத்துவமனை கட்டமைப்பை தமிழகத்தில் உருவாக்குவது என்று முடிவெடுத்து 708 மருத்துவமனைகளை தமிழகத்தில் கட்டுவதற்குரிய நடவடிக்கைகளை மேற்கொண்டார்கள். அதில் 21 மாநகராட்சிகளிலும் 63 நகராட்சிகளிலும் அந்த பணிகள் நடைபெற்று கொண்டிருக்கிறது. இன்னும் ஒரு மாத காலத்தில் ஏறத்தாழ இந்த 700 மருத்துவமனைகளின் கட்டுமான பணிகளும் நிறைவடையவிருக்கிறது. 700 மருத்துவமனைகளுக்கு தேவையான மருத்துவர்கள் பணி நியமனங்கள் மிக விரைவில் ஒரு மாத காலத்திற்குள்ளாகவே அந்த பணிகளும் முடிவுற்று ஒரே நாளில் தமிழகத்தில் 500க்கும் மேற்பட்ட மருத்துவமனைகளை நம்முடைய மாண்புமிகு தமிழக முதல்வர் அவர்கள் சென்னையிலிருந்து தொடங்கி வைக்கவிருக்கிறார்கள். இது எல்லாமே இந்த துறையின் ஒரு அசாத்திய சாதனைகளாக இருக்கவிருக்கிறது. அதோடு மட்டுமல்லாது இங்கே ஆய்வு கட்டுரைகள் பலவற்றை இங்கே பேசியவர்களுடைய பேச்சுக்களை நான் கேட்டேன். தொடர்ச்சியாக அவர்கள் கட்டுரைகள் புத்தகமாக ஒன்று வெளியிடப்பட்டு முதல் நாளில் வெளியிடப்பட்டது. அதையும் நான் வாங்கி பார்த்தேன். பார்த்ததற்கு பிறகு ஒரு யோசனை வந்தது. இவ்வளவு திறமையில் பொதிந்தவர்கள் நம்முடைய தமிழக மருத்துவத்துறையில் இருக்கிறார்கள். ஒவ்வொருவருடைய ஆய்வு கட்டுரையும் படிக்கிற போது உண்மையிலேயே அசாத்திய திறமை கொண்டவர்கள் நம்முடைய தமிழக மருத்துவர்கள். உலக மருத்துவர்களுக்கு சவால் விடுகிற அளவுக்கு மருத்துவ நிபுணத்துவம் வாய்ந்தவர்கள் நம்முடைய தமிழகத்தின் மருத்துவர்கள். இப்படிப்பட்ட மருத்துவர்களுடைய திறமையை வெறுமனே ஒரு குறுகிய வட்டத்திற்குள்ளாகவே அடைக்க விடாமல் இந்த மருத்துவ திறமையை வெளி உலகுக்கு கொண்டு வருகிற ஒரு முயற்சியாக ஒரு புதிய முயற்சி ஒன்றை ஜனவரி 1ஆம் தேதி அன்றைக்கு தொடங்கவிருக்கிறது. இந்த துறை நலம் 360 என்கின்ற ஒரு யூடியூப் சேனல் ஒன்று புதிதாக உருவாக்கப்படவிருக்கிறது. அந்த நலம் 360 என்கின்ற யூடியூப் சேனல் நம்முடைய டிபிஎச் அலுவலகத்திலிருந்து தான் இயங்கவிருக்கிறது. அந்த நலம் 360 என்கின்ற யூடியூப் சேனலில் இங்கே இப்பொழுது நீங்கள் 283 பேர் ஆய்வறிக்கைகளை தந்திருக்கிறீர்களே, ஒவ்வொரு துறையின் வாரியாக தந்த இந்த ஆய்வறிக்கைகள் உங்களுடைய உரைகள் தினந்தோறும் லைவாகவே நேரடியாகவே மக்களை போய் சென்றடைகிற வகையில் இன்றைக்கு சமூக வலைதளங்கள் தான் இன்றைக்கு ஒவ்வொரு சமூகத்தையும் நல்லது கெட்டதுகளை நிர்ணயிக்கிற ஒரு அமைப்பாக இருக்கிறது. எனவே சமூக வலைதளங்களின் மூலம் நம்முடைய இந்த துறையின் அடுத்த கட்ட வளர்ச்சியை பொதுமக்களுக்கு கொண்டு செல்லுகிற வகையிலேயும் பொதுமக்களுக்கு அங்கங்கே ஏற்படுகிற அசௌகரியங்கள் மற்றும் அவர்களுக்கு தேவையான விஷயங்களை இந்த யூடியூப் சேனலின் மூலம் அறிந்து கொண்டு அதற்கேற்ற வகையில் இது நிறைய பலனளிக்கும் விஷயங்களை செய்யலாம் என்கின்ற வகையில் ஒரு யூடியூப் சேனல் ஒன்று நலம் 360 என்கின்ற வகையில் ஒரு சேனல் 1ஆம் தேதி முதல் தொடங்கப்படவிருக்கிறது என்கின்ற மகிழ்ச்சியான செய்தியையும் இந்த நூற்றாண்டு நிறைவு விழாவில் தெரிவித்து இந்த சிறப்பான நிகழ்ச்சிக்கு வருகை தந்து பெருமை சேர்த்திருக்கிற 1526 பேருக்கும் 86 இதில் என்னன்னா முதல் நாள் வந்தவங்க 2வது நாள் இருக்க மாட்டாங்க, 2வது நாள் வந்தவங்க 3வது நாள் முகம் காட்டிட்டு போயிடுவாங்க. ஆனால் இங்கே நம்ம பார்க்குறோம், முதல் நாள் தொடங்கி வைக்கும் போது யாரெல்லாம் இருந்தீங்களோ கடைசி நாள் முடிகிறப்பவும் எல்லாரையும் பார்க்க முடியுது. இது ஒரு மகத்தான வெற்றி, இந்த மாநாட்டுக்குரிய ஒரு மிகப்பெரிய சிறப்புக்குரிய வெற்றி. இவ்வளோ பேர் பேசுனாங்கிற கணக்கு மட்டும் நான் சொன்னேன், எவ்வளோ பேர் நீங்கள் கேள்வி கேட்டீங்கிற கணக்கு நான் சொல்லலை. அதை நிறைய பேர் கேட்டிருக்கிறீங்க, அந்த கணக்கு இங்கேயே இல்லை. ஆனால் இப்போ அவ்வளோ பேரும் ஒவ்வொருத்தரும் பேசி முடிச்சதுக்கு அப்புறம் 2 பேர் 3 பேர் கேள்வி கேட்டிருக்கீங்க. ஆக இந்த கேள்வி கேட்டு அதன் மூலம் பதிலையும் பெற்று உங்களுடைய ஐயங்களுக்கு அது ஒரு பதில் கிடைத்தது, ஒரு சந்தேகம் தீர்த்து கொள்ளுகிற அந்த வாய்ப்பும் இந்த மாநாட்டில் கிடைத்திருக்கிறது. ஆனால் ஒன்று என்னன்னா, இன்னைக்கு நான் வந்து உட்கார்ந்ததுக்கு அப்புறம் எல்லாம் ஹெச்ஓடிஸாக பேசினாங்க. செக்ரட்டரி பேசினாரு, NHM பேசினாங்க, அந்த பிடி பேசினாங்க, இவங்கெல்லாம் பேசினாங்க. அவங்கள மட்டும் நீங்கள் யாரும் கேள்வியே கேட்கல. அப்போ நானும் சொன்னேன் வந்தவங்க கையில், ஏன் உங்கள் கையில் நீங்கள் கேள்வி கேட்கணுன்னா நாளைக்கு திரும்பவும் அவங்க ஆஃபீஸில் போய் அவங்கள நீங்கள் பார்க்க வேண்டியது இருக்கும், அதனால அவங்கள கேள்வி கேட்கலையான்னு கேட்டேன். சிரிச்சுக்கினே நம்ம விஹெச்என்லாம் சொன்னாங்க, அதெல்லாம் இல்லை, நாங்கள் கேள்வி கேட்கறதுக்கு முன்னாடியே எங்கள் செக்ரட்டரிங்கெல்லாம் அதை பண்ணி கொடுத்துட்றாங்க, அதனால நாங்கள் அவங்கள கேள்வி கேட்கலன்னு சொன்னாங்க. இந்த நம்பிக்கையும் இந்த மகிழ்ச்சியும் தொடர்ந்து நீடிக்க என்னுடைய வாழ்த்துக்களை தெரிவித்து விடைபெறுகிறேன். நன்றி, வணக்கம்.
கூடுதல் இயக்குனர் பொது சுகாதாரம் மருத்துவர் சோமசுந்தரம் அவர்கள் நன்றி தெரிவிப்பார்கள்.
இங்கு இந்த மாநாட்டில் நிறைவு விழாவின் சிறப்பு பேருரையாற்றிய மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்களே, இயக்குனர் அவர்களே, கூடுதல் இயக்குனர்கள், இணை இயக்குனர்கள், துணை இயக்குனர்கள், ஹெல்த் ஆஃபீஸர்ஸ், எம்ஓஸ், விஹெச்என், ஹெச்ஐ, பிஎம்ஓஏ, மெடிக்கல் ஆஃபீஸர்ஸ், விட்டிருந்தாலும் தப்பாக நினச்சிக்காதீங்க. அனைவருக்கும் வணக்கம். இந்த மாநாட்டுக்கு ஜிஓ வந்து நம்ம கேட்கும்போது 5 நாள் கொடுத்துருந்தாங்க, ஆனால் இப்போ 4 நாள் தான் நடத்தியிருக்கோம் சார். தயவு செய்து ஒரு நாள் நன்றி உரைக்காக தனியாக ஒரு மாநாடு நடத்தணும் சார். ஏன்னா எல்லாத்துக்கும் நான் சொல்கிறதுக்கு டைம் இல்லை. அதனால் சார் வந்து ஏதாவது நாங்கள் ஒர்க் ஷாப் மாதிரி ஒன்று அரேஞ்ச் பண்ணுறோம் சார். அன்றைக்கி ஒரு 1 hour வந்து சார் வந்து சிறப்புரை ஆற்றி எல்லாருக்கும் பரிசளிக்க வேண்டிய ஒரு ரெக்வெஸ்ட்டை நாங்கள் வச்சுக்கிறோம் சார். இந்த ப்ராஷர் போடும் பொழுதும் இந்த லோகோ அப்புறம் வெப்சைட் ப்ராஷர் போடும் பொழுது அதுக்கு நாங்கள் வந்து சேர்மன் வந்து நம்மளுடைய டிபிஹெச், ஓஎஸ்டி இருவரும் வந்து வைஸ் சேர்மனாக இருந்து மற்ற எல்லோரும் உங்கள் எல்லாத்துக்குமே தெரியும், கமிட்டிஸில் எல்லாருடைய மெம்பர்ஸ் எல்லாத்தையும் போட்டிருந்தோம். இந்த லோகோ வெப்சைட் ஸ்டார்ட் பண்ணுற அன்னைக்கு மினிஸ்டர் சார் சொன்னாங்க, இந்த மாநாடை சிறப்பாக நடத்தி தர வேண்டியது ஏன் பொறுப்பு, நான் பல்வேறு மாநாடுகளுக்கு போயிருக்கிறேன் அப்படின்னு சொல்லி கிட்டத்தட்ட ஒரு 4-5 மாதத்துக்கு முன்னால் நம்ம ஹோட்டலில் வச்சு சொன்னாங்க. சொன்னதுக்கப்புறம் டிபிஹெச் வந்து என்கிட்ட சொன்னார், பார்த்துக்கோ மினிஸ்டர் சொல்லிட்டாரு, அதுக்கப்புறம் உன் பொறுப்பு தான் அப்படின்னு சொன்னார். அதுக்கடுத்தது நம்ம கமிட்டிஸ்லாம் போட்டோம். ஓஎஸ்டி சார் டாக்டர் வடிவேலன் அண்ட் ஓஎஸ்டி மேடம் சித்ரா மேடம் தலைமையில் எக்ஸிக்யூட்டிவ் செக்ரட்டரி டாக்டர் சேகர் அப்படின்னு எல்லாருடைய கமிட்டிஸ் போட்டோம். நான் டைம் கருதி வேகமாக 2-3 பாயிண்ட் சொல்லிடுறேன். டாக்டர் தேவா பார்த்தசாரதி அனுராதா மேடம், கொஞ்சம் கை தூக்கி மட்டும் நீங்கள் வந்து இது பண்ணால் போதும். எனக்கு இல்லை, சாருக்கு எல்லாத்துக்கும். ஏன்னா அவங்க இல்லைன்னா இந்த ஹோட்டலில் நடத்த முடியாது, இந்த உணவை நம்ம கொண்டு கழிக்க முடியாது. அடுத்தது டாக்டர் நிர்மல்சன் அண்ட் டீம். அந்த டீம்னு சொல்லும்போது தயவு செஞ்சு எல்லாரும் வந்து அதை ஏற்றுக்கொள்ளுங்கள், தனியாக சொல்ல டைம் இல்லை. அவங்க வந்து கல்ச்சரல் ஆக்டிவிட்டீஸ் பண்ணாங்க. நேற்று வரைக்கும் இந்த டிஜே பீச்சில் நம்ம களியாட்டம் எல்லாம் பண்ணதெல்லாம் அவங்களுக்கு எல்லாம் ஞாபகம் இருக்கும். அடுத்தது பவானி உமாதேவி அண்ட் டீம். அப்புறம் சதீஷ் ராகவன், இந்த மாநாட்டுக்கு வந்து எம்ஜிஆர் யூனிவர்சிட்டி, டிஎன்எம்எஸ்சி நர்சிங் கிரெடிட் பாயிண்ட்ஸ் வாங்கி கொடுத்தது சதீஷ் ராகவன் அண்ட் டீம். அடுத்தது ஒரு 2 மாதத்துக்கு முன்னால் டார்ச் ரேலியை ஆரம்பித்து திரும்ப நம்ம எல்லா மாவட்டங்களுக்கும் சுற்றி வந்து திரும்பியும் சென்னை வந்து ரீச் பண்ணதுக்கு டிடி ஹெச்விபி நாகராஜன் அண்ட் டீம் அவங்களுக்கு கொடுக்கணும். அதுக்கு அடுத்தது முக்கியமாக பணம் தேவை. அதுக்காக வந்து ஜாயின்ட் டைரக்டர் சண்முக சுந்தரம் அண்ட் டீம் பரணி, ராஜா முகமது. அடுத்தது டாக்டர் விகே பழனி, பிரியாராஜ், பரணி, செந்தில்குமார், ஜவஹர். இவங்க 4 பேரும் சுற்று வட்டாரத்தில் இருக்கக்கூடிய டிடிஸு. அவங்க வந்து எங்களுக்கு வந்து எல்லா விதமான ஹெல்ப்பும் பண்ணாங்க. அதுக்கடுத்தது வந்து டாக்டர் சித்ரசேனா. இருக்கிறதுலே கஷ்டமானது என்னென்னா அந்த வெளியில் இந்த ரெஜிஸ்ட்ரேஷன் பண்ணுறது. ஏன்னா பேகை எனக்கு கூட, கீச்சைனை கூட, கொடையை கூட, அதை கூடன்னு சண்டை இன்னும் நடந்துகிட்ருக்கு. சண்டை இன்னும் ஒரு 10 நாளைக்கு சண்டை நடக்கும். அது பஞ்சாயத்து நிறைய இருக்குது. தேங்க்யூ மேடம். அடுத்தது வந்து டாக்டர் வித்யா அண்ட் வினய். இந்த ஸ்டேஜில் எல்லாரும் வந்து இப்போது கான்ரபிள் ஹெல்த் மினிஸ்டர் வந்து இந்த நம்பர் கணக்கு சொன்னாங்க. இத்தனை பேர் பேசுனாங்க, இத்தனை பேர் கேள்வி கேட்டாங்க, இத்தனை பேர் வந்து ப்ரெசன்டேஷன் பண்ணாங்க, இத்தனை செஷன் நடந்ததுக்கு. அதுக்கு வந்து முழு காரணம் ஒன்று ஜெரால்டு ஆரம்பித்து வச்சாங்க, டாக்டர் ஜெரால்டு சார். அதுக்கடுத்து டாக்டர் வினய் அண்ட் வித்யா பின்னால் இருக்காங்க. வழக்கம் போல் ஸ்க்ரீனுக்கு பின்னால் இருந்தே எல்லாம் இயக்கிட்டு இருந்தாங்க. அவங்களுக்கு நன்றி. அது மாதிரி இந்த மாநாட்டுக்கு எகைன் பணம் வேணும். அதுக்கு ஸ்பான்சர்ஷிப் பிடிக்கிறதுக்கு டாக்டர் சேகர் சார், சம்பத், ஓஎஸ்டி சார் எல்லோரும் பண்ணாங்க. அடுத்தது வந்து இந்த விழாவில் இங்கே நடக்கக்கூடிய மாநாடு மட்டும் இல்லை, 5 பேரலல் செஷன் நடந்துகிட்ருக்கு. அதுக்கு வந்து டாக்டர் சீனிவாசன், ஸ்டான்லி மெடிக்கல் காலேஜ், அண்டு டாக்டர் விஜயலக்ஷ்மி ஜேடி பின்னால் இருக்காங்க சார். அதுக்கு அடுத்தது டாக்டர் சுதர்ஷினி, டாக்டர் அரவிந்த், டாக்டர் வெங்கட்ராமன், டாக்டர் சுதாகர் அண்ட் டீம், இனியன், பன்னீர்செல்வம், இஜாஸ் அகமட், அரவிந்த் ராஜ், சக்திவேல், பிரதீப், விஜய் சூரஜ், ரிஸ்வான், கோபி, பிரதீப் ராஜ், ஜோயல் பிரபு, திவ்யலக்ஷ்மி, பாலாஜி, அபிநயா, பிரியங்கா, பவித்ரா, காருண்யா, தரணி, சரத். இந்த லோகோ வந்து வெப்சைட்டினுடைய ஃபஸ்ட்டு பேஜை வந்து நமக்கு டிசைன் பண்ணி கொடுத்தவர் வந்து டாக்டர் சரத்னு ஒரு டாக்டர் சார். அவர் 3 தடவை பிஜி கொடுத்து எய்ம்ஸு, ஜிப்மர், பிஜிஐ இது சண்டிகர் எல்லாம் கிடைச்சும் வேண்டான்னு சொல்லிட்டு கடைசியில் நம்முடைய சென்னை மருத்துவக் கல்லூரியில் ரேடியாலஜி டிபார்ட்மெண்ட்டில் ஜாயின் பண்ணியிருக்கார் சார். அவர் இப்போ இல்லை, ஆனால் அவருக்கு நம்ம நன்றி சொல்ல வேண்டிய கடமை சார். அடுத்தது டாக்டர் தமிழமுதன், அப்துல், பிரியவர்ஷினி, சாய் பவானி, சவுந்தர், தீபலக்ஷ்மி, மனோஜ் பிரபா, அரவிந்த் சாமி, அனந்தகிருஷ்ணன் சார் அந்த புக்கு ரிலீஸ் பண்ணதுக்கு உதவியாக இருந்தவங்க, டாக்டர் மிஸ்டர் வந்தியத்தேவன், ராஜா முகமது, பிரசாத் அண்ட் டீம், ஸ்ரீமந்தா, விஸ்வா, சிலம்பரசன், ரஞ்சித், ஆனந்த், ஸ்டாலின், சரவணன் அண்ட் டீம். இன்னும் 2 பேர் இருக்கிறாங்க, சுதர்ஷன், தாமோதரன், பன்னீர்செல்வம், இனியன், அஜாஸ் அகமட், கிறிஸ்டோஃபர் ஹச்சை, டேவிட் ஹச்சை, அறிவுச்செல்வம் ஹச்சை, பியூலா, மெர்சி, ரேகா, ஜெயந்தி, மகேஸ்வரி, டிஎம்சிஹெச்ஓ, யோகநாதன், சங்கர், ஏடி, அப்புறம் ஜேடி, எஸ்பிஹெச்ஐ அண்ட் டீம். அந்த 3 பேர் விஜயலக்ஷ்மி, தாக்ஷாயினி, சுமதி, ஷண்முகம், சீனு, பார்த்திபன், செந்தில், பழனி, யாழினி, நஜ்முதீன், பரணி, அருண், டேவிட், ஓஎஸ்டி மேடம், அடிஷ்னல் ஜேடி, டிடிஸ், ஹெச்ஓஸ், எம்ஓஸ், அட்மின் ஸ்டாஃப், டிரைவர்ஸ், ஓஎஸ், ஹெல்பர்ஸ், WHO, யூனிசெஃப், சிடிசி, யூஎன்டிபி, வேர்ல்டு பேங்க், ஜேஎஸ்ஐ, ஐஓபி, மற்ற எல்லா மெடிக்கல் காலேஜஸ் ஸ்பான்சர் பண்ணவங்க, ஸ்டால்ஸ் ஸ்பான்சர் பண்ணவங்க. எகெயின் ஐ வாண்ட் டு டெல், அந்த புக்ஸ் எல்லாம் வந்து டைப் அடித்து கடைசி நேரத்தில் வந்து பிரிண்ட் கொடுத்த பிரிண்டர்ஸ், சயின்டிஃபிக் அப்ட்ராக்ட் ப்ரெசென்ட் பண்ணவங்க, போஸ்டர்ஸ் அப்ட்ராக்ட் ப்ரெசென்ட் பண்ணவங்க, எல்லா டாக்டர்ஸ், விஹெச்என், ஆல் கேட்டகரிஸ், ஹச்ஐ குவிஸில் பார்ட்டிசிபேட் பண்ணி இப்போ 4 கேட்டகரி சடனாக நேற்று தான் டிபிஹெச்சில் கேட்டேன் சார், ஒரு 10,000 ரூபா கேஷ் ப்ரைஸ் கொடுத்துலான்ட்டு. ஓகேன்ட்டாங்க. 5,000 ஃபஸ்ட் ப்ரைஸு, 3,000 செகண்ட் ப்ரைஸ், 2,000 தேர்ட் ப்ரைஸ்னு அதுவும் கொடுத்துட்டோம். எல்லா கேட்டகரிஸ்க்கும் குவிஸ் ப்ரோக்ராம் நடத்தின ஃபஸ்ட்டு மாநாடு இதாக தான் இருக்கும் அப்படிங்கிறது. அடுத்தது இந்த ஹோட்டல், மீடியா, போலீஸ், சந்தோஷ் அண்ட் டீம். அடுத்தது வந்து இந்த ராஜு அண்ட் டீம் சர்டிஃபிகேட்ஸ் எல்லாம் அரேஞ்ச் பண்ணி கொடுத்தவங்க. ஆல் டிடிஸ் டெபியூட் பண்ணிங்க, டாக்டர்ஸ் டெபியூட் பண்ணிங்க, ஹெச்ஐ டெபியூட் பண்ணிங்க, எம்சிஹெச்ஓஸ் டெபியூட் பண்ணிங்க, ட்ரைனிங் ஸ்கூல் பிரின்சிபல்ஸ். அப்புறம் இந்த வென்யூவில் இந்த ஸ்டேஜில் உட்காந்துருக்குறோம், இந்த கார்பெட் பார்க்குறோம், சேர்ஸ் பார்க்குறோம், வெளியில் ஸ்டால் எல்லாமே அரேஞ்ச் பண்ண, உள்ளே வெளியே அப்படின்னு நாங்கள் கிண்டலாக பேசிக்குவோம். ஏன் அப்படின்னா உள்ளே வந்து கிருஷ்ணராஜ், வெளியில் வந்து சம்பத், அவங்க 2 பேரும் இங்கே தான் உட்காந்துருக்குறாங்க. அடுத்தது இப்போ எல்லாம் முடிச்சுட்டு ஆஃபீஸுக்கு போனால் டியூட்டி சர்டிஃபிகேட் கொடுக்கணும். அதுக்கு ஒரு ஜேடி போட்டிருக்கோம், சுரேஷ்ன்ட்டு. யாராவது தப்பாக கொடுத்தாலும் அவர் தான் பொறுப்பு, கரெக்டாக கொடுத்தாலும் அவர் தான் பெருமை, அந்த மாதிரி இருக்கும். அதுக்கு அடுத்தது வந்து டாக்டர் சேரன், இந்த சித்திரசேனாவுக்கு அவர் தான் கைட் பண்ணிகிட்டு இருந்தார், அடிஷ்னல் டைரக்டர். ஸோ இது இன்னும் சொல்கிறதுக்கு ஒரு நாள் கேட்டிருக்கேன் சார்கிட்ட, நன்றி சொல்கிறதுக்கு. அதுக்கு அடுத்தது வந்து எம்ஓஸ், ஃபார்மசிஸ்ட், ஏஎன்எம், எல்டி, அப்புறம் வந்து டிஎம்சிஹெச்ஓஸ் சிலர் பேப்பர் ப்ரெசென்ட் பண்ணாங்க. அதுக்கு இவ்வளோ பேர் இருக்கிறாங்க. இன்னும் சொல்கிறதுக்கு நான் எதாவது மறந்துருந்தால் எனக்குடைய வருத்தத்தை தெரிவித்துக் கொள்கிறேன். இந்த டிபிஹெச்சில் வந்து பிரியாராஜ் அக்காமடேஷன் அண்ட் டிரான்ஸ்போர்ட் எப்படி பண்ணோன்னு நினச்சிட்டு இருந்தோம். காஞ்சிபுரம் டிடி. அதுக்கு அடுத்தது வந்து பிரவீன், டாக்டர் பிரவீன் அந்த கிருஷ்ணராஜுக்கு ஹெல்ப் பண்ணிட்டு இருந்தவர். அனைவருக்கும் நன்றி, அனைவருக்கும் என்னுடைய வாழ்த்துக்கள். இது ஒரு வார்த்தையில் சொல்ல முடியாது. டிபிஹெச்சில் 5வது மாடியில் இந்த கான்ஃபரன்ஸ் செக்ரட்டரியேட்டில் யாராவது பேர் விட்டுருந்தாலோ இல்லைன்னா அப்படி தவறி போய் நான் மறந்துருந்தாலும் உங்களுக்கு ஃபோன் பண்ணி நன்றி சொல்லிடுறேன். இன்னொரு வாய்ப்பு கிடைக்கும் போது அனைவருக்கும் நன்றி சொல்கிறேன்.
நிகழ்ச்சியின் இறுதியாக நாட்டுப்பண்.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलति तरंगा तव शुभ नामे जाहे तव शुभ आशीष माहे गाये दव जय गादा जनहन मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे